Dear friends, it's my great pleasure and honor to invite Professor Alok Kanungo to kindly give a very brief welcome address. Alok? Alok, am I audible?
Yes. Welcome, Professor Ashok Das, Professor my Guru, Professor K.C. Samal, Professor Niranjan Tripathi, Professor P.K. Misra, Dr. Anup Misra, Dr. Vijay Kumar Misra, and my whole team, Saurav and Mamta, Dr. Bharat Panigrahi, and everybody. I welcome you to the 11th Nucd. I still remember one fine morning when I called Dr. Niranjan Tripathi, sir, I am thinking to start a national update on clinical diabetes. Now, this will be a very good idea. Nobody is doing clinical diabetes. And from that onwards, year onwards, with the blessings of Professor Samal, I started this program, and my biggest mentor became Professor Ashok Das. He has stood by me from the day one, and the planning of whole scientific program and organizing everything has been his brainchild. And Saurav has become a very important aspect in our life for last 4 years by giving it a new shape, new design in the webinar form, in the virtual form, and which is much better than the actual physical form. So I welcome all of you over these 11 years of NUCD. We have taken a long journey, and in that journey, we have seen people across the world have participated, from OK Landmark to anybody who is matters. And this year, Dr. Ramji Naik, who is a pioneer in type 1 diabetes research and prevention work, is also giving a talk. Professor B.N. Das from London is delivering a lecture on diabetic retinopathy and prevention in the society. And who's who in India are all participating in this niche clinical program, where we focus on discussing only clinical problems faced by our day-to-day clinical practice and practitioners. So I have nothing more to say. This session also will continue. I request Professor Ashok Das to give an introduction to the program and take it forward.
Thank you, Alok. It's my great pleasure and honor to place at the feet of my teachers, Professor K.C. Samal, Professor Niranjan Tripathi, and all the other teachers, seniors, Vijay Mishra, and all my sincere pranam, Prashant. And to everybody, there are over 2,000 people who have joined this webinar just now. I welcome all of them. Dear friends, I'll be very brief. You know, this year's national update on clinical diabetes is woven around 10 sessions. Now, as you heard, Saurabh had given a new direction, and as per it, we have from the last year a new format. We have talks, we have the interviews with one of the prominent persons in that field. We have, following that, a great panel discussion lasting for about 45 minutes, and of course, question answer session. So the format of each of these 10 sessions that we have today are centered around that. I would only request the speakers to kindly stick to the time. Of course, very humbly and with my sincere namaskar, I tell them to please stick to the time. There will be one bell just for 2 minutes by the ceremony chief, Mrs. Tuti, and in next 2 minutes there'll be another bell. Now, I would also mention that this year's NUCD is centered around most clinical and practical aspects. We'll be having the opening remarks and the inauguration by Professor K.C. Samal and Dr. Naik, Dr. Tripathi. Following that, we have the Padam Shri Vinod Kanungo oration, which will be given by Professor Abdul Hamid Zargar from Kashmir. He has already joined. We have the sessions 1 to 10 centered around obesity and diabetes, with people like Dr. Krishna Sesadri, Nitin Kapoor, Anup Mishra, and Sandeep Mathur, Nita Deshpande. and various other people, Dr. Bharat Panigrai and all. The second session is Ruben round, complications of diabetes. We have two sessions. So we have first session by PK Sahu, the famous cardiologist, Manisha from Hyderabad, the upcoming and very famous nephrologist from in the country. We have PK Sahu, Manisha Sahai, Pratap Pani joining for the panel discussion along with me and others. The third session is very important. Are going to be the modern therapeutic approaches, and that will be centered around context setting, early insulin initiation and intensification, insulin aspart, the advancing metabolic care with the fixed drug combinations like SGLT2, DPP4, and metformin, and why glucocentricity still matters by Professor Sharma from Jaipur. The fourth session, and there'll be a small talk on pioglitazone, and then we have panel discussion. Then the fourth session is type 1 and diabetes in the young. Will be done by Jayant Ramachandra Naik from United States, Bansi Sabu. There'll be Archana Sarda. There'll be Ramachandra Ji Naik and others in this particular session. Session 5 is future of all anti-diabetic drugs. It is by Dr. Shivendra Barma, Bimal Sanmugam, Dr. Belinda Judge from the St. John's, and Dr. Jayashree Shah will be moderator for the panel discussion, which was Vijay Kannan and others. There'll be clinical pearls of diabetes, hypertension, and cardiorenal care with the next session by Dr. Devmalya Sanal from West Bengal, Calcutta. We have Dr. K.K. Behera Kishore, our own Kishore. We have Dr. Shumantok Bakchi speaking to us about hydrology in a new molecule. The session on the day 2 will start with insulin and GLP-1 arrays. The session 7 will be diabetic foot and neuropathy, and 8 will be basal insulins, and we'll have the 9th session on the complex diabetes. That's number 2 session on complications, and session 10 will be nutrition exercise. Dear friends, this is our very humble attempt to bring to you the latest in the field of clinical diabetes, and it is a type of knowledge exchange. And therefore, dear friends, it's my humble request to kindly concentrate on the proceedings, and we'll take it forward. And before I end, I must say you that the only thing that matters in life is the relentless advance in the topic you have chosen. There's a relentless advance in diabetes. Diabetes itself is a relentless disease, and when we share knowledge, we become richer. Thank you very much, and dear friends, with this, may I now invite the Professor Kirti Samal, Professor Niranjan Tripathi, Professor Vijay Mishra to kindly, and Prashant
Professor
to speak
P.K.
to us,
Misra.
and Dr. B.D. Shah and Dr. Mishra. Dear friends, may I now request Professor, my teacher, Professor K.C. Samal, my mentor, to speak few words, sir.
Stuti, the lamp lighting and the
Yeah.
Saraswati Bandhana should start.
To this, start the lamp lighting and this Saraswati Bandhana.
And then Professor Samal will talk.
Speak.
या कुन्देन्दुतुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा।
Jai Ma Mahasaraswati, Jai Lord Jagannath. And with this, I will now request Professor Samal to speak few words as we have inauguration, followed by Professor Tripathi, then Dr. Mishra, Vijay Mishra, Dr. D.B. Sahu, and others will speak, maybe a couple of minutes to 1 minute. Professor Samal, my teacher, my mentor, please, sir. Sir, you have to unmute, sir.
So please unmute yourself.
Hello.
Yes, sir. Is audible.
Thank you very much, Ashok and others. You are all stalwarts there. And I have been requested to inaugurate this session. And I am very pleased to be here. This is the 11th time we are meeting.
Thank you.
And diabetes is a big subject, just like a banyan tree. It has the roots, branches, sub-branches, and everything is growing fast all over the world. Now, there need to be updation in every aspect, not only in the clinical, the pathological, the types of diabetes, the management, everything. And those are different things. The present gesture is the how to escape from diabetes. Big subject is coming up, cure of diabetes. It's a big subject. Now for that, our knowledge in clinical diabetes will be updated so that we can treat them in a good manner. And for that, the patient cooperation is very essential. And other things like diabetes monitoring, the continuous glucose monitoring, the interstitial glucose monitoring, the other aspect, transplantation, like islet transplantation, pancreatic transplantation. These are new chapters which has added glamour to the subject of diabetes. Now, there are many aspects updates should be done, and especially in clinical diabetes, so that take-home message for everybody should be guideline for the treatment of diabetes in future. Treatment is diabetes gradually changing from previously diabetes was being treated simply by diet restrictions. Now diabetes has spread from everywhere, from tribals to the rich class people. Now, one thing that is not doing well, the survey of diabetes. Diabetes in different type of populations. Pregnant women, poverty-stricken people, tribal people, rich class people. These things are lacking. So there should be a updation in the incidence and prevalence of diabetes, which that is a very big aspect, the practical aspect, how to treat diabetes with new drugs, new insulin therapy, new mode of insulin therapy, and everything like that. With these words, I thank you all, and I hope with the big stalwarts will give a good clinical extravaganza for the improvement and the treatment of diabetes. I thank you all and pray God that all success will be done. Thank you.
Sir, thank you for the Ashirvachana, for the first DM who came back to Odisha and established the department. We vividly remember your classes, sir, in the seminar hall on the diabetes, on hirsutism, on PCOS. Sir, I remember your classes very vividly. And you established the diabetic clinic and the endocrine clinic and took it forward. Our pranams to you, sir. There are tons and volumes to write about you, speak about you, but I'll keep quiet because in the silence is the greatest respect from all of us. Dear friends, thank you, sir. May I now invite my teacher, Professor Niranjan Tripathi, a doyen of physicians and medicine teachers in our country, who has made a dent in the clinical care and teaching medicine to the students, postgraduates, to give his Ashirvachan. Professor Tripathi, sir.
Professor Ashok Das,
Thank you, sir.
dear Alok, Mamta, Saurabh, Professor Kitish Samat, Professor P.D. Sahu, Professor Vijay Mishra, all in the dais and who are in the inaugural table. Mamta sang Saraswati Vandana and I will sing for Lord Jagannatha and start the meeting with Vedic mantras. Then I cite like this. Anubhadra Kratava Sattu Vishwata Asatumang Sat Gamaya Tamasomang Jyotir Gamaya Mrityormang Amrutang Gamaya Om Shanti Om Shanti Antarikya Shanti Apa Shanti Vanaspadaya Shanti काम Shanti, Krodha Shanti, Shantireva Shanti. In this war, stripping the world, the Shanti mantra it still stands, and instead of spending in words, if you spend for the diabetic care, I will be away from the country. Then I will now recite for Lord Jagannath. You in the prayer mode, please sit in the prayer mode. Om Niladrau Shankha Madhye Satadala Kamale Ratna Singha Sanastang Sarbalankara Jutang Navagana Ruchirang Sanjutang Achagrajena Bhamaya Bhamabhage Rathacharan Juktang Brahma Sive Indravandhyang Vedanang Saramidang Swadana Paribhrutang Brahmadaru Smarami. Lord Jagannath, Odisha is the land of Lord Jagannath, and Odisha is growing under the guidance of Lord Jagannath. So we all pray to him for success of our conference, so that diabetes, India from diabetes major world center capital will be major diabetes treatment center. According to ICMR India study, this is a very landmark study in 2023 by one group. They studied this diabetes disease center is like as much about 10 crore population, 10.1 crore. But I think with this number, there are equally good number of hidden cases. So that will be about 20 crores. And what we are spending on diabetes, India's annual estimated diabetes treatment cost is likely to rise as high as 1.26 thousand crores in 2025. These are all Lancet collaborative study results. And it is estimated that 5% of the family expenditure, 5 to 25% of every family expenditure will be on the diabetes care. Again, India is growing, life is growing, lifespan is growing. But if one is afflicted with diabetes at the age of 30, his age will be reduced by 14 years. If it is 40, this will be by about 10 years. And if it is beyond 50 years, this will be reduced by 6 years. So diabetes is a hindrance, and this is a very, very important disabled disease which makes lifespan short. So for better lifespan and better health care and good health, diabetes should be taken care of so that we live longer. The disability adjusted life years, that is DALI, between 1990 to 2021 increased 262%. That means with the diabetes, disability adjustment has increased to 300%, say. So this is a very huge number which reduces the economic cost of the income of the person and becomes an economic burden for the country. Again, quality adjusted life years, QALY, for screening the population went from say 16 lakhs to 25 lakhs, which didn't bring any result because screening doesn't give any good result in India. So mitigating this economic impact, this diabetes, there is a term called now ASHA. ASHA means hope, but it is ASHA. A stands for awareness, S for access. Access, they have taken S from access, H for high quality, and A for affordable medicine. So all these things are being taken up by KIDS. KIDS was started in 2009 by Dr. Alok Kanungo, a very, very mission-oriented young doctor who started with a mission so that the diabetes patients will have ASHA, means they will be aware of diabetes. For that, he wrote books in Odia. They will have access to treatment. That's why he established KIDS, Kanungo Center of Diabetes. And for high quality and affordable medicine, it is not with him, but he has given high quality treatment with insulin pump in his institute. And affordable medicine should be now researched, and medicine tablets should cost below life of kids. When kids were suffering like anything, and Alok wanted to dwindle up the institution. He came like a ray of hope. And during last 4 years, he has changed everything in the kids, and kids from a now a economic crunch institute has become a economically surplus institute. And Alok, I must congratulate Alok, Mamta, Saurabh for bringing this greatest institute, one of the greatest institute, one of the greatest quality institute in India and the best in Eastern India. And we know Alok is son of Padma Shri Binod Kanungo. Padma Shri Binod Kanungo is a freedom fighter and read up to 9th class in those days. But he is the person who authored Odia Encyclopedia. So, but actually, you please clap for him because he is in the heaven. But Binod Kanungo was the person who was suffering from diabetes. Who motivated Alok to take up this? And Alok single-handedly in Odisha took up this cudgel and established Kids Diabetic Center against all odds, against financial constraint, and made it a very, very success story in 2025. Please give a good hand for Alok. And Odisha is a land of eminent diabetologists in the country since 1960. When I joined medical college in 1960, as a first-year student with a reverence, I take these 10 names in diabetology who have now signed and signing in India like stars. They are Professor Vibhuti Bhushan Tripathi, better known as BB Tripathi, father of figure in Indian diabetology. Professor N.C. Panda, his assistant. Professor B.C. Kaur, his assistant. And in 70s, Odia student, Professor R.J. Das, a student of my batch, who headed the PGI Chandigarh, had known for his excellent research in laboratory medicine. He was the person who made diabetes research very, very significant and published a lot of articles in journal of importance and eminence and made Odias proud. He has recently published his biography, which tells what he done in PGI Institute. Then Professor Kitesh Samal, the father of diabetology in Odisha, who established the diabetic clinic. Of course, diabetic clinic was established by Professor B.B. Tripathi, but that was not running good because of the crunch of the staff. And it made possible to have a good diabetic clinic by Professor K.C. Samal, who established endocrinology department as the father figure in Odia endocrinology. Then our students like Professor Prasanto Mishra, Professor Gaurang Naik, Professor A.K. Baliyar Sinha, Professor Siddharth Das, Professor Ashok Das, they have actually adorned diabetology in Odisha and India with Hilal. Here I take only earlier names, and there are now more than 500 diabetologists in Odisha who are treating Odia patients and also known all over India and the world because of their good research publications. At this age of mine, at the evening hours, I urge good quality, low-cost diabetes medicine and awareness should be mainstay of our approach in diabetes care, so that instead of India being diabetes disease capital, will be treated as diabetes care capital. Jai Hind.
Thank you, sir. Thank you very much.
Jai Hind.
Jai Hind. It is great lecture and it has brought a lot of glory. And thank you very much, sir. My sincere regards and pranams. Now we have got 2 items left. One is the felicitation starting from Dr. Prashant Mishra, then going to Dr. Vijay Mishra, then B.D. Sahu, and others. That will be about 1 minute each. I will be ending it with a bandana, another bandana by Mamta, and this is a bandana which will be welcoming. We call it in Oriya Abahan. Will be Abahaning the Ma Jagadamba for this conference. With this, may I request Prashant, my classmate, my very close friend, to speak a few words of felicitation. Prashant.
Well, namaskar to my teachers, Dr. Samal, Dr. Tripathi. My best wishes to my friends, including Ashok Das and Alok Kanungo. Now, it is a pleasure to be a part of this team. And I have seen Dr. Samal from my undergraduate days and also Dr. Tripathi from my undergraduate days at SCB. Now, at that time, Dr. Samal, after DM and technology at PGH Chandigarh, joined as a registrar. Then assistant professor of medicine at Burla, and then came to Kotak and is managing gastroenterology, managing diarrhea ward, it had infectious ward. And he was not looking after the diabetes clinic that was there established in the Department of Medicine. I was a PG student of Dr. Parida, and he was really a godly man, though there are difference of opinion. But to me, Professor Tripathi and Professor Parida, though they had difference in opinion, they are really superhumans. They are different themselves. They are unique in themselves. Now, once I told Dr. Parida, who is not there today, that well, Dr. Samal has completed his DM in endocrinology and he is looking after diarrhea ward. He said that the junior most assistant professor in medicine will look after the diarrhea ward. I said, with that, why not his knowledge in the Department of Endocrinology or the diabetes clinic be utilized? I had the courage as a PG student to say this to the head of the department. And then he took one day and passed the order that, in fact, he is to look after the diabetes clinic. Then I was, my thesis was in nephrology. I was interested in nephrology. But it was circumstantial that Dr. Samal left for London in 1979 for some fellowship. And then he handed over the charge of the unit to Dr. Misra. And then assistant professor of medicine. And then he handed over the entire 1 kg bulk of keys to me and then said, Prasanta, you will look after the clinic till Dr. Samal returns. And that made me to look after the diabetes clinic or endocrine clinic in the absence of Professor K.C. Samal. The day he left for London, the same day I had to look after the endocrine clinic. There was a lot of difficulties in the endocrine clinic, and then I started, because there were a lot of referrals, I had to read Jocelyn Diabetes to know more, to help more. And that stimulated me to do DM in endocrinology. I said, this is a discipline, but there's a lot of positive things to be done. If you treat well, the patient gives a fairly normal life. And today, with the best available medicines, whether injectables or orals, we can claim that though we can't cure diabetes, but we can give a fairly normal life, though with a normal quality of life. Being a student of Professor Parida, he said, well, this country, we don't have a lot of research facility. You should be a very good clinical clinician, very good clinical professor. And I took up his words that one should be a very good clinical professor in endocrinology. And that is how I claim myself as a professor of clinical endocrinology, but I don't have a lot of research in the subject because what research they do in the outside, you can't think of in this country. Now, Ashok, my classmate, my roommate, I have the pleasure and pride to say that he left us to go to Pondicherry and then headed the Department of Endocrinology and the whole Institute of Pondicherry and has gone up. Very nice, and I'm proud of him. And the effort that has been made by the team with Professor Samuel, myself, Dr. G. Nayak and Anuj, and we have all the times efforts to see that the Department of Endocrinology improves. And today we have, in fact, I during my tenure thought to have DM course in SCB, and that's we started the program there. And then, of course, 3 years after it was implemented, and then we have multiple centers with DM endocrinology, and we have now more than 5 dozen sub-endocrinologists in the state. And the only request to the clinicians who handle the patient of diabetes, whether DM endocrinology or MBBS or MD, whatever, they should have a total approach to the diabetes patient. It's not only glucose-centric, only controlling blood glucose, take the multiple areas to consideration and then treat the patient well so that you give a very normal life for decades to come. And I think that I'm trying till today, and it is my pleasure and privilege to be with Dr. Kanungo for all these years, and I wish his institute, his ideas, and all good success. Thank you all.
Prashant, thank you for this great word. Dear friends, we have 5 minutes left. And I will take the privilege of listening to Mumtaz Abahan. And following that, we have the oration whom Dr. Tripathi mentioned, Padam Shri Binod Kanungo oration by no less a person than Dr. Jargar from Kashmir. He has already joined. So let us listen to the Abahan first. My request to Professor Vijay Mishra, my senior, Professor B.D. Sahu, to kindly wait. We'll be having their words in little later. Let us listen to the Mumtaz Abahan to the mother for the conference. Stuti?
जुग करे जोर शिवा शिव जुग करे जोर शिवा शिव प्रभु नाम मंत्रैका भन्यो भाव प्रभु नाम मंत्रैका जगतारक सक जान भवानी के लाश में भोर भयो कैलाश 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 भोर भयो.
Thank you, Mamta, for this abahan to the mother to bless this great conference of Nucd. Thank you very much, dear friends. Professor Vijay Mishra will be with us in the sessions. BD Sahu, I do not know how long he will stay. Can I take 1 minute extra and request Professor BD Sahu to just say us for 1 minute his love and his greetings to us? Professor BD Sahu. Are you there, sir? Professor Sahu, with the eminent physician of the country and a
Please ask Professor Vijay Mishra to speak few lines because Mr. BD Sahu is not. Professor,
is Professor Jargar there? Professor Jargar? Professor Jargar?
Yes, I'm here.
Yes, yes, Professor Jargar, my dear friend. Dear friends, as you just now heard, Padam Shri Binod Kanungo was a doyen in Odisha. He was a Gandhian, a freedom fighter, went to jail to get the freedom for the country. He is the person who believed in democratizing knowledge. He believed in democracy should invade the knowledge domain. And that's why he founded the Odia Encyclopedia, Professor Jargar and the other people in the country, to speak about that how important it is to know encyclopedic knowledge. He has contributed a lot to the country's upliftment. He was apolitical and contributed his heart, soul, and mind for the country. And today, put your hands together to welcome Dr. Abdul Jargar, the eminent endocrinologist of the country, who will be giving this year's Professor Vinod Kanungo oration. He has chosen
I'll take 1 minute here. Professor Das,
Yes, yes, sir.
thank few persons, some organizations. Can I go to the previous slide, please?
Yes.
Yes. So some organizations, very few, who have relentlessly supported the academic event of Nucd for years together. And I should thank Farida ma'am and her team from USB, from Sanofi, Cyrus, and Dipankar and the whole team, from Vikrant Sotria and his team from Novo Nordics, Exeltis, Boehringer Ingelheim, Medley, and Dr. Kanungos Diabetes Center and Kids Hospital for supporting us in this maiden venture. No words will be enough to thank them, but I thank all the members of USB, Sanofi, Novo Nordisk, Exeltis, and Boehringer and Medley to support for their support. And thank you very much. Sorry to interrupt.
No, it's very important, because they are there, we are here. Dear friends, Professor Jargar is one of the earliest endocrinologists of the country. I have no audacity to introduce this year's orator. Suffice it to mention, he was in the Sere Kasper Institute where he joined. He became in the department. He went for his endocrine training to Delhi. He came back again to Sere Kasper Institute and established the department, a vibrant, research-oriented, clinically oriented, academically oriented department, and rose to the rank of the director, the professor at head and the director. And he was also secretary to government of J&K in the matters of health, full secretary. He was also the advisory board member, we call it governing body member of all the three big institutes, AIMS Delhi, PGI Chandigarh, and the SGPGI. There were only three institutes that time of Lucknow. And he made his contribution in the new education policy, new health policy is quite a bit. Dear friends, we are short of time. I will just request my very, very close friend, Professor Jargar, to deliver his oration. He's going to speak to us on diabetes in women. Dear friends, he says diabetes in women is different, it is deadly, it is difficult to manage, and often dismissed by the men folk. It is over to Professor Jargar for his oration. Thank you.
Dear friends and colleagues, I am humbled as well as honored to give this Padam Shri Binod Kanunga Memorial Lecture. And today, in the next 15-20 minutes, I'll be talking about diabetes in women, fundamentally what perception is about the peculiarities of diabetes in women. We know that women have not been getting their fair share of things in life for ages. But with the time, there has been a lot of upgradation of the women power. But still, there continue to be a lot of structural situations where women still are not getting what men are getting, and a lot of negativity associated with women's health. Now we know diabetes for a long time, we have been discussing it, what a huge public health problem it is. Now for a woman, it has more than one challenges in comparison to the man. How do you handle it during puberty? How do you handle it during young days? How do you handle it during pregnancy? How do you handle it in the post-pregnancy period? And in the elderly age, in the old age. So we need to have a relatively different and better understanding how to approach diabetes in a holistic way in women. This is a study that I published 2.5 decades back, where we showed that obesity has started appearing in the country. But what surprised me even at that time was that women were more obese than men. And then there was, a global group known as Non-Communicable Diseases Collaboration Group. This is a global group which is looking at the magnitude of non-communicable diseases as they have evolved globally over a period of time. And this particular study, which was published in Lancet, looked at the obesity globally. And what did it tell us in relation to our own country? If you see on your right side, in 1975, we had the 19th highest number of obese men in the country. Now today, we have the 5th highest number of obese men in the world, in our country. And if you look on your left side, this data shows that today in the whole world, if we look at, after China and United States, we have the 3rd highest number of obese women in the country. And this obesity comes at a cost. This paper that this group published in Lancet did tell us now that not only obesity is emerging, but obesity started emerging right from childhood, adolescence, and getting into the adulthood. And this paper, 3 years later, in a different population, showed the same trends, that obesity now coming up right from the childhood, early adulthood, and adolescence and young life. Now, in women, this early childhood or young peripubertal obesity has led to a huge phenomenon known as polycystic ovarian syndrome. And now we know different societies have today different magnitude of this polycystic ovarian syndrome, which basically is a surrogate marker for insulin resistance. And different studies have shown that 11 to 20% young females do have either radiological or biological or investigative suggestion of polycystic ovarian syndrome. And for a long time, people have known for decades that this polycystic ovarian syndrome is associated with insulin resistance, so the chances of development of diabetes are rather early. Because of this epidemic of obesity, the type 2 diabetes that used to occur at the age of 48 on an average in my younger days is progressively coming down and down. And the current data shows in our country, this is now happening at the mean age of 29.4 years. And this is the age where, the pregnancy and diabetes are interacting and having impact on each other. This is a paper on gestation diabetes that we published a couple of decades back. We showed that, yes, diabetes in pregnancy is becoming an issue. But if you look on your right side, the bottom line, later the marriage occurs, more the chances of gestation diabetes. Now, with the onset of time, now marriage is getting delayed for females, for educational purposes, for professional purposes, and diabetes happening early, type 2 diabetes. So two are coming together in a big way, and that's something different that we need to look at today. So, in summary, adolescent years measure biological and psychosocial changes. If diabetes occurs there, you have to handle the adolescent tumult as well. Reproductive years, growth, development, and pregnancy. You have to handle pregnancy also. Transitional years, menopause, psychosocial events, comorbidities, you have to take care of that also. And in older age, disability of the age and lack of social support now growing in older people, and poverty, women playing a second fiddle in the economic scenario of the whole thing. So those are the issues that need to be taken into cognizance. Now, if you look at this cartoon, very simple. You have a young, beautiful girl who gets married and has a baby. And during this conception, the lady puts on some weight, which is known as gestational weight gain. So by and large, once the delivery occurs, this additional weight gain should be lost. But the practical experience is that that does not happen. So every time an individual gets pregnant, this gestational weight gain puts another risk factor for potential non-communicable diseases. And here we are talking about diabetes in general. So in a country where multiple pregnancies aren't all that uncommon, this additional load of retaining, not losing, retaining, and the gestational weight becomes an additional factor that needs to be factored into the management. If you look at it today, hyperglycemia in pregnancy is a huge issue in young people, right from 20 to 34 years, even up to 20%, as I said. But the first time, you're looking at diabetes in pregnancy even after 4th and 5th decade, because now assisted reproductive techniques have made it possible to conceive till very late in life, and they have their own consequences, and this needs to be handled in a different fashion. Hampton data available from different parts of the world. Everybody says now gestation diabetes is increasing because of those factors that I alluded to. Another aspect, for a long time, we thought that women, in comparison to men, are protected in their early age from coronary artery disease. Framingham Heart Study, Nurses Health Study did tell us that if a female develops diabetes in a younger age, that protective effect no longer is there. There's amazing information from IDF 2017. Globally, there are more deaths attributable to diabetes in women than men, probably not getting a fair share of the healthcare facilities. And this is the data that we published 2.5 decades back on mortality. And we found out, particularly in type 1 diabetes, hardly anybody makes it to the 4th decade. That was in 90s, 80s, and 90s. This is a paper that we published a decade later in Postgraduate Medical Journal, where we showed that, yes, the gap between a diabetic and non-diabetic population has decreased. The life expectancy is now better. There are quite few people with type 1 diabetes who live beyond 4th decade, who live beyond 5th decade. But this also is a fact. No female type 1 diabetic lived beyond 5th decade. It's only advantage to the boys. Average life expectancy of female type 1 diabetes was 27 years. So that tells us what this societal polarization of resources towards the male probably needs to change a bit and needs to be taken cognizance of. Societal and cultural barriers for management. Many times obesity is not considered negatively, it's taken as a sign of good health. So people have to be made aware of it. No value given to physical activity, particularly for females. Very rigid social and cultural norms. Even at this age, when I tell some lady, you need to move around a bit, says, as a doctor, it doesn't look good for a female. I'm so like, this rigid social stance needs to change a bit, and we need to contribute a bit in telling people repeatedly that for good health, it needs to be done. And diet is the key. The lady of the house changes the diet, sanitizes it, is better. From the metabolic point of view, probably the whole family would get benefited. Diabetic women have a psychosexual behavioral abnormalities. Men do talk about it, females do not. So it should be approached and talked about. And we need to get a better comprehension of that for our own society. Before I sign off, there's a beautiful paper that our group published in Nature half a decade back. This shows now diabetes has reached the state of saturation, and urban and some urban areas is now shifting to the rural areas. Now imagine this epidemic of diabetes shifting to Indian rural areas. And this is really going to complicate the issue of not only diabetes in general, but diabetes in women, because that is where maximum pregnancies do occur, where healthcare isn't as that optimal. Professionals are not available around the clock. So it's very essential, if you look at it in totality, that yes, the first thing I believe is that education is the key to the empowerment. The general education, what we are talking about, but education about diabetes. But also healthcare systems should consider custom designed prevention and control programs for women. Because, women are a little bit introvertish in our country, shy, not amenable to more interaction, and as I said, obesity not being taken negatively, physical activity not being taken up in a big way. So policies that empower adolescent girls, young women to take control of their own metabolic management should be encouraged. Nutritional education, including healthy cooking practices, should be taught to all women. Because all these metabolic diseases epidemic that is sweeping globally in general, but more importantly in our country. That's what we are responsible for. If we sanitize this, how we prepare our food, cooking practices at home, probably this epidemic might slow down a bit, hopefully. And the need for postpartum follow-up, I told you about the gestational weight gain, postpartum follow-up, the gynecologists, the physicians should insist that additional weight that has been acquired during the pregnancy should be shed. The importance of physical activity should be emphasized and facilities for the same provided to all women. During pregnancy, that excess weight should not be. Many times, think the more they eat, the more they put on weight, the baby would be better. And all those concepts that have emerged over decades and centuries in our society that progressively need to be replaced by scientific thoughts and beliefs. Thank you so much.
Professor Jargar, it was a great academic treat, and I congratulate you for a great lecture. I do not know, my words fail, and your citation and the medallion will be sent to you, or we'll give it to Diabetes India when we meet personally. Thank you, Professor Jargar. Thank you very much. Next session is in obesity and diabetes. It will be conducted by Dr. Jayant Panda, the other scientific chairman of the committee, and of course our very own Dr. Bharat Panigre, very eminent physician and diabetologist of our state. And we have in this session very eminent people. We have Krishna Sesadri, and we have Dr. Nitin Kapoor, and we have one important interview with a doyen in obesity in our country, Professor Dr. Padam Shri Anup Mishra, and we have a panel discussion. Without much ado, we must stick to time, Jan. I hand over the session to you to invite Krishna to give the talk.
Thank you, sir, for that introductory talk. It's a very grand beginning year after year. And today, after listening to the vibrant talk of Dr. Abdul Hamid Jaga, I invite you to the session 1, the obesity and the diabetes. Here we have, as usual, one panel discussion at the end, interview before that, and two very nice presentations by Dr. Krishna Seshadri and Dr. Nitin Kapoor. So I join Dr. Bharat Panigrahi to invite you all to this very interesting session for 1.5 hours on the obesity and diabetes. And the first session will be by Dr. Krishna Seshadri, and the topic will be interlinking of obesity and type 2 diabetes. This is for 15 minutes. Over to Dr. Seshadri. And all of you know Dr. Krishna Seshadri is a first-liner endocrinologist of the country. And not only that, tomorrow he is participating in Swami Vivekanand's both celebration all over the country as a youth day. And he has kept his spiritual ethos with him, and with all science, and one of the best endocrinologists of the globe. He has kept his contact, and when you meet him, you'll feel you are meeting a monk. Over to Krishna Sheshadri sir for the topic interlinking of obesity and type 2 diabetes.
Thank you, Jayant. Namaskar. It's wonderful to be here. Dr. Das called me probably late last night. Can I have sharing privileges, please? I don't have a sharing privilege.
Stuti, can sir share these slides?
Stuti, allow Professor Sheshadri to share the slides. Just
So you can share.
I don't see the icon once.
yeah.
Ma'am, I don't see the icon.
Sir, the sharing rights are with everybody.
Sir, say there will be a green icon at the base. Just that you have to select. There is a box written share. There is an arrow upwards.
It's not there.
Yeah.
Is it okay if I just return back? But I don't have it on my this thing. It says you're chatting as a guest, which means that that I don't have host privileges.
Sir, I have made you co-host. Please try again.
Just 1 second. I'm just going to re-log in.
Dear friends, I will now like in this time to introduce Professor Dr. Bharat Panigrahi. Jayant, please do the honor.
Yeah, our chairperson, Dr. Bharat Panigrahi is here. And before Dr. Sheshadri starts, I think we have some technical glitch. So my request, Dr. Panigrahi, to give an introduction to the topic.
Right, can you hear me?
Yeah.
You can start the talk right away. He's ready.
Sir, what I will do is I just send the slides to somebody.
Yes.
Yeah.
Stuti, can I send
Yes, sir.
the person who sent me the link, right? I'm sending them, but I'll start talking so that you don't waste time.
Yes,
Sure,
you
sir.
send it to us, you will project it. Mr. Stuti, without loss of any time, please.
You give your
Yes, sir. Once he send, I'll download and I'll share the screen.
Yeah, give your mail ID in the chat box.
No, I'm just sending it to her on WhatsApp right away.
WhatsApp, because the link came from her, na, Jan.
Yeah.
Krishna has the.
Okay, I'm going to start talking because I don't want to waste time of everyone. Let's talk about the adipocyte. I'm not a big fan of the word obesity anymore. I think we need to start thinking about adipocyte dysfunction as the link for diabetes, right? I think that is a very important way to think about it. In 1997, the Nurses' Health Study showed for the first time that there was a direct relationship for the risk of diabetes with the waist circumference, correct? So first, let's understand what is the metabolic function of the adipocyte. The adipocyte is something that takes up VLDL particles into it, correct? And then traffics it, and stores it, right? Glucagon, cortisol, adrenaline, inflammatory cytokines all cause lipolysis, meaning take the adipocyte back into the circulation. Whereas there are others that, especially this thing that prevent lipolysis. What we know is that there are two things that are happening. As the size of the adipocyte increases, its relation to diabetes also increases. This is something that we have learned over a period of time. The size of the adipocyte is directly proportional to the risk of diabetes. What is happening is the adipocyte is a very, very dynamic organ. At its leanest, it has all the things that I talked about. Its mitochondria works well. Wheat oxidation takes place. The tricyclic cycle happens fairly well, right? On the other hand, as it starts expanding, things change, correct? And there is a point of time when its size increases to a certain extent, it causes complications. Obesity, the fat cell is not an inert cell as we think. Oh, okay. Can you move to the next slide, please? I think the slides have come. Can you hear me? Shruti, you have to move the slide. Dr. Das, can you hear me?
Sir, I did. I guess your network is fluctuating. I'm on the graph.
Hello?
Hello, can you hear me, sir?
Yeah.
Are you listening to me? Krishna, am I audible?
Yeah.
Now you are audible, sir. Stuti is not moving the slides.
Shruti, please move the slides.
Sir, I'm moving the slides. I'm on the graph. Can you see the graph?
Yeah, this year all talked about Nurses' Health Study. He has covered it. Next slide.
Go to the next one, please. I can't see it, but go to the next slide.
Next slide. It's on the metabolic function of the adipocyte.
So can I tell you something? Go to slide number 9, and then we will go from there.
Go to next slide.
Go to slide number 9, please.
Next is the high-fat diet followed by adipocyte volume and cytokine is this one. Next.
Then fat expand. Next slide, please.
Next slide is the fat expansion. Correct. It starts.
Next slide.
Next slide.
So fat expansion is a normal phenomenon, right? That there is a healthy expansion and there is an unhealthy expansion. When it expands in a healthy fashion, it causes adipogenesis. It decreases the cell volume. There's an increase in insulin sensitivity. This is the normal phenomenon. But when there's an unhealthy expansion, there is mitochondria, there is a cytokine invasion, macrophages are produced, there is cell hypertrophy, there is low-grade inflammation and infiltration. Next slide. If you see this, there was a time people would call that the obesity, where there's some amount of tissue hyperplasia, normal angiogenesis, small insulin-sensitive adipocytes. On the other hand, when there's increased hypoxia, apoptosis, adipocyte stress, they would call it metabolically unhealthy tissue. Next slide, please. And if you can see the CT scan that shows this, that 10 to 20% is metabolically healthy, 80 to 90% unhealthy. But if you go to the next slide, there's a bar graph there. If you see the next slide, you'll realize that
Next slide, Stuti.
That slide number 12, that even in the metabolically healthy obesity, there are still cardiovascular risks, cerebrovascular risk, heart failure risk, and all the others. So the important thing is there is really no healthy fat expansion. Second is this next slide. The metabolically healthy and the metabolically unhealthy are interchangeable. You can go from healthy versus unhealthy, right? Next slide. Please go to slide 15. If you see in the lean adipose tissue, right, there are eosinophils, there are interleukins, but they're really not causing problems. But the moment the adipocyte expands too much, signals are sent. Next slide. Signals are sent that invade the intra-abdominal tissue. When they invade the intra-abdominal tissue, there is. Next slide. We can go to slide 19. I'm not going to go into too much. Go to slide 21, please. When there is increased intra-abdominal tissue expansion, at some point of time, what really happens is it becomes pro-inflammatory. What do you mean by pro-inflammatory? There are changes that are occurring inside the adipocyte tissue itself that send a signal to the bone marrow, and from there, inflammatory cells come in. Normally, these cells that come in, they come in because they want to help. They are sensing something is going wrong, they want to come and help. But once they reach the milieu of the intra-abdominal tissue, they become pro-inflammatory. Why? Because there's a phenotypic shift of these T cells that are coming from the bone marrow from a helper cell to a killer cell. Next slide. Next slide. Can you go to slide number 22? This is exactly what I was talking about. That there is a pre-adipocyte, there's an overload of fuels, there's mitochondrial dysfunction, there's hypoxia, the adipocyte does not differentiate anymore. Adiponectin goes down, there is a change, phenotypic shift, and this continues. On top of that, and very interestingly, go to slide number 23, you will realize that one of the strangest things that occurs and interesting things that occurs is that inside the adipocyte itself, insulin is not able to act. Insulin is a stabilizer of the adipocyte. GIP is a stabilizer of the adipocyte. Inside the adipocyte, there's insulin resistance. I don't know if you're able to see my slide. It's on slide number 23. And when that happens, that insulin resistance occurs, how does it occur? By activation of the mTOR pathway. That's one of the reasons pioglitazone is something that's very important in diabetes management. People give it a shirt, but it's actually very important. These are fat cell stabilizers. Once the mTOR pathway is activated, then there is the signal that I told you that goes into the bone marrow and increases cytokines. Go to the next slide. And this is a context phenomenon, but what we need to understand is that the body knows how to react to threats, both internal and external, only by inflammation. I hope we are in the next slide, right? So, yes, this one. Normally, we have a gut pathogen, a microbiota that are inherited from our mothers, probably for 14 generations, that are protecting us because Dr. Das still eats a ODI diet at home, right? But if he stopped doing that and started eating, instead of Jagannath Prasad, if he eats Krishna Prasad in Chennai, it changes. The thing is that, let me take a side. There are two things your mom is given to protect you, only from the mother. One is your DNA, mitochondrial DNA. The mitochondrial DNA is maternally inherited. That is why we call it Shakti. Mitochondrial DNA is maternally inherited. The second thing that we inherit from our mother is the gut microbiota. Remember that even if you've had a C-section, there is a lacteal gut hypothesis that says that you still colonize your gut. These bacteria, they not only take care of complex carbohydrates, they protect you from infection. When they change, when the Firmicutes bacteroids ratio changes because of the food you eat, that sends inflammatory signals. So adipocyte hypertrophy, inflammation, and the gut microbial dysbiosis are important reasons for this is happening. Next slide. This slide, I put it because I've been using this for almost 13 years. I wanted all of you to see it. That sort of summarizes it. Adipocyte hypertrophy, macrophage infiltration, macrophage polarization, M1 to M2, and the Jugalbandi that starts. I don't want to get into the details of it, but let's go to slide number 31. It's a very interesting slide, and if you notice that it's from a very obscure journal, but it's 15 years old. Go to 31, please. What it shows is something very, very interesting. A few days of incubation I hope you're getting the table. A few days of incubation of macrophages with chemokines, and see what has happened. By day 8, the adiponectin is dropped by almost 40. The GLUT1 expression has already dropped. The GLUT4 expression has dropped. Can you see really what is happening in diabetes? This is what is happening. Next slide. This is just to show when you co-culture, the inflammatory markers increase. I'm going to ask you to move on. I've already talked about role of gut microbiota. I'm going to ask you to go on to slide number 43. I don't want to waste too much of your time. So this is like a big lecture, so I'm just cutting it short. I've talked about the gut microbiota. I've talked about all these parameters. I've talked about this slide. Go to the next slide. So I said that fat expands. Then as fat expands, inflammation occurs. As inflammation occurs, at some point of time, the fat cell undergoes apoptosis. The function of the fat cell is to protect the body from dissemination of fat, because ectopic fat is bad. The next stop of the ectopic fat is the liver. And you don't get diabetes without fat in the liver. That's why MASLD is very, very important. The next slide. The presence of fat in the liver causes insulin resistance, because the moment you have diacylglycerol in the liver, the insulin resistance increases. The same phenomenon is occurring around the pancreas. The fat goes around to the pancreas, and their peripancreatic fat is increased, and it causes diabetes. Go to the next slide. It tells you what happens in the liver. You see that there is a complete change in the liver function. And interestingly, if you go to the next slide, remember what happens when you lose weight. I keep talking about it everywhere. I'll tell you, yesterday also I spoke in CMC about the same thing, that 16% weight loss is 30% intra-abdominal fat loss, 66% intrahepatic triglyceride loss. Therefore, the primary treatment of diabetes needs to be to remove the fat from the liver. How do you do that? You lose weight. You do that, you lose diabetes. It's a little simplification on my part, but I want to drive home this place. The next slide shows that the BMI is inconsequential. Why do I say the BMI is inconsequential? Because we all have our individual fat threshold. If we cross that threshold, there's ectopicization of fat. When fat becomes ectopic, there's insulin resistance and there's diabetes. Next slide. So this is a summary slide, and it tells you how when your diabetes is actually adipocytes becoming sick. When adipocytes become sick, you have insulin resistance. When adipocytes become sick, you have insulin resistance in the heart and the muscle. You have leptin resistance, you have apoptosis, and you have diabetes. It's as simple as that. I won't go on to FOXO and my other favorite parts of this whole story. I wanted to give a very short talk. This talk was prepared actually for a much more longer oration, but I thought, if I'll give you this very, very simple way of thinking about obesity. If you create adipocyte dysfunction, you get diabetes. Therefore, the treatment of diabetes also needs to be to reverse adipocyte dysfunction. How do you do that? Eat less, eat on time. Don't stay awake too much in the night. Don't look at your cell phones all the time, right? Be aligned with nature, and you'll be fine. Dr. Das, I'm sorry about the slides not being able to load, but I hope that you and the audience have gotten what you wanted. Thank you so much.
Absolutely, Krishna, and I'm absolutely thankful to Krishna. I rang him up last night. Morning, I rang him up, and within 2 hours, you have given a lecture which is absolutely fulfilling. I have no other word to say. Original is a typical of Krishna. Okay. Speak about the things which are fundamental, basic, and build up the clinical. Thank you very, very much for joining us on this lecture. Thank you. Thank you.
Thank you.
Thank you, sir. It was really amazing that diabetes and obesity interlink could be so simplified. You told from the realistic pictures and the images that how loss of weight helps us getting rid of the diabetes, decreasing the fat load in the liver, and the subcutaneous and the visceral fat helps getting rid of the glycemic load as well. And then it shows a big research work, and sometimes we have to listen in detail to you what message we got. So it's a big presentation made very simple in 15 minutes, and I request Dr. Sheshadri to stay back for half an hour to be part of our panel discussion, which is starting at around 11:50. And we'll move on. Before that, I invite Dr. Bharat Paningrai sir. Dr. Bharat Paningrai, as you know, is the obesity man, and he started working in the field of obesity for last 2 decades, and he is the person who got the All India Association for Advancing Research in Obesity at Odisha, and hosted annual conferences for past so many years, even during the COVID. And he is chairing this session, and I request Dr. Paningrai to give his introductory context-setting presentation, and also introduce Dr. Nitin Kapoor. He is with us. Over to Dr. Bharat Paningrai, sir.
Thank you. Thank you, Professor Ponda. So friends, again, good morning to you all. So we have with us Dr. Seshadri, was very nicely described regarding the adipocyte and inflammation and insulin resistance. So basically at this diabetes and that is obesity and diabetes, this adiposopathy, that is what we call the adiposopathy, is responsible for this inflammation and insulin resistance. So inflammation is a very, very important part because this is both obesity and diabetes are low-grade inflammatory conditions. So how it occurs, Dr. Sadri has very nicely showed these slides. So one thing I just want to point out here, because whenever there is stretching and inflammation, there are these macrophages, the A1 and M2 macrophages, which he has also shown us. But in obesity, what happens? The M1 macrophage is the pro-inflammatory and M2 is the anti-inflammatory. So the reverse occurs in obesity when it occurs that gradually A1 goes up and up and M2 goes down. That's the what the inflammation becomes more and more. And all other slides he has shown very nicely. One thing just I would point out to the gut microbiota. Gut microbiota, yes, gut microbiota is a part of this process because in all autoimmune diseases, what we see that gut microbiota do take part. But one point I turn to the infancy or the newborn. You see, the newborn doesn't have the gut microbiota. The newborn carries what is the it is equivalent to the gut microbiota of the vagina. Whatever the gut microbiota in the vagina, that is equivalent to the gut microbiota of the newborn. But if somebody is having the cesarean section baby, in cesarean section baby, the gut microbiota is different. That is, it is equivalent to the skin of the mother. That is gut microbiota. So these are the differences between the newborn, but gradually, by the age of 3 years, the gut microbiota of the newborn, that is the age equivalent to the adult. By the age of, because the gut microbiota, the baby that acquires from the environment. So these are the gut microbiota that is the what is there in the, and that gut microbiota also is very important. We are reading gut microbiota in various autoimmune diseases for the last 4 decades, but still it is a, I think it is a subject of research and it's going on. So again, without wasting your time, I invite the next speaker, that is Dr. Nitin Kapoor. Yeah. So this is his biodata. Nitin is a very young endocrinologist from, I think, from Pune, and we have heard from him many lectures, and he is very voracious orator. So let us go to Nitin. Nitin, please start your talk.
A very good morning to one and all. Right at the onset, I'd like to thank the entire team at Nucd for having me here today for this particular talk. In the next 15 minutes or so, I shall take you through this topic on prevention and treatment of diabetes. And I thought to make it more clinically relevant, we'll take it as a case-based approach. Now, friends, I'm sure all of us would agree on the fact that obesity has reached pandemic proportions globally, and the prevalence just seems to be increasing through every age group. When you just look at data from Vellore, this is a study done in school children a couple of years ago. We looked at 300 children, 12 to 16 years. We found that 1 in 3 children going to school have obesity. Talking about adults, and again looking at our data from the Vellore birth cohort, we saw a rapid increase in the last phase in the prevalence of obesity. What was just 20 to 30% has increased to 50 to 70%. Even in the elderly, there is a significant proportion of people living with obesity, and this is data from a rural Vellore where we've looked at women, postmenopausal women, mean age of 61, and again, a large proportion of them have obesity. Looking at national statistics, again, this is data from NFHS4, 35 to 40% of people have obesity. But when we talk about National Family Health Survey 5, just 5 years after National Family Health Survey 4, whatever was in late 30s has become early 40s. The point that I'm driving at is that in our clinical practice, we will have more and more patients working with obesity. But today we are talking about diabetes. So let's look at the diabetes data. And one of the best studies to quote that from an Indian perspective would be the ICMR INDIAB study. And again, very clearly showing that about a quarter of our population has some kind of dysglycemia, a third of them have diabetes. So definitely all of us in our clinical practice would see more and more patients with diabetes, and it is our duty to make sure we take steps not only to treat, but also prevent this disease. So in today's session, we look at a case-based session. This patient actually presented to me in the multidisciplinary pediatric clinic at CMC Vellore. And we'll take you through the story and try and apply a 5A framework on management of diabetes as to how this patient can be managed. But when we look at the different guidelines for management of obesity, things have really changed over the years. What initially used to be predominantly a BMI-centric guideline today has become more complication-centric. The two major guidelines from an Indian perspective, both by the Endocrine Society of India and by the RSSDI, are very clearly spelled out as to how we have to manage obesity and diabetes in Indian patients. So let me take you through this 5A framework, which was initially proposed by the Canadian Obesity Network, and let us apply that to a case, a patient who presented to me. So the story of this patient is essentially a 17-year-old girl, a young girl who has presented with progressive history of weight gain. Now, all along as a child, she was considered as a cute, chubby child. There was nothing wrong that was looked at in terms of the weight or the fat in the initial years. However, as she attained her puberty, she developed irregular menstrual cycles, and all this cute fat suddenly became very ugly the moment she was diagnosed to have diabetes, and some physician outside had started her on insulin. So all this while she was cute and playful, but the moment there was a diagnosis of diabetes and some insulin injections came into the scene, the parents became extremely worried, and they started thinking, oh my God, how is she going to get married? And what's her future like? Very young age, the weight is so much of a problem all of a sudden. So let's try and apply this 5A framework to this patient. The first A of the 5A framework is to ask. So whenever you have a patient with diabetes and obesity in your OPD, I think for diabetes, most patients would accept whatever treatment you would ask, but for obesity, it is important to ask and find out whether your patient is happy to discuss about weight gain. Because believe me, if the patient is not willing, or if the patient is not very keen or motivated to lose weight, no matter you give a 1-hour didactic lecture in your clinic, this patient will not be able to apply all those principles in their life. Many times in practice, it is the sibling or the parent or the spouse that has brought the patient. And if the patient is not interested, I think what we can do is tell that there are options, there are benefits for the patient to lose weight. And when they think they are in a ready state of frame of mind to understand this, that's the time that we should act. At the same time, it's very, very important for us as physicians to not be very judgmental, not to have any preconceived notions. Today, the patient's weight may be 120, but she might be 140 6 months ago, and she's already done pretty well then. At the same time, we also have to reduce the stigma associated with obesity, make sure we have a very weight-friendly practice. We use the right terms. That's very important. We make sure we use scientific terms and not derogatory terms in terms of obesity, because weight stigma is not only associated with obesity, but it is a vicious cycle. So people with obesity are often stigmatized, but stigma itself leads on to habits. In this study from our center, where we looked at how stigma can also inculcate poor eating habits and therefore contribute to the obesity and therefore a vicious cycle. Well, coming back to our patient, the patient's parents are now extremely worried. So the patient is a very intelligent girl. She's motivated. She's concerned about her diabetes and insulin injections. Now she's in a stage about to go to college and obviously worried about her physical appearance. So that was the first A of the 5A framework. The next A of the 5A framework is to assess. And here we are trying to assess three things. We're trying to assess of obesity. We're trying to assess the comorbidities associated with obesity. We're also trying to assess what has caused obesity in this particular patient. When you look at the first part of the assessment in terms of obesity indicators, yes, definitely, several obesity indicators are available for use in clinical practice. BMI is indeed one of the most common ones. We have our own guidelines, the South Asia specific WHO guidelines, which classify BMI slightly differently as compared to the West. Our thresholds for developing metabolic problems is much lower as compared to the Western population. But yes, we know that beyond BMI, waist circumference is probably a better indicator measurement for fat or estimation of fat is even better. But where the literature is moving today is moving away from just looking at BMI and numbers, but looking at overall picture of the patient as well. I mean, looking at staging systems of obesity. The adventure obesity staging system is something that has been adopted very well for the Indian communities, especially also endorsed by the Endocrine Society of India. So what is this adventure obesity staging system? The staging system tells us how severe the obesity is, not based on BMI, but based on comorbidities. I may have a patient who's got maybe severe diabetes with retinopathy on dialysis. This is a complication of obesity. So this patient will have stage 4 obesity, even if the BMI is just 31. Whereas I may have another patient who's got BMI of 36, but just probably has prediabetes. And that time, that patient will be stage 1. Now, why is it important to stage patients with obesity? And this is very interesting data from the NAINS database, following up patients for 15 years, trying to see if we use BMI alone as an indicator, we are not able to predict the mortality of patients, but how clearly, with the help of adventure obesity staging system, we are able to tell if the stage is more than 2, you see a significant dip in this Kaplan-Meier curve. When we looked at our own data from the pediatric clinic in Vellore, we find that about 2/3 of our patients are actually belonging to stage 2 and stage 3. And today, the Endocrine Society of India guidelines clearly mentions management of obesity based on the EOS score. So friends, that was the first thing that we talked about. We talked about assessment of obesity in terms of the severity of obesity. The next thing is to assess the obesity in terms of comorbidities. And I think all of us do a very good job in assessing the metabolic problems of obesity, but there are beyond the metabolic issues as well, especially focusing on the psychological aspect, the mechanical aspect, and the psychological aspect in a patient with diabetes and obesity is really, really important. We talk of diabetes distress, and similarly, we have the psychological issues associated with obesity as well. About 1/3 of the population that we see in our clinic, in the obesity clinic, have a psychological problem. The third part of assessment is to try and assess why this patient has diabetes and obesity. And again, I think we try and understand. It could be either because of metabolic issues, an inherent problem as a genetic cause, or dietary practices, or limited physical activity. Some of the common causes are highlighted, but yes, definitely more and more understanding on this subject is becoming very useful. So while coming back to our patient, we see that the current BMI of our patient is 44.6 kilograms per meter square, clearly having severe obesity. Your staging is stage 2 because the patient already has an established complication, which is diabetes. So in conclusion, we find that yes, this is exogenous kind of obesity. There is diabetes and dyslipidemia, also PCOS that this patient probably has. Trying to find out the cause of obesity, we went through the dietary recall, and we see that the quantum of food intake, especially the carbohydrate intake, is far more than what should be. 4 to 5 idlis, 4 to 5 dosas for breakfast is definitely very high, and this is something that needs to be addressed. So this takes me to the third and the most important aspect of managing obesity with diabetes, that is giving proper advice. And the advice is definitely just not medicines. We talk of the overall discipline of the patient, right, from adequate sleep management to obesity and diabetes. Well, these could be broadly classified as those which are based on calorie restriction versus macronutrient change. But a long story short, I think what really works in patients is a customized diet plan. Gone are the days that you give a pamphlet that these are the don'ts for diabetes, these are the don'ts for obesity, and you expect that the patient will come back with a normal A1C and weight loss. That doesn't happen. This is a large consensus statement that was written for management of diabetes in terms of nutrition. It's a big, large document, about 25 pages, but if there's one line, if I need to pick up from this, I would say that we should make sure that these patients with diabetes and obesity have adequate amount of protein intake that reduces the spike in terms of glucose, but also helps to get satiety and therefore helps in weight loss as well. Again, when we looked at data from the Vellore Bariatric Clinic, we find that despite these patients with morbid obesity are eating a lot of calories, they are not meeting up the amount of protein that they should be taking. When we talk of dietary fiber, that's another important thing in terms of diabetes and weight management. Also very important to talk about the micronutrient intake in terms of obesity management. We also have more recent studies that talk about looking at dietary patterns rather than individual food items. Well, that was for dietary interventions, talking about physical activity. Well, I think it's very easy to try and convince this patient in terms of how just consuming a moderate size French fries needs to have so much of physical activity that requires to burn one portion of French fries. So that is definitely something that convinces patient that, probably it's easier not to eat that rather than to do the amount of physical activity. But when these patients do require physical activity, I think it's important to go stepwise in that, talking about flexibility enhancement, balance training, thereafter aerobic and resistance exercises. I think it's very important to also address the psychological health of these patients, reduce the emotional eating. And again, there are several types of frameworks which are available in terms of motivation, opportunity, and capability frameworks which are helpful. In addition to that, we have meal replacements. Meal replacement therapy is also something that can help in sufficient weight loss. This could be either partial or complete. Again, the whole concept being that you replace one major meal of the day and then you can replace with a pre-packed meal which is available in the pharmacy. Yes, cost is an issue, and at this point we have data up to 4 years, but more data would be required. But yes, with the help of these very low-calorie diets, you can achieve significant reversal of diabetes as well as obesity, and also excuse me. Moving on to the next aspect of management of diabetes, which is related to medications. Again, I think first thing we have to look at to make sure whatever medicines they're taking for diabetes are not asking them to gain weight. They should be at least be weight neutral, if not be helping them to lose weight. From the ASI guidelines, again, there are several types of medications which were approved, but yes, over the recent times, we have seen the impact of GLP-1 analogs. Step 1 study was truly a game changer, telling a drug that can cause 15% weight loss, and several studies then after that. And in this particular slide, I put a summary of all the drugs which are available from the GLP-1 point of view, both for diabetes and obesity, and the quantum of weight loss that you see with each of these drugs is absolutely amazing. And there are a huge number of drugs in the pipeline as well. Well, when patients have severe obesity, bariatric surgery is also an option. There are specific indications. These are, again, lower thresholds from an Indian point of view. Intragastric devices are also coming up as an important aspect. Again, coming back to our patient, when we looked at her dietary recall, she was taking about 3,400 calories, and we gave her good diet counseling. Physical activity is important. You see how innovatively our nutritionist has told her walking for half an hour, but she's put 10 songs because the patient likes to listen to songs. So rather than make it boring in terms of time, she's provided another way to count the quantum of exercise that she needs to do. From a medication point of view, she clearly had type 2 diabetes, C-peptide levels were high, GAT was negative. So definitely we stopped her insulin, we put her on metformin and atorvastatin. This was a time when the SGLT2 inhibitors were not very affordable and freely available. So we saw, and then the 4th A of the 5A framework is to make sure the patient agrees to the plan, because it's not you who has to follow the plan, it is the patient who needs to follow the plan. So yes, success is different for everybody. We try and give smart goals to our patients so that they can achieve them and they can be rewarded accordingly. So very, very important to also have the psychiatric assessment, which again was clear that this patient is though sensitive and social, she did not have any psychiatric comorbidity. Moving on to the last A of the 5A framework is to assess and that is for long-term assistance, because obesity and diabetes both are today considered as chronic diseases. So it is important to follow up these patients long-term to prevent any kind of relapse of both weight gain as well as for diabetes. And this is also an important aspect where I would like to cover the prevention aspect, not only for weight gain, but also making sure we prevent obesity and diabetes in general for all the people who we see. And again, very clear guidelines have been listed out as to what should be the do's and don'ts for people to prevent diabetes in general, not only for children, but also for adults, and very specific indications, especially in children today. The quantum of screen time, which has increased remarkably, is something that we really need to tackle. So this patient came back to us for after 3 months. We see that the 120 kgs has become 114 kgs. She is following about 1800 kilocalorie diet. That's the time we started on meal replacement. We did continue the oral drugs, and you look at the quantum of weight loss that the patient has achieved over a period of time, that she has lost significant amount of weight. Her diabetes has kind of reversed despite having an A1C of 12%. Today, it is 5.2%, and she's off her medicines. But yes, long-term adherence is something that is required. So friends, I will stop here. This was my key message of showing how the 5A framework can be used for management of diabetes, and is something which is very helpful in clinical practice. So I'll stop here, but would be happy to address the questions in the panel discussion. Thank you.
Thank you, Dr. Nitin Kapoor. And it was really a learning experience, a case-based, and very practically has shown what is possible if we rightly approach these patients. And prevention and treatment is a feasibility, is a possibility that you have told. Before we go to interview with the legend, Dr. Anup Mishra, by Dr. Ashok Das, I request Dr. Bharat Panigrahi to give his comments.
I think, Joint, we have less time now. We have to go to the interview first.
Yeah.
I have less time. Bharat, a very single sentence comment. We'll go to the, because we have decided to have the comments during the panel discussion, Joint.
Yeah.
Okay.
We'll save some time from panel, sir.
Yeah. Let us move.
Dear friends and dear audience, Professor Anup, I'm delighted to inform you about 3,600 odd members have joined for this webinar on the distant mode and few on the face-to-face mode, the hybrid meeting. And this is a national update on the clinical diabetes. And we're discussing today a very important aspect, that is the rising prevalence of obesity and what we'll do. Dear friends, in next 1 minute, I'd like to introduce my very, very close friend, whom I adore, whom I look forward for academic and clinical guidance, the go-to man in the country on many aspects, including obesity, Professor Dr. Anup Mishra. He is the executive chairman of the Fortis CDOC Hospital for Diabetes Allied Sciences. He's the director of the National Diabetes, Obesity and Cholesterol Foundation, president of the Diabetes Foundation of India, and his entire career had been in AIMS. He was the former professor at the AIMS New Delhi and the former faculty at the Human Nutrition Endocrinology at the UT Southwest Medical Center in Dallas, Texas, where he did very important work. Dear friends, I'll be coming to his publications, but to make a long story short, 367 publications of research papers, very, very great papers, analyzed by the Stanford University to be among the top 2%. I'll repeat again, top 2% of the scientists in diabetes from India, ranked globally. Please watch the words. And he has established the definition of obesity in India for Indian population. And do you know how many citations of his papers? It is 48,328. H index is 109, one of the highest index, and about I-10 index of 486. Dear friends, I must also tell you before I go to the discussion that we're going to have today, he is editor-in-chief of the Diabetes and Metabolic Syndrome, Clinical Research and Reviews by Elsevier, and the Impact Factor had been 10. Impact factor 10 is a great thing. Anup, I wish you Godspeed. I call down on behalf of all of us, God's love, blessings, and grace to make you one of the topmost globally. You are already there, but to shower His blessings more and more. Anup, can I start with the first question?
Yes, sir.
Can I start? I would like to ask you first that, what is the burden of obesity in our country, in the children, adolescents, and young adults, you can combine, and the adults?
So first of all, let me thank you, sir. I respect you a lot. You have been my teacher, sir, my mentor, and to be interviewed by you is an honor to me. You and Professor J.S. Bajaj, who mentored me during my tenure at All India Institute of Medical Sciences.
Allow me 1 second to pay our regards on behalf of the nation to this great person, Dr. Professor J.S. Bajaj. I'll be meeting his son tomorrow, in the day after tomorrow, in this. You are also coming there in this CNC.
Yes, sir.
And my words fail to describe the towering scientist, researcher, investigator, clinician, and the administrator, organizer, Professor J.S. Bajaj. My words fail. I will not speak beyond it. Great.
Yes, sir.
Yeah, we are great to have him amongst us. Yes.
And the second person I would like to pay my regards to is Abhimanyu Garg, along with Professor Scott Grundy at the UT Southwestern Center, where I did a lot of work during my professorship there. Sir, the obesity work we started almost 3 decades back. And at that time, when nobody was actually paying any attention to obesity, and when I used to say in Nirman Bhavan that obesity is rising, they will laugh at me because they say it is anemia and malnutrition that we are tackling and not obesity. So we were first to raise the voice, and since then, sir, obesity has risen in men and women by almost 2 to 3 times. And of course, it depends on which region you are looking at. For example, Chandigarh, Pondicherry, New Delhi, the obesity prevalence is especially high. So around 6 to 10% is the obesity prevalence, and if you take a BMI by Asian or Asian Indian standard, it is more than that. But it is not obesity that we are talking about. It is the more important abdominal obesity that we should dwell on, and that is particularly high. Especially amongst women, is 30 to 50% in some of the metropolitan cities, and men around 10 to 30%. So this is as far as adults are concerned. In children, interestingly, we have obesity which is more than adults, and actually at par with the world's childhood obesity prevalence data. So the children, we have similar data as the worldwide data. In adults, we have lower prevalence than the worldwide data. Of course, if you compare with America, we are far behind. But nonetheless, the obesity wreaks a lot of havoc in Indian bodies more than any Western bodies. And that's where we will come to a little later once we progress in the interview.
Correct. Now, Anup, you have been credited to have given the definition of obesity in our country for the Asia and for our country. Would you dwell a few seconds on that?
Yes, sir. We were fortunate to go into this problem starting in 2004 at All India Institute of Medical Sciences, along with my team, where Naval Vikram was my associate.
Yes.
And at that time, we did a number of studies on BMI as well as waist circumference as to where we stand as far as the risk of diseases is concerned. And what we found was that the BMI, both for BMI and waist circumference, our risk for diseases starts at a much lower level than what has been, the obesity definition in the West. At that time, we thought of revising the definition for obesity for Indian population, and along with data of Ramachandran, Mohan, and many others in this country, we compiled this document in 2009, and that was an epochal moment because it led to
almost 3 crore of people being diagnosed now as overweight and obese as compared to before, and they were under the ambit of diet and exercise protocol, and hence many more people who are going to develop diabetes were prevented from developing.
I always say, Anup, you have given the public health bell. Because of your work, public health bell rang. And now that the latest evidence, the paper is in the pipeline. I know you have told me, Anup. Now it is 23, and that will also give a great caution for our country. Absolutely fabulous. Now, Anup, I just wanted to ask you, what do you think are the causes for this rising prevalence?
So, whatever people say that the genetics is the cause, there are certain genes which may cause obesity, to my mind, those are only less than 5%, and 95% are always driven by the changing diet, our consumption of all sorts of imbalanced food and sedentary lifestyle in our country. Of course, adding to that are many other factors, including the stress, pollutions, and so on. But diet and exercise remain the front line change maker as far as the from thinness to obesity is concerned.
Great insight. Please, my dear people who have joined so large numbers, see, it is diet and the physical activity or physical inactivity which has driven it. And it was a very important point that in ICMR in-depth study, we found that physical activity, both leisure time, non-leisure time, is almost non-existent. Thank you very much for highlighting this point, which is inexpensive and the crux of the issue. Now, you have told us a comparison between the obesity in our country and obesity globally, all in the West. You have told about the intra-abdominal obesity or visceral obesity vis-a-vis generalized obesity abroad. Would you like to say something about the obesity of the obesity in the subcutaneous fat, or any other great difference between the two?
Very interesting point, sir. Thank you for asking that, because for the first time in UT Southwestern Center at Dallas, I investigated that whether the subcutaneous fat, truncal subcutaneous fat, the fat below the skin and abdomen and trunk, versus the intra-abdominal fat, which is more important as far as the metabolism is concerned. And using hyperinsulinic clamp technique, we found that insulin resistance is more correlated with subcutaneous obesity. Now, this was something, going against the current, swimming against the tide, because most of the people till now, they still believe that intra-abdominal obesity is something which is more important. Interestingly, in this regard, it is absolutely in line to say that the subcutaneous adipose tissue, especially over the abdominal area, is much thicker in the Indian population. Also, if you take the whole subcutaneous tissue, total mass of the subcutaneous tissue, it is 3 times more than the intra-abdominal mass, and this contributes majorly to free fatty acid. So I think in Indian population, we should dwell more on subcutaneous adiposity rather than intra-abdominal, although more may be at fault, or other fat depots also may be in fault, for example, the liver fat and pancreatic fat.
Yeah, absolutely. The epicardiac, epipancreatic, and the liver fat, as you rightly said, very significant. Anup, I have a question, which is, many of the people in our country want to become obesity physicians, clinical physicians, and to establish obesity centers. About the instrumentation, what do you believe? What are the instrumentation you like to recommend to have, from bare minimum to advanced?
Sir, very little is needed. If you are in All India Institute, or you are in somewhere deep into Rajasthan in a primary healthcare area, all you need is a weighing machine, a tape to measure waist circumference, your stethoscope, a blood pressure apparatus. That is all you need. And most of the time, this will do the trick. If you do calculate the BMI, do the waist circumference, measure blood pressure, and so on, profile the patient. However, if you have resources, then you may like to go ahead and buy a machine which can measure the body fat. Because after all, what is obesity? Obesity is excess of body fat. So if you say that truly what should be measured in any patient to label him or her as obese, then it is the body fat that should be measured. And body fat measurement takes machines which may be DEXA, which is often established in a hospital and maybe more expensive, and to the bioimpedance machine, which is also their ranges expensive to less expensive. So if you have resources, buy a least expensive bioimpedance machine, measure body fat. It may not be exactly accurate, but serially, it may give you an idea whether the body fat is being reduced by your measurements or not, by your intervention is being successful or not.
And Anup, what are the basic calipers that one should have? Because you have given importance subcutaneous fat. Which calipers they should have? It is available from the ICMR, but what is, in your opinion, which calipers one should have?
Sir, the calipers, Harpenden calipers, etc., they are a very costly caliper.
Okay.
But if you have a smaller caliper, which is Indian-made calipers also, which are cheaper, may not be as accurate. So other calipers are used. We use it in the research study.
Okay.
But for measurement in the clinic, now caliper may not be always necessary, but if necessary, at least measure the suprailiac fat, because our studies previously shown that thicker the suprailiac fat, the more is the insulin resistance, especially in children. So at least measure that. And we have a number of studies where we measured the subcutaneous fat in various sites: biceps, triceps, subscapular, suprailiac, lateral thoracic, calf, etc. So if you look at our paper, we have taken them together to say these are the central the skin fold, and these are the peripheral skin folds, and there is a ratio of both also. But essentially, if you are doing some sort of a research study, a small caliper of Indian made and a couple of the subcutaneous tissue or subcutaneous the skin fold thickness measurement may give you more idea.
Very good. I think it is a great help for the entire nation. Now, I just go on to the things that you were mentioning. Now, what are the clinical spectrum? I'll finish my question very briefly. The comorbs and the multimorbs that are associated with obesity, and what are the complications that you would like to give the message to the nation?
So, sir, there are metabolic complications or associated diseases of obesity, and there are physical manifestations of obesity. Metabolic, the most important is, of course, diabetes, and there are a number of other ones, including dyslipidemia, hypertension, and so on. And along with the contribution to coronary artery disease, obstructive sleep apnea, fatty liver. So number of these diseases may be associated with obesity. As far as mechanical is concerned, it is the hip which may be involved, it may be the knees which may be involved, and because of great mass of adipose tissue over the chest and so on, they may be, along with the obstructive sleep apnea, one may have shortage of oxygen or shortness of breath or palpitation because of obesity itself. Goes without saying that there are a number of cancers which are associated with obesity. So actually it is the harbinger of almost 40 to 50 diseases, and root cause of clearly type 2 diabetes, which we are seeing every day because of it.
Correct. I think I don't know whether you would like this term. There's a term used, quote unquote, metabolically healthy obesity, especially used for the children who have no other comorbs, and maybe little obese. I mean, what's your take on that? Should we use that term, metabolically healthy obesity, or not use that term?
Yes, sir. This has been in use for several years now, and there have been a couple of studies from India also which have shown that it exists. Now, our new classification of obesity, which is classified into stage 1 and stage 2. Stage 1 is the innocuous obesity, where there is an excess fat without much of a problem. A healthy obesity. It is metabolic as well as mechanical both. So in stage 1 obesity, there is no metabolic problem, and no mechanical problem means there is nothing which is causing problem to your joints, hip joints, knee joints, or nothing causing shortness of breath. So it is this classification is more important than the metabolic healthy and unhealthy, because that's only focusing on metabolism. And stage 2 obesity has not only abdominal obesity as a prominent component.
I think it's a great note. And you know, hypertension is also, as you rightly said, next to cardiovascular disease per se. Hypertension is also quite important, and also dyslipidemia. Anything you want to speak about, particularly about dyslipidemia, that is one area of interest?
Yes, sir. Dyslipidemia, because of obesity and the fatty liver. And the fatty liver also depending on the grade of fatty liver, the fat in the liver, and fibrosis. All this is important for generation of dyslipidemia, and in India particularly, the low HDL is extremely common, ranging from 60 to 80% in several population groups, as well as a high triglyceride. So high triglyceride, low HDL starts at a very early age, say 20 years of age, and we published this data almost 20 years back. And this is perhaps the most common abnormality in the young individuals, that this occurs. And the moment it occurs, you have to be clear that this individual needs to be focused on as far as the diet and physical activity is concerned, and maybe other interventions are required.
Yeah, I think we'll pass on to the management, and you know, you have been, I call you nutrition champion of our nation, because your messages are simple and they're very great. You have so many nutritionists working with you. I have seen in your A to B conference, AB conference, and all that. They make very your seminal contribution about the nutrition and obesity. Can you just give some tips, some summarizing points about nutrition in the obesity, adult obesity?
So, you know, there are a number of things currently. There are craze of certain diet, there are fad diets, and so on. But essentially, it is the calories which count. And I feel, and I tell the patient often, that if you cut off your 20% of your diet, you will start losing weight. And that is the Japanese principle in Okinawa, to cut off 20% of their diet, and they live long. So depending on the BMI and the weight the patient carries, I start cutting on the calories. But in the calories, the macronutrients are particularly important. And our studies have shown that a high protein is something which makes one lose weight, because the appetite decreases. There is a kick towards weight loss. And if you increase protein, automatically the other two components, which is the fat and carbohydrate, they come down. So carbohydrate needs to come down clearly. In our we have 55, 60, 65% intake of carbohydrate that needs to come down. And fat, whatever fat intake is there, should be more of monounsaturated for polyunsaturated fat. So for example, say if we say protein is something like 12 to 15% energy in the Indian diet, we should increase it to 20 to 25% of the energy. We decrease carbohydrate to 40 to 45% and keep fat with a high monounsaturated fat content. This will work beautifully while we decrease overall calories and increase exercise. Beautifully in most situations, without resorting to either a keto diet or some intermittent fasting or anything like that.
Good. I think I've answered the two questions that was ingrained. I think much better way. Do you believe in the OSN, obesity specific nutrition, like something omitting a meal or something or substituting a meal?
Yes, sir. We have experimented with that, and
I
when
remember that paper you presented the paper with almonds. I remember that paper.
yes, sir. So there are two things. One is that we replace one meal with a protein, and so it could be drink or it may be anything else with protein. And if patient loses weight, and if we make it two meals replacement by protein, the weight loss is more. The second thing is that the sequencing of the macronutrient, and we are among the first in the world to establish that if we preload, if we give something before the meals, for example, we take
that also
almonds,
yeah.
protein, or even salad. 15 minutes to 20 minutes before the meal, the postprandial metabolism improve and postprandial blood
That is
glucose
a
goes up.
great tip for the country. Great tip for the country, and it's
Yes.
correct what you preload before we start our main meal.
Yes, sir.
But I think before we end, I would like to have your comments on the modern drugs that we have. I think the only drug available today, I don't know your opinion about the older drugs. The new drugs we have today, very briefly, and the use of this drug continually as for any chronic disease, or can in India we can stop it, and number three, about the sarcopenia, which you spoke so beautifully in the Delhi ACCD, sarcopenia, how to measure it with the hand, that manual, seeing the strength of the pen, and just a little bit about that.
So the first thing is about the drugs, sir. Again, I'll go back to the obesity classification that we are going to unveil in a couple of days' time. In stage 1 obesity with no metabolic problem and no mechanical problem will give this patient option of losing weight only with the diet and exercise, unless specifically patient really says that I need some faster weight loss, etc. It depends on physician whether to use a powerful drug like semaglutide. However, if it's a type 2 obesity where there is associated disease, for example, let's say obstructive sleep apnea, a patient has diabetes which is uncontrolled, a patient has a cardiovascular disease, patient has a markedly increased fatty liver with the fibrosis, in such cases, it's earlier use of the semaglutide-like drugs are required. And if a patient cannot afford semaglutide, we can use a combination of drugs like SGLT2 inhibitors, the orlistat, etc., along with diet to make him lose weight. So this is our approach. In patient innocuous obesity, we aggressively diet and exercise and keep drugs reserved. And type 2 obesity, we use earlier these drugs. Now, these drugs or any drug like SGLT2 inhibitor, which may lead to some amount of weight loss, may decrease the muscle mass. Now, sir, there are two things about it. One is the muscle mass real loss, and the other is that the fat within the muscle is lost, so muscle looks thinner. Now, our experience, and we have published that the grip strength actually improved after weight loss with the SGLT2 inhibitor. So actually, muscles become more efficient. But nonetheless, there is Indian population majorly is sarcopenic, and especially women are more sarcopenic, and we are much more sarcopenic than the Western population. Our muscles are weak. Any weight loss needs to be combined with the resistance exercise, and ours is the only paper, our resistance exercise in this country, along with a high protein diet, so as not to lose further muscles and not to become further sarcopenic. Now, people will say how to measure sarcopenia. You need not have something like DEXA or anything. If you want to quickly measure sarcopenia, you can have a sit-up test on the chair and get up 5 or 6 times, and it can be measured. Or you can have a hand grip strength caliper. Now, the usual thing is the JAMA dynamometer, which is very expensive, but there are cheaper versions which are available in Indian market. So these dynamometers may be purchased. In our clinic, all our patients undergo the hand grip test, and we measure over serial time whether their hand grip has improved or not. And all our patients receive advice for resistance training.
Anup, I have no words to express the gratitude on behalf of the nation. I will just let you know that it will be NUCD broadcast on the 11th. And after that, with your permission, without any commercial interest, it will be put in the national YouTube channel if you do not have any objection. And it will be for the whole nation. Number three, I would like to tell you that before we close, what is your lessons for the nation?
So my lesson for the nation is that we catch them early and that we start with the schools. And my message is towards mothers that keep your diet healthy, do a daily exercise so that you can be role model to your children. Don't let their weight go up during the school or subsequent to school. If they are within the BMI, they are physically active, then they will be free of most of the diseases which we are seeing in the early adulthood. So you be a role model, your husband be a role model, and at the same time, teachers also should be. If three of them combine together, our children will be healthy, surely.
Anup, thank you very much. On behalf of all of us, we offer our sincere thanks and gratitude and appreciate your giving so much of time to us and talking to us. Thank you very, very much. But
Thank
it's
you,
very
sir.
impacting. I'm sure it will make a dent in the obesity prevention, care, management, complication control in the country. Thank you. Thank you very, very much. Thank you,
Thank you,
Anup.
sir.
That was a very informative interview by Professor Ashok Das with Professor Anup Mishra on rising incidence of obesity in India. So he has covered almost all part, giving a clear message to the parents, to the teachers, to every one of us, that how to manage our weight practically and why we should be conscious of the weight. So with this, the context setting, the obesity and type 2 diabetes by Dr. Sheshadri, the beautiful presentation of prevention and treatment by Dr. Nitin, and the interview very informative, very practical by Professor Mishra and Professor Dash is over. We have very less time, maybe 10, 15 times for the panel. So I'll be trying to squeeze the panel to very efficient panelists. Before that, I request Dr. Bharat Panigrahi to sum up the sessions quickly. Dr. Panigrahi.
Thank you, Dr. Jayant. So, friends, we heard from three eminent speakers, that is regarding the obesity, this pathophysiology of diabetes, and the prevention and management of diabetes, and of course the great debate. There is a great interview by Dr. Ashok Das with our eminent speaker, that is the eminent obesity, that is Anup. So with all this, we could know. So what I want to in 2-3 sentences, that obesity and diabetes, what goes for diabetes, they are interrelated, and these are two pandemics. And if you can prevent, because management part is, I think prevention part is more difficult than the management part. So our aim is always to prevent. We don't want to be again the diabetes capital or obesity capital in the world. So if you can prevent what Dr. Anup told, that is from the very beginning, if you can be at least conscious regarding our lifestyle. So for the because we cannot change our gene. What we cannot change our gene, but we can influence our epigenetics factors. But the epigenetic factors are only, these are all influenced by the environmental factors. So that environment, that is the lifestyle, what we call the diet and physical activity, if we can control it from the very beginning, then we can at least prevent the very fast growing number of obesity and diabetes in this country.
Very nice conclusion, Dr. Panigrahi. So with this, quickly we'll move on to the panel discussion. I request the organizers to focus the panelists, and we have a very efficient panelist whom whole country wants to listen. To start with, our own scientific chair, Dr. Ashok Das, who is endocrinologist at Pondicherry Institute of Medical Science, PIMS, and the new medical center. And Dr. Krishna Sheshadri, you heard
Jayant, I
just
will
now.
suggest that
Yeah,
we have been introduced, so we'll confine the questions to Nita and to
yeah,
Sandeep. So Nita and Krishna is also there. So Krishna is an eminent.
yeah,
So
yeah,
these two people, two questions each. Please ask. Start with Nita, then
yeah.
with Krishna, then to Sandeep.
Yeah. I request the organizers to take this panelist and put them in a box so that they'll be focused in the discussion. To start with, Dr. Nita, as suggested by Ashok Shah, and before that, I welcome Dr. Shandip Mathur as well as Dr. Nita Deshpande. And for the interest of time, I'm not introducing them. All of you know them, and their CV is projected. To start with, Dr. Nita, who has one of the highest work in the field of obesity. I'll start the first question. What is the burden of obesity and diabetes in India? As you know, the theme of this program, the obesity and diabetes. So we know both are so closely related, and both contribute to the other one. But at present, what is the burden in the country? To start with, Nita ma'am. Over to you, Nita ma'am.
Yeah. Yeah, thank you very much, Dr. Panda, and thank you for having me on this particular panel discussion. Well, as far as the burden is concerned, as alluded to already by Dr. Anup Mishra, sir, we have the latest data now from the ICMR INDIAB study, and we can see that the obesity prevalence is actually very high, and it's a study that has been done across the country in all the states, and we find that the generalized obesity is to the tune of 39%. 28%. And if you look at the abdominal obesity, it is even higher, which is 39%. So you can see here, and if you see the overall prevalence of diabetes in this particular study, it's about 11%. So you can see that the obesity prevalence is double that of diabetes, which actually tells you the metabolic connection between obesity and diabetes. So more number of obese patients, and these are all many of them set to become diabetic later on. So the burden is very high in general of metabolic disease. And this particular study, which is the latest one that has been published, gives you a good slice of what is happening as far as the statistics of diabetes and obesity is concerned.
Yeah, almost one third of the people are obese, maybe metabolic or visceral, and in the diabetes, which is much lesser, and many of them have both the pandemics together, as already you have been pointed out. So we'll come back to you again, ma'am, then to Dr. Shandip Mathur. Already we have discussed this issue. How do you think that the both obesity and diabetes are together causing the metabolic challenge? This twin epidemic, this double trouble, how they pose the metabolic or influence the metabolic challenge for a person, the diabetes and obesity. Dr. Mathur. Yeah, you are muted, sir.
Yeah, thank you, Dr. Pada, and thanks, Dr. Das sir, for opportunity to speak here. You see, as a molecular geneticist, my opinion is entirely different. It's not the amount of fat present in the body, but this is the quality of the fat that matters a lot. So quality of fat, because we done a lot of work with ICMR support and we look over the adipose tissue biopsy and find its correlation with disease, and at a molecular we find There are several modules of co-express gene which are genetically driven, and they play major role in determining whether your fat causes disease or not. So this is adiposopathy or sick fat that is most important. And Dr. Anup Mishra's one paper I had a read where he has shown that the large volume of the pancreas were there in diabetics and large volume of liver. But I look into his supplementary table, I find there was basically very less peripheral fat. So that was the beginning point, though that was not much highlight in his discussion, but I could see in his work. And then we look for the peripheral fat pathology. And we find peripheral fat, femoral fat show a good degree of adipose tissue pathology, so-called adipocyte hypertrophy and inflammation, and that very strongly correlate with the disease. So the model of disease for diabetes and obesity relationship, it is more the quality of fat, particularly in your subcutaneous. Dr. Mishra also told the same, there's subcutaneous fat and your peripheral fat, that is more important for our country. Very interestingly, recent paper we published in PLOS One, which I think Dr. Mohan highlighted during even ADA meeting also, that it is the ectopic fat that shows very strong correlation with your diabetes and insulin resistance and metabolic syndrome. So relationship is not straightforward related to your BMI. BMI is an indicator of quantity of fat, but not an indicator of quality of fat or its distribution. Now, going to the same issue from geneticist point of view, very good paper from in Nature Medicine from for this finance group from Queen Mary for South Asian. It is fat distribution between peripheral and central compartment that decide the disease. So relationship is different than simple BMI. And lastly, my comment is this: we have come with a concept. The paper is still not published in review with us. It is central obesity with cutaneous signs of insulin resistance. That's the best predictor of adipose tissue pathology and your risk assessment of the clustering disease, diabetes, hypertension, dyslipidemia, and coronary disease. So my view is a little different.
Can you give me 1 minute?
Yeah,
Can
yeah,
I,
sir.
with your
Sir.
permission?
Sure.
I think, dear friends, Dr. Sandeep Mathur is one of the most prominent researcher in obesity in our country. And give a big round of applause for the huge grant Government of India, along with the state government, he has been awarded for taking the original research. To make a long story short, Sandeep has been pioneered in few things, Jayant. One is about the brown fat. So can I ask you a little bit of brown fat?
Sir, actually brown fat is a protective fat, and we have less brown fat for two reasons. Number one, our high temperature. Because if we live at a temperature 18 degrees centigrade, the base cells or browning of the adipose tissue take place. And because of the uncoupling, there is more energy production and less of fat accumulation, or this your positive calorie balance. So, because a number two reason is if we consume lot of spice in our diet, that will lead to browning. So, two things are environmentally driven. One is your temperature, and another is your your spices in diet. There's two factors are very environmental factor related to browning of the fat. So brown fat is a healthy fat that protects from weight gain, protects from your dysmetabolism, and protects from insulin resistance and diabetes. So very
That has been
important.
your message to the nation. Last two questions very quickly, Sandeep. I understand you have to go back. Number one is that whether it is intraperitoneal fat or it is the peripheral fat or both that show association with diabetes.
Yes, because now I have a couple of publication.
Yes, that's why I'm asking this question.
One paper published recently we have shown it is the ectopic liver fat.
Yes.
That show strongest correlation with insulin resistance.
That's what Krishna also said. Krishna also beautifully said. It was a classic lecture, Krishna. Classic. Krishna is here, going and coming. Krishna, we can't see you now. Krishna gave that with the liver fat, diabetes begins.
Yes.
Am I correct, Krishna? And you said the
Absolutely, sir.
importance of liver.
So if you there's a very good correlation between systemic diacylglycerol levels and diabetes, right, and insulin resistance.
Yes.
The There is no diabetes without ectopic fat.
Yes, exactly. So one
There is
more.
no diabetes without ectopic fat. I mean, I'm not talking about type 1 or Modi's, but I'm talking about the garden variety type 2 that we see. There is no diabetes without ectopic fat. And that's why the treatment of diabetes is to stabilize and reverse ectopic fat.
And what the means for that? You said about weight
Weight,
loss. Said about
weight
weight
loss.
loss. Yeah, but
Absolutely.
any other simpler thing, Krishna?
Uh,
Sorry.
so I think Dr. DiFranzo and I are the only people who think glitazones are great. But
Absolutely. I'm talking about it little later today. Good, good.
we are the only two people who believe in glitazones. In fact,
Yes.
people get upset with me, but I will say that the greatest combination ever invented is a GLP-1 RA, SGLT2 inhibitor, and a glitazone.
Yes.
Yeah, and, exactly. I would have asked you that, sir. When we target obesity and diabetes together, how do we plan our intervention in those high risk group?
I think that's a great question. Jayant has a very intelligent guy. Do you have what is the same plan? Can you attack both in the same plan?
Yes, absolutely. So remember that we now have does weight loss reduce A1C? The answer is yes.
Absolutely.
Second, does the weight loss reduce glucoses? The answer is yes. Does the weight loss reduce hepatic fat? Answer is yes. The weight loss reduce peripancreatic fat? By inference, yes. Does it reduce pericardial fat? By inference, yes. Right? We know that weight loss through metabolic surgery, as one way that we have looked at it, reduces MACE, reduces pill burden, reduces insulin use, reduces complications of diabetes. Uh, we have data for all of these, and this is, forget the incretins, forget everything else. Weight loss as a continuum, and preferably over 10 kilograms, does wonders. And by the way, it reduces obstructive sleep apnea. It reduces it. We haven't looked at cognitive function. I think we need to start looking at cognitive function also. But reduces osteoarthritis, reduces back pain. There is that in the retune study they used people with normal BMI. So again, people will get upset, but I will tell you that even if your BMI is 23, some amount of weight loss helps you. The only thing is make sure that when you do that, that the patient starts on resistance exercise so that the degree of muscle loss is reduced.
I mean the sarcopenia. I think Jayant will have the last question for Sandeep and then pass on to the
Nitin is there, sir?
queen of obesity. I call Nita the queen of obesity. We'll pass on to her for the last question. Yes, yes. Sandeep to
Dr.
Sandeep.
Dr. Nitin Kapoor is not there. No,
Nitin is
she's
not here. I have a
not.
question for Sandeep. Sandeep, what is, I mean, to make a very brief, you have a couple of minutes. What message you have to give? What you are looking forward in the great study? Number two, I mean, what is the great change, impact, dent it will make in the nation?
Sir, actually, most important thing for South Asians is adipocyte hypertrophy. If we say our phenotype is different than Caucasians, we have less fat, more disease, it is only related to our adipocyte hypertrophy, well proved in the study done in UK. Number two, in my own data, which I am analyzing now, and paper is submitted for publication. Whatever is visceral fat volume high in our people, it is just because of adipocyte hypertrophy, not increase the number of adipocyte size. And adipocyte hypertrophy, particularly limitation of adipocytes to proliferate in number, rather increase in size, is responsible for all the disease, and it is more so in the peripheral compartment, which we have shown our transcriptomic studies all. So all strategies should be directed not only reducing the weight, but redistribute the fat from central to peripheral compartment. So we have a study going on and we have interim data analysis. What Krishna says rightly, pioglitazone as compared to sulfonylurea when added over to your metformin in newly diagnosed patient, drastically reduce liver fat as compared to sulfonylurea. So important message is take care of adipose tissue pathology as a primary target of intervention, not only simple weight loss, because there are many things to reduce the quality of fat, right from your eating early in the morning, not late night snacking. That makes a difference. Krishna told me this thing many times. I appreciate thanks to him. Number two, loss of is use of a spice, lot of physical activity, less mental stress, and last and most important, avoid environmental pollutants and endocrine disruptors. They all contribute to adipose tissue pathology. And not only it is diet, but it's the quality of diet makes a lot of difference. In fact, I working with Krishna on this direction. So we are
Thank you, Sachin. Thank you. I think it was great to have you and Krishna together. And I call Nita my very, 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 very close friend, the queen of obesity studying in India. Jayant, please ask Nita a few
Yeah,
questions.
yeah. Nita ma'am will give her final opinion. Before that, I'll request ma'am to just sum up the workup of a patient of obesity. What Professor Das was asking,
Yeah.
Anup sir, actually we
Yeah.
quantifying obesity and the measurement of obesity and
Yeah.
giving them target of the loss, that at times our general physicians should get a message how
Yeah.
will investigation the workup of a obese person, and then for your final saying uh, for the physicians how to approach a case of obesity and how to motivate them or help them reducing weight.
Yeah, thank you, Dr. Panda. It's a wonderful question, although difficult to answer in 2 to 3 minutes, but I'm going to try my best. So it all starts with the proper history. The history taking of an obese patient is quite different from the history taking of a patient with diabetes or any other illness. For example, you need to ask completely about the weight history. When did it start? Were there any trigger factors for the weight gain, like a pregnancy, or was it from childhood? Was it childhood obesity? So weight history is extremely important. Nutritional history is also very important. What the patient has been eating, how much he's been eating, and a computation of the macronutrient divisions with what the patient is eating. So that is the second part. Third part in the history is the weight loss attempts in the past, because yo-yo dieting is so common. So every time when a patient walks into your clinic, you don't know how many times the patient has gained and lost weight, whereby they have been changing the fat to protein, fat to lean mass ratio drastically, which is going to affect the future weight loss attempts. So that is a history that needs to be taken. After doing that, then comes the actual workup of the case, where you look at, of course, the height, weight, you get the BMI, and if you have a bioimpedance machine in your clinic, you look at the and which you can, as Dr. Mishra also pointed out, serially, if you look at it, it might give you a better idea, even if the machine is not a very high quality one. So you will have to. So that's what we do with the body. Some machines are there tell you a little about the visceral fat as well. So that is something. And then we have a panel of investigations which we look at, which have a twofold effect. One is to find out what other comorbidities are there which were previously unrecognized, like pre-diabetes, diabetes, dyslipidemia, thyroid status, etc. So you get to know all of that. Second important thing is to find out for staging of the obesity. Like if you want to put the Edmonton obesity staging system, you need a lot of investigations to find out what stage the patient is at. And do not forget the mechanical complications of obesity as well. But then, of course, there is in the history you would have taken things about stress, sleep, which are again very, very important factors in obesity. So with all of this, you can actually find out what the root causes of obesity are in that particular patient, because for each patient, they may be unique. So that is how we assess a patient. And then, of course, if you have we are also doing hand grip in each and every patient. So so these are also, you can add ancillary investigations and assessments to the whole thing. So this is a complete assessment of an obese patient in short.
Very, very well described, ma'am. I am sure that our physicians are benefited. And your last words to close this the diabetes obesity session. What message you want to give to our doctors?
Yeah, the message is that even if a particular physician, most physicians do not run obesity clinics, obesity is too important to ignore. Just like you are diagnosing diabetes, just like you're diagnosing hypertension, you need to diagnose obesity and put it on paper. Just like you would write in your diagnosis, type 2 diabetes, hypertension, anemia, hypothyroidism, you also need to put obesity, if possible, with the staging and grading. So this opens up the conversations with the patient of trying to, assess his weight status. That is number one. Number two, I would say to all the physicians listening in, a basic working knowledge of obesity and the algorithms that are there for treating obesity have to be known by everyone. It's not enough anymore to tell a patient, go lose weight or eat less and walk more. That's not going to work. So every physician needs to have a working knowledge of how obesity is to be treated. Or if they don't have the time, patience, and workforce to do it, they need to refer the patient to an obesity clinic for weight loss specifically. That is what I would say.
A very, very important message ma'am has given, that you recognize this as a metabolic problem and then help patient stratifying the obesity and guiding him regarding the drugs, diet and lifestyle, so that he or she will be able to lose. Thank you ma'am for being with us and giving so important message. And I'll come back to Dr. Sandeep Mathur. Sir, quickly, you have already told your message, and we have taken you through all brown fat and the quality and the quantity and everything you have told. Quickly, one thing that to enhance the brown fat in the body, as you told, the temperature and the spices and all factors that affect, what message you'll give to the patient through our physicians, so that they can have good fat in their body, not bad fat.
Yeah, very, very pertinent question. You see, synchronize your day-night cycle with the sunlight. That is very important. Early to bed, early to rise, very important. Number two, eat as early as possible, no late night eating, because liver metabolize carbohydrates in day and fat in the night. If you are eating late, then your liver is metabolizing carbohydrates in night and there is no opportunity for fat to be metabolized. Number two, environmental disruptors, because we have a publication regarding that bisphenol A coming for plastic. Very important determinant of your adiposity or adiposopathy. Avoid environmental pollutants as much that possible. Third point is, of course, eat less. And what Krishna rightly said, lose weight by 5 to 10 kg, 5 to 10% weight loss by change in calorie content. Number two, there is an index of Indian food quality index, because less carbohydrate, less fats, good quality fat. That is very important, good quality fat. And last and most important, go back to your traditional diet, which your forefathers have been taking. And last and more important is lot of physical exercise. So these are all strategies to improve the quality of fat. And we should target adiposopathy for the not for mechanical, but from disease associated disease prevention point of view.
Very, very pertinent points. And by simply following what we all were doing long back and a right lifestyle, we can have better quality fat, and which will not be pathological. At the same time, weight loss will enhance our getting over the risk factors. So with this, we'll conclude the panel discussion. I thank Dr. Nita Deshpande ma'am and Dr. Sandeep Mathur sir, also Dr. Krishna Seshadri sir and Dr. Ashok Das sir for their participation. And we had a very clear message for the physicians, for the attendees, and I'm sure starting the Nucd with obesity and diabetes session and so much of discussion on obesity will definitely help all our physicians to develop the approach, and their assessment and intervention will definitely change. Henceforth, they see a metabolic patient with multiple complications like diabetes, obesity, hypertension, dyslipidemia, and all together. So thank you all. With this, we'll move on to the second session, that is complications in
Thank you
diabetes.
very much,
Over
Jayan.
to Dr. Das. Yeah.
Bharat, thank you very much. It means how much of interest in the country for the obesity. We'll come back to it. Now, can I just go back to the second session? Now, this session is centered around complication one, and we have, they have set the context. Only I will tell context setting for the two speakers that are going to encounter. One of them is both are my favorite, me and Lalit. Both welcome them. Lalit will conduct the session. I just invite Professor P.K. Sahu to talk about warning signs of the cardiovascular disease in diabetes mellitus. We have Manisha, one of my most favorite speaker, Manisha, who will be speaking about the kidney disease in diabetes is a danger in slow motion. Lalit will conduct the session. Lalit, be careful about the timing. Now, with this, may I now invite Professor P.K. Sahu to give his presentation on the warning signs of this. I'll just tell one story short. He's the presiding king of the cardiology in the Odisha. Yes. Let us start the lecture.
Thank you, Team Nucd and Professor Das, for your kind words of introduction. In fact, this is a topic which for every physician should know, that is basically on what are the warning signs in diabetes. So this is very important because we all know that diabetes is something which can affect the full body. If you know about diabetes, basically you know everything about medicine. Previously, used to tell if you know about syphilis, you know everything about medicine. Now you know if atherosclerosis, you know everything about medicine. So I'll be basically starting with that every heart wants to live more. Now, the thing is that we cannot just ignore the warning signs of the heart and says that because we only have one heart. So that is why it is very important to know what are the warning signs. Now, this is a very common slide where you see that the risk of vascular complications, especially the macrovascular complications, almost start 4 to 7 years before the diagnosis of diabetes. So already the bed has been ready and already the seed has been implanted and the tree has started growing. And by the time they come to this stage, it is already quite late. So the question comes, can I detect the warning signs much earlier than diabetes? Or if there is diabetes, whether it can be detected? Now, diabetes cardiovascular risk solely hovers around coronary artery disease, heart failure, peripheral arteries, and stroke. But I restrict myself to these three because this involves the cardiologist and the cardiovascular team as a whole. Coronary artery disease is almost to the tune of 20%, and one-fifth of the patient will be there, even if the diabetes is well controlled. Now, let us not be like this blind men and just thinking that no, my patient is okay. Don't need to detect anything. We need not be blind. There are enough symptoms and signs which the patient will focus before us so that we can pick them up. Now, most importantly is chest pain. Chest pain possibly is the most frightening cause of all pains in diabetes. No neuropathy, no this thing, but it is only cardiac pain which is most important. And most importantly, listen to the patient properly because the patient will tell you exactly what is wrong. Here I stress upon that it's history taking is most important. Many patients will come to you, will tell you, I have pain, some vague pain, this thing, I easily get fatigued. Don't take the symptoms lightly because possibly you are dealing with a cardiovascular disease which may finally blow up and time is already lost. Chest pain in a diabetic is a body saying that it's an emergency. Now, if you come to the actual definition of this thing that is angina, which was described long time back, so it clearly has the same description does still follow now. And as a rule, any chest pain diabetes is ischemic in origin until proven otherwise. This is what we as cardiologists, and it should be a dictum for everyone. Now, angina has typically, this picture must be very familiar with you from the Netter's Atlas, that it should be substernal, onset with exertion or emotional, relief with restor angina and nitroglycerin. Three important points. If these three important points are fulfilled, it is typical angina. If two are fulfilled, it is atypical. And if one of them is fulfilled, it is non-cardiac. So very easy to diagnose angina in patients. They have to fulfill this criteria. Now try to see what are the palliative and the provocative factors that if they on work or walking they get it or on rest they get relief. What is the quality of discomfort? Does it radiate? Are these symptoms associated with discomfort? And what is the exact timing? Because many patients tell you that after I take my food, I get this pain. Or when I'm hungry, I start getting pain. So these are certain indicators from which we can know that possibly the patient is having coronary artery disease. Now, quickly, where does the pain occur? It may be the upper chest, the substernal, the radiating to the left arm, or even still in the epigastric region, or epigastric radiating to the neck, jaw, and arms, neck and jaw involved, or both shoulders, or even interscapular pain. So if I tell any pain below the lower lip, till this thing that is epigastrium in any diabetic should be considered as given pointed in this diagram, should be considered as cardiac in origin, and you have to investigate further. Besides that, diabetics just might tell that while I walk, I get some pressure in the chest, it starts spreading, and many patients complain that I just get lightheadedness, start sweating, and feel that I am nauseating. So these are very important warning signs that one has to pick up that your patient is having chest pain. Please do not, just because the patient will come with a diagnosis that I have gas, I have heartburn. This is the commonest symptom that the patient gives, but don't ignore it in a diabetic because he is possibly giving a warning that he is having a cardiac problem. Now, don't be fooled if the ECG is normal. This is a very important dictum. The ECG you may do multiple times. So it has been seen that 40% cases of acute myocardial infarction, the ECG is absolutely inconclusive. So as I said, the patient will tell you the history. You don't have to go ahead. Now, to diagnose this thing that is coronary artery disease, there should is a triad of angina, ECG, and markers. If angina and ECG changes are there, we call it as unstable angina. If all the three are there, we call it as non-STEMI. And very easily diagnosed in non-STEMI, it has to go below the baseline, and in STEMI, it goes above the baseline. Basically, what happens in non-STEMI, there is an incomplete occlusion of the artery, and in STEMI, there is a complete occlusion, which is really a cardiac emergency. So just see whether it is below the baseline or above the baseline. It's going above the baseline, it's STEMI, and if it is below the baseline, it's a partial occlusion. Now, these are all what happens. This is how this ST segment elevates, and this is in non-STEMI. Either the ST segment goes down or a T inversion can take place. Most importantly, STEMI is very easy to know. It is like the tome sign, tome stoning of the ECG, which gives you an idea that no, my patient is having a STEMI. Now, once this history is there, you have an ECG. Next thing, you get an echo done, enzymes done, or you can go for this thing, an angio or a bicycle ergometry if the patient is having a chronic stable angina. Now, but for MI, you have to act fast because we know when myocardial infarction starts and the patient usually do not give a significant history, life hangs on a thread and minutes do matter. And it has been seen the golden hour is most important. As we go down, the more of damage takes place, and as a result, many patients will lose. And it has been seen we have moved from the past of just bed rest to we directly wheel into the cath lab, to the CCU, to immediately manage them. And it is what I call as coronary firefighting. Because once the patient starts complaining, you have to fight it out because that is the organ that might get damaged and you might land up in problem. The most important message that should go is that as soon as the patient gets affected, you see within hours the muscle starts getting damaged. So open this ocular artery either pharmacologically, keep it open so that you limit the size of the infarct and you ultimately improve your LV function. Now, the two solution is either when you have a closed drain, you have to use a medical solution, or if it doesn't open, you have a mechanical solution. Similarly, if a closed artery, you can do a thrombolysis, or you can take him to the cath lab and open up the artery, which is a mechanical solution. Now, why are we so interested that these patients should be quickly intervened? Because as the heart attack occurs, as the angina takes place, the heart starts getting dilated and secondary damage occurs. And the ejection fraction starts coming down, and asymptomatic patient starts becoming symptomatic. The quicker you open the artery, revascularize artery, the patient improves. The next thing that the patient can present with sudden cardiac arrest. You don't know anything, suddenly the diabetic falls down. So you have to know the warning signals, early recognition. One should know CPR, should know how to do an early defibrillation, and shift to the hospital with this thing, all services available. Now, the next part I'd like to go, which is really a pandemic now, is heart failure in diabetics. And almost 1/4 of our patients with diabetes do have heart failure, and we do have to recognize them early. There are certain warning signs of heart failure. Why are we worried about heart failure in diabetes? It has been seen that almost 55% of diabetics, heart failure patients are diabetics, and these patients have to be detected quickly, or else we might have a lot of patients who are really they do not have a regular good lifestyle and they have low quality of life. It has been shown that heart failure is present in almost 15% of patients as per various studies, and also that 72% of the patient may not have heart failure, and there is an entity known as heart failure with preserved ejection fraction. The patient's echo may be normal, Everything be normal, but the patient may be in heart failure. So we have to detect this 23% of patient as early as possible. So heart failure is an early and forgotten complication in type 2 diabetes. And most of the patients have this heart failure with preserved ejection fraction, almost in 44% of the patients with diabetes, and they need to be detected. Now, once these patients' endothelial dysfunction takes place, atherosclerosis occurs, CAD, MI, strokes, LV remodeling, and these patients comes to heart failure, and we cannot reverse the cycle. So it is very important that in diabetes, heart failure needs to be detected early. Now, these terms are very it's common to us: heart failure, reduced ejection fraction with mid-range or recovery ejection fraction and preserved ejection fraction. Any patient having more than 50% has a normal or preserved ejection fraction. Anyone with reduced ejection fraction less than 40%. So we can have patients who can improve from reduced to preserved and can also go down from preserved to reduced in diabetics. A new term in 2024 which has come is heart failure with supernormal ejection fraction. And this is seen more in diabetics. The ejection fraction is more than 65%. And we all pass off these patients as a patient being normal. But these patients do have heart failure. And this is a new entity of supernormal ejection fraction where the major adverse cardiac events are more. And these patients have a normal ejection fraction and a higher risk of mortality. Not only that, these patients were really older, were women, and the most importantly, natriuretic peptide values were not very high, and they had similar cardiovascular deaths to heart failure for hospitalization with preserved or reduced ejection fraction. So reclassification of heart failure has already been done in 2024. We have brought in the term of heart failure with supernormal ejection fraction, where we should not miss these patients. Now, these are the clinical features when the ejection fraction on echo goes more than 65. There's a woman, non-ischemic, blood urine nitrogen is slightly raised, natriuretic peptides are not very high. They are under beta blockers. They have usually microvascular dysfunction, more common in ladies. The stroke volumes index is less and almost at a U-shaped prognosis in these patients. They were recognizing this entity more and were trying to see how many percent of diabetics have a supernormal ejection fraction. Now, these are the common symptoms that you should not miss: dyspnea, fatigue. This is the most important symptom that the diabetic patient may tell, or slight pedal edema. Don't always confuse that. Most likely the patient is taking a calcium channel blocker or is on some drug so that there is an edema. Any edema has to be taken seriously in any patient of diabetes. Not only that, the symptoms may include PND, bendopnea, reduced exercise tolerance, wheezing, which many patients are go to the pulmonologist, bloated feeling, mostly they go to the gastroenterologist, loss of appetite, palpitations, dizziness. All the symptoms have to be taken very carefully because these are the warning signs of heart failure. With normal ejection fraction, the just patient may tell, I feel a little breathless. I have breathlessness while lying down or sleeping. I have a chronic cough which is not getting cured. I just unusual fatigue. I'm having weight gain. There's some edema. Sometimes my heart is irregular. So these are the symptoms which you should pick up and are the warning signs that the patient may be having heart failure. Based on the signs and symptoms, go for the enzymes, get an echo done, get an ECG done, and the diagnosis will be confirmed. So basically, we have two types of heart failure, mainly the reduced ejection fraction where the heart is dilated, or a reduced, preserved, or a supernormal ejection fraction where the heart is hypertrophied and may not have a ejection fraction, which is but normal, but is hypernormal. Now, the last entity is peripheral artery disease, and this also occurs in almost 30% of patients, and usually we miss it. And usually these patients tell that their feet feel heavy, there's coldness in the limbs, and to the extent they cannot bear it, especially in winter or in summer, slight injuries and bruises don't heal. There's conspicuous paleness in the areas after they take a shower or a bath. The limbs feel very cold in the morning and in the evening. Even tap water feels cold to them. Presence of stubborn athlete's foot, and they always keep on wearing their socks feeling cold. Now, the best way is to palpate arteries. It is, as I said, in clinical medicine, one of my professors had said, when you you receive your teacher, you first touch their foot. So when you receive your diabetic patient, touch their foot first. You'll first see the dorsalis pedis, then you'll see the posterior tibial, then you'll see the posterior fossa artery, which we normally don't do. And most importantly, if you do a ABPI, where you take the ankle brachial index blood pressures, if it is less than 0.9, then definitely your patient is having peripheral artery disease. So it is very important that you have to detect this problem, and we see that they're detected early. Dopplers are easily available, bedside Dopplers also in every clinics are there to detect it. Now, if you tell the diabetes cardiovascular risk composes mainly of the coronary heart disease, so you have to detect the signs, warning signs early. Heart failure is a pandemic for you to detect as early as possible, treat them so the quality of life improves. Peripheral artery disease, a disease which we rarely detect or we usually miss because we do not see the pulses, we should be given importance so that we do not miss the warning signs. So it's exactly like this, that if you do not see the warning signs, you do not see whether it's a red light or a green light or yellow light, and you drive blindly, then there's every chance that you will definitely have a catastrophe. So we have to be very vigilant and try to see that we don't have such accidents in a diabetic patients. Thank you very much for the patient hearing.
Prashant, thank you. Classic, impactful, unforgettable. Over to Lalit. Lalit, you
Thank
please
you, sir.
conduct the rest of the session.
Thank you, Dr. Sahu, for your very elegant talk. You have talked in detail how the cardiovascular morbidity and mortality is very important thing so far as a diabetic patient is concerned. And you have told the whole spectrum of the cardiovascular manifestations like coronary artery disease, heart failure, peripheral vascular disease, and how to catch them early. That means how to pick up the early signs and investigate them later on and prevent the catastrophic incidents. So I think we'll go to the next talk because we are just running a little bit shortage of time. The next talk is on CKD in diabetes, an emergency in slow motion, to be delivered by Dr. Manisha Sai. She is a very eminent speaker. She is the president of Women in Nephrology, associate editor, Indian Journal of Nephrology, emeritus editor, Indian Journal of Transplantation. And she has got many publications to her credit. And now, without wasting much time, I will request Dr. Sai to go ahead with the talk.
Yeah. So am I audible?
Yes, Manisha.
Yeah. So thank you very much. It's a privilege to be here, and I learned a lot from the previous presentation as well. So thank you, Dr. Das. I mean, thank you very much for this opportunity. So are my slides visible?
Not yet. Not yet. Only your opening slide. Go to next. Yeah. No, next slide.
Yeah.
Here is your introduction. Disclosure. Yes, now it is visible.
Yeah, so thank you very much. So this topic is very close to my heart. CKD in diabetes, the topic is excellently given, emergency in slow motion. So let me talk about why the CKD is so important in diabetes. We are all aware of CKD, that renal dysfunction equal to or more than 3 months with a GFR less than 60. And if the GFR is more than 60, presence of proteinuria, hematuria, small kidneys, all of us know this. And we are also well aware of the 5 stages of chronic kidney disease. Why is it so important? Because 17% of Indians have chronic kidney disease. That's a huge number. And can you believe 2 lakh develop end-stage kidney disease and need dialysis or transplant every year? And out of these, 1 lakh people are diabetic kidney disease. It's a huge economic burden. And we all know that transplants are very costly. Apart from the high CV deaths, the people who progress to end-stage kidney disease, there are hardly any kidneys. We are doing only 15,000 transplants in India per year. We need around 2 lakh transplants. And also, dialysis also, though available, it's very, very costly. And the problem is we have drugs for renoprotection, and we also have mechanisms of renoprotection. Unfortunately, with so many webinars, seminars, CMEs going on, still we are not aware, and still the patients are progressing to end-stage kidney disease. So it's a call for attention, ladies and gentlemen. Diabetes is the leading cause of CKD in India. 40% of all CKDs because of diabetes. Our dialysis rooms are full of patients who have diabetes. So half of your diabetics will develop CKD. And diabetes is an important cause of progression to end-stage kidney disease. And not only this, CKD in diabetes increases the risk of cardiovascular deaths. The other important thing I want to highlight is we are all under Ayushman Bharat coverage. And do you realize what's happening to the fund of Ayushman Bharat? The maximum money-consuming modality is dialysis, even more than cardiovascular disease. Anything else, cardiovascular disease, we heard, is very important, an excellent lecture. But look at the cost which India is spending on maintenance of dialysis patients. And once you start dialysis, you cannot withdraw the patient from dialysis. So definitely it's an emergency in slow motion and we are still sleeping. We are not aware. Why physicians need to be aware of this? Because we are 1.4 billion Indians, just 2,500 nephrologists. So early CKD detection is the job of everyone. General practitioners, physicians, endocrinologists, cardiologists, everyone should be tuned to detect the kidney disease. Now, how can physicians control this epidemic? Just go for guideline-based management. The important thing is we all hear about it, we read about it, but when it comes to practice, still the prescriptions are not based on the guideline. All the components are not there in the prescription, and this we need to implement. So what are the practical points of these guidelines? So let us start with a patient who comes to you, type 2 diabetes, who comes to you maybe for the first time. He doesn't have any kidney symptoms at all, no swelling, urine output is fine. He's a software professional. He's a long-standing diabetic for 5 years, hypertension 3 years. He does not have any other comorbidities. He's a smoker. And you can see he's obese as well. He's hypertensive. And the unfortunate thing is that there is no urine examination available. Many of the times it's not done. And this gentleman is put on metformin, telmisartan, and glimepiride. So this is the sorry state of affairs. Many of the prescriptions are like this. Sugar medicines are given, BP medicines are given. What else needs to be done? Is this prescription adequate? No. It's important because this gentleman also, though no swelling, no urine output decrease, you have to test for kidney disease because early stages are completely asymptomatic and the screening tests are very simple. Only 2, urine albumin, and apart from that, if you don't have urine albumin, you can go for urine protein as well. Remember values, urine albumin 24 hours should be less than 30 milligram. And urine protein, if you go for the protein creatinine ratio should be less than 0.2. It's very, very, very important. You have other modalities available. You have formulas based of GFR on cystatin, creatinine, all those things. But remember, urine albumin is the primary test. And out of these GFR formula, go for the creatinine-based formula most of the times. You have it on your cell phone. Just do a creatinine and calculate the GFR. So it's a free download app. Despite discussing in so many webinars, many of the times the prescriptions still do not contain the eGFR. So this patient, though he did not have symptoms, creatinine was already 1.9, eGFR was 43, and urine albumin was 640 milligram. Too much. Remember all this, that some people only look at creatinine and eGFR and don't look at the protein. It's important to look at both because now you have non-proteinuric diabetic kidney disease, no protein at all in the urine. Still, the patient has diabetic kidney disease and it's quite common in India. So look at urine albumin and GFR, just these two. Remember doing GFR, otherwise we'll miss the early stage of kidney disease. So this gentleman, you can see he was already in advanced stage, sort of advanced stage of kidney disease with a heavy level of albuminuria, and the GFR was also low. So what do we do for this patient? First thing, this was discussed earlier lectures also, diet. The important thing is to explain to the patient, just eat healthy doesn't suffice. Vegetables and fruits can be taken in early stages of CKD. Avoid banana, maybe that's high potassium, and coconut water, but most of the other fruits can be taken in moderation. Whole grains, plant-based proteins, and low refined foods. So this we all know, and same applies for diabetic kidney disease patient as well. And ask what the patient takes generally and modify the diet accordingly. Don't give a diet which the patient won't take. Protein intake, now the new guidelines say 0.8 gram per kg. So many of the times we see the patients taking lot of keto analogs. Is it right to give or wrong to give? Remember, keto analogs are very expensive. You need to give 9 to 10 tablets per day. You can use keto analogs if you are giving a very low protein diet. Very low protein diet means 0.3 gram per kg. So hardly any protein. Those patients in very advanced CKD, keto analogs can be given. But otherwise, they are not essential in early CKD where you can give fair amount of plant protein. Most of the times, it's better to tell the vegetarians to take whatever they want. All vegetable proteins can be taken. Otherwise, in India, most of the times, once CKD, the protein is stopped. We know that balanced food looks like this. Even for a diabetic kidney patient, I have put this plate because the diet pretty much remains normal. If you avoid the animal, the red meat, if you avoid that, if you restrict your pickles, salt, and juices, the diet pretty much remains the same. Apart from telling them to restrict salt, which we tell them half teaspoon per day, tell them about pickles, papad, tell them to take a lot of other spices. You can take maybe salt-free spice, kali mirchi can be taken, so many other Indian spices can be taken, even lemon can be added if the taste is bad. Avoid soya sauce. Many of the times people go for salads and they put a lot of salad dressing on it. Tell them not to take salad dressing. Avoid processed foods. So all these things have to be told in India. Average Indian salt intake is 10 grams per day, and we need to restrict to half teaspoon per day. That's 2.5 grams. About fats also, you tell them, they say, no, we take Saffola only. Please tell them that it's not only the quality of oil, quantity is important. So half liter per person per month. So for a family of 5 members, it should be 2.5 liters per month, and they can take variety of oils, palm oil, sunflower, rice bran generally are preferred in diabetic kidney disease. Fish can be taken as a source of unsaturated fatty acids, so that's important. Butter, ghee, vanaspati should be avoided. So half liter per person per month is important. Otherwise, most Indians take 2 liter or 1 liter per person. That's too much. We also tell them about the importance of exercise. So this is important because even in diabetic kidney disease, tell them that 3 days cardio, 3 days resistance or weight training. They should not go for 2 consecutive days without exercise. Also tell them that it's better not to be prolonged sitting all the time. Avoid sitting for more than 30 minutes. Get up in between. That's important. 5-minute brisk walk adds 4 more years to a diabetic patient's life. And in addition, sleep 6 to 8 hours. So this sleep hygiene is important for a diabetic kidney disease patient as well. This patient should be advised to avoid smoking, completely avoid smoking. Blood pressure, still, despite 100 medicines, blood pressure 140/90, 150/90, no, not acceptable. 130/80. If no contraindication, even as less as 120/80 is fine in case the patient doesn't have any hypotension. It's very important. So individualize. Which drug we all know? We all hear about the RAS blockers. We know that ACE or ERBs can be used in all diabetic kidney disease patients, but few questions are there. We are giving baby doses. Telmisartan, nephroprotective doses 80 mg. In April, it is around 40 mg. We start with 5 mg, 10 mg because of fear of hyperkalemia. This is unwarranted. Hyperkalemia is not that common provided you give a proper dietary advice. It's very, very important. But remember not to combine the ACE inhibitor and ARBs. Use either one of them, whatever works for your patient. Now, the other thing is still how long we continue. Creatinine is 4, potassium is 4. Will you stop it? No. The new guidelines say you can continue using till stage 4 CKD. Till GFR of 15 also you can continue using the RAS blockade. So that's important. But before you start RAS blockade, check whether there is any renal artery stenosis, which might occur in elderly diabetics. So that's important. Always check a creatinine and potassium 15 days after you have started the RAS blocker. And if the rise is more than 30%, then you need to stop. Otherwise, minor rise in creatinine and potassium, you continue. Try to avoid potassium from the diet. After the RAS blocker, if the blood pressure is not controlled, you can add a calcium channel blocker and a diuretic. These can be used. Calcium channel blockers, you have different types. So whenever you are using amlodipine or something like that, it's better to use it along with telmisartan because that, or telmisartan or any other RAS blocker for that matter, because it reduces the proteinuria as well. The third drug of choice is a diuretic. You can use either loop or a thiazide. Thiazide is better, loop diuretic in severe renal failure. The others are added later on. Spironolactone is also a very good antihypertensive, but again, use only in resistant hypertension because the fear of hyperkalemia does exist. Later on, you can go for centrally acting blockers as well. Now, glycemic targets, maintain around 7. That's what we advise. Remember, this patient now was on all these drugs. Telmisartan, chlorthalidone, amlodipine, fine. Metformin, he was taking 1000 mg BD and glimepiride was 2 mg BD. Are we happy with this prescription? We are not happy with this prescription because if the GFR is less than 45, this patient had a GFR less than 45, reduce the dose of metformin to 500 milligram BD. That's 1 gram per day. Less than 30, you avoid it altogether, but that should be the first drug. Then about renal protection, we know SGLT2 inhibitors definitely should be given. Still, they are missing in many of the prescriptions. Till the GFR of 20, you can continue giving SGLT2 inhibitors. You can initiate SGLT2 with the GFR more than 20. If the GFR declines beyond 20, you can still continue to use them till the patient goes on dialysis. Now, trials are being done for dialysis patients as well. But as of now, once the patient goes on dialysis, we stop this. Genitourinary infections are known, but they can be handled very well with genital hygiene. And we are using SGLT2 for all our patients. It's very, very important. They reduce the blood pressure. They are smart diuretics. They reduce the renal work, reduce albuminuria, and they are cardioprotective as well, apart from causing weight loss. So excellent drugs. And any of them can be used. There is much trial evidence. So type 2 diabetic with any albuminuria, with any fall in GFR, remember to add these drugs. And this sentence is very important. If you start them on time with a GFR of 85 in a diabetic patient, you give 26 years dialysis-free life. If you were to be the patient, won't you go for it? And if you start it, if the GFR is already dropped around 2022, you still give 2 years dialysis-free life. So it's very, very important. So this patient was started on SGLT2 as well. Still, HbA1c was 7.8. So any other drug which is good glycemic control and renoprotective. So we have good evidence from flow trial about semaglutide, the injectable semaglutide weekly once. However, as of now, it's not available in India, but this would be a good drug to add in case the glycemic control is required and you need further renoprotection. Fine. So this patient, after all these therapies, still at 6 months, the creatinine is 2, stabilized, HbA1c is 7, but albuminuria is still there, 430 milligram. What else can we do? Does their prescription contain this? The next step is to add a non-steroidal mineralocorticoid receptor antagonist. This is very important. Don't use it just like that for all diabetics. Don't use it without using the RAS blockers. Use the primary therapies. But still, after all this, albuminuria is continuing. There is 30 milligram or more albuminuria. In that case, finrenone is indicated in a diabetic with kidney disease. The only problem with finrenone, what is it? Hyperkalemia. So remember to add it when the potassium is less than 5. If the GFR is between 25 to 60, for example, our patient, how much dose you give? We give 10 mg. And if the GFR is more than 60, then you can go for 20 mg. If you have started with 10 mg, check the potassium again after 1 month. If it is less than 5, you can titrate to full dose, that's 20 mg. How long can you continue? You can continue as long as the GFR falls below 15. After 15 drop, we stop finrenone. So the criteria for discontinuation is GFR less than 15 and if the potassium goes above 5.5. So this is the prescription now the patient is receiving, which has changed markedly from his original prescription. Now, anything else is missing in the prescription? Yes, add bicarbonate. Try to maintain a bicarbonate of 18. So the thing is, we see prescriptions where either the bicarbonate is added unnecessarily, the serum bicarbonate is already 22 and more bicarbonate is added, or it's not added even if the bicarbonate is very low. But remember, target 18, but if fluid overload is there or hypertension is uncontrolled, then don't use bicarb. Control those first. Fine. Is the prescription complete? Anything else we need to give? Yes. Aspirin, many of the times we find in the prescription, but it's not given for primary prevention. If any history of cardiovascular disease is there in the past, then it's indicated. We see many times febuxostat or allopurinol in prescription. Uric acid more than 9, or if the patient is symptomatic, then you give these drugs. Anemia management, if the hemoglobin is low, then we check for iron, add iron and erythropoietin. And if mineral bone disease is there, hypocalcemia, give calcium, hyperphosphatemia, give phosphate binders. If vitamin D is low, we give vitamin D, and we control the PTH by giving calcitriol. So these are mostly done by the nephrologist, but if the physician is taking care of the patient till a GFR of 30, you can do it, but check all these parameters. Don't only concentrate on the glycemic control and hypertension. Everything else is important. In addition, statin should be a part of prescription. Blanket rule, even if the cholesterol is normal, lipids are normal, all diabetics with CKD, if they are adults, even if no dyslipidemia, add statin for CV risk reduction. So remember this guideline, many of the times statins are missing in the prescription. So this, ladies and gentlemen, is a complete prescription. So in addition, tell them not to take any nephrotoxic drugs or go for unnecessary contrast studies. Refer to nephrology if the GFR keeps on falling, nephrotic proteinuria, hematuria, rapidly progressive renal failure, and no retinopathy. Otherwise, you are the best people to manage these patients. You're already using these drugs. So, ladies and gentlemen, this is the complete prescription. And I just end with a couple of photos. See, this is a dialysis unit. Can you imagine how many dialysis we are doing in Osmania per month? 3,000 above. We are doing 5 shifts. Nobody in the world is doing 5 shifts. In addition, we have 30 centers under us in all the districts of Telangana. Each center is like this, and still there are many patients waiting. 50% of all these patients are diabetic kidney disease, which we, me, you could have prevented if we had acted early, but we didn't do that. These are our transplant patients. Again, a big number are diabetic patients. We do for type 1 diabetics, we are doing pancreas kidney transplant also. We are doing type 2 diabetic nephropathy, we are doing isolated kidney transplant also. But remember again, the cost. We in a government hospital are doing free. But again, even if free, where are the kidneys? Where are the donors? As I told you, only 15,000 for 2 lakh people. So I end by saying, ladies and gentlemen, a good doctor does dialysis, a better nephrologist does transplant. What's the best nephrologist doing? Prevents the progression of patient to either dialysis or transplant. And this applies to a very good physician or a general practitioner, whatever be our specialty. Prevention is always, always better than cure. So thank you, ladies and gentlemen. This is from the Department of Nephrology, Osmania Medical College. Thanks a lot for the opportunity.
Lalit, 1 minute. I think, dear friends, big round of applause for this young girl, whom I once addressed as the daughter-in-law of Professor Vinod Sahai, my close friend, Professor B.K. Sahai. Lalit and others, he corrected me. He said, sir, you cannot call me daughter-in-law. I'm your daughter. I'm Sar's daughter. So for this great daughter of the nation, a big round of applause. Fantastic talk, as usual. And over to Lalit for discussion.
Yes, ma'am, you have left very, very important message for all of us. The essential message being diabetes is the leading cause of chronic kidney disease almost throughout the globe. And it is very important that we have to screen early to detect diabetic nephropathy, which can easily be done by a spot albumin creatinine ratio. And so far as the management is concerned, apart from the weight control, lifestyle measures like diet, exercise, etc., most important intervention that you have told is the ACE inhibitor or ARB, that too in sufficient dose, which is most important. Many times we give around 20 to 40, which is not enough. Tell me certain, has to be minimum dose, has to be 80, and we should not be afraid of. It should be given till the stage 4, but of course with monitoring of the potassium and serum creatinine. Then comes the importance of the dose of metformin. Whenever we are giving metformin to a patient of CKD, we must keep in consideration the eGFR. Once it is less than 45, the dose should not be more than 1 gram. Less than 30, it should be avoided. Then the role of the SGLT2 inhibitor. Certainly, the emergence of SGLT2 inhibitor has changed the natural history of CKD in diabetes, and it should be continued till the eGFR is 20 or till the patient is subjected to dialysis. Then about the non-steroidal MRA, Finrenon, it has also changed the natural landscape of the treatment of diabetic kidney disease. The dose should be around 10 mg per day when the GFR is between 25 to 60, and more than 60 we can go to 20. So most important is also to take care of the other factors like uric acid. We can use allopurinol if or febuxostat if the uric acid exceeds, only when it exceeds 9, and aggressive control of blood pressure is another important thing. The target should be somewhere around systolic should be 120, and if otherwise we can also keep around 130 to 80. Thank you, ma'am, very much for the information that you gave to all of us. And so any question from Dr. Das or anything?
I think my sincere appreciation as usual. Manisha's very absolutely fabulous talk. You can go to the interview now, or to the, I think Dr. Pani just, I don't know what the sequence now. Alok, Shruti, the next is the interview, or next is?
So the next is the interview.
There will be an interview about this is a complication session, and we will go for a neuroprotection in diabetes by Professor Ashok Das.
and then we'll go to the panel discussion.
Yes.
Welcome to 2025 National Update on Clinical Diabetes, NUCD 25. Today with me, one of the India's astute clinician, great teacher, scientist, and author, Professor Ashok Das. Welcome, Professor Das, to NUCD.
Thank you.
2025.
Thank you for generous introduction. Thank you.
And this time today we are going to exchange views and ask Professor Das about very basic things, that is neuropathy or neurodegeneration and how to go about that. Professor Das, diabetes definitely affects nervous system, but whether brain is more affected or the peripheral nerves are autonomic.
I think I'm extremely grateful and thankful for giving this opportunity. Neuropathy is the most important contemporary challenge as the largest complication of type 2 diabetes and type 1 diabetes also. Now, the study we concluded, like the ICMR in-depth study and the landmark study, both have shown that the neuropathy is the commonest complication. And it's also in clinical practice we see that. Now, this neuropathy, as you just now asked, Professor Alok, is two types, central and peripheral. Any day, peripheral neuropathy is more common than the central because peripheral neuropathy includes the peripheral somatic neuropathy and also peripheral autonomic neuropathy. And it has to be more in the feet, in the leg, the highest. It can minimal in the hands, and therefore it is PNS is more involved than CNS. And in the PNS, in the feet and leg, it can also affect the proximal nerves, rarely like the diabetic amyotrophy. It can produce subcutaneous transcostal neuropathy in the chest, mimicking even chest pain of a MI. So most commonly it is PNS. Central neuropathy are only two. Number one, diabetes encephalopathy and diabetes mononeuropathy of the cranial nerves. Prominent among them is the seventh nerve, which occurs more common, can be bilateral, and second is third nerve with pupillary sparing, which responds to conservative management, is vascular. And now the other peripheral neuropathy in the cranial nerves can occur. We call it mononeuropathies. If they occur together, we call it mononeuropathy multiplex or polyneuritis cranialis.
Great. As Professor Das, we know that diabetes affects the nervous system. And we also know that diabetes starts almost 10 years before its clinical diagnosis. At diagnosis, other complications may be there. We rarely find neurodegenerative problems. Is there any marker or a test that should be done early in the life of a diabetic to predict that he is going for some problem and can be prevented?
I think I'll approach this question in three ways. Primarily clinical. One is symptoms and signs. Symptoms of positive symptoms of neuropathy include tingling, numbness, needles and pins, hot and cold. And the negative symptoms is becoming numbness. This is number one symptom of diabetic peripheral somatic neuropathy. And if you want to catch them early by instrumentation, we have the monofilament, Sams-Winston 10-gram monofilament, and the biostoichiometry, where the voltage 5 to 10 is early neuropathy. Now, in contradistinction, if you want to go in for an instrumentation bigger than that, we have to use instruments like nerve conduction, etc., which do not use in the clinical practice. So clinical symptoms and signs. So signs will produce two things. Number one, loss of pain, temperature, vibration, and also very important, the ankle jerk is lost. Ankle jerk is lost, very important for the peripheral neuropathy. Now, you also asked about the markers. Now, the hardcore markers in the blood that we find is NFL, short chain, which is fine as a marker of the peripheral neuropathy. And also we find peripherin, one more protein. And third, the protein aggregation, which is becomes more in diabetic peripheral neuropathy, like A beta and A alpha beta, This two dot protein aggregation can produce peripheral neuropathy, which is only done for the experimental purposes, research purposes.
Nowadays, we find many people are suffering in India and southeastern countries that they have Alzheimer's. Alzheimer's forgetfulness is very common and at an early age. So, how diabetes is increasing that or affecting it?
I think it's a very important question because Alzheimer's and Parkinson disease and dementias are quite common in the diabetic population than the non-diabetic. Now, the explanation for this are three. It is mediated through metabolic, deranged blood glucose, and I must tell you, even peripheral neuropathy is a effect of the high blood glucose. And if you want to reverse peripheral neuropathy, control the glucose. It can be reversed early on. Now, second thing is vascular, and third is the inflammation. So this metabolic, vascular, and inflammatory alterations in diabetes can give rise to increased incidence, increased prevalence of AD, Alzheimer's disease, and PD, Parkinson disease, and dementia. So this is a very simple answer to what you asked. And if you take care of metabolic alterations, vascular alteration, inflammatory alteration, we can conquer it.
Professor Das, in the present drug armamentarium, do you think any of the drugs are helpful in achieving these goals?
I think you have asked a very important question. And today, rather than any other time, we have a drug in our armamentarium, GLP-1 RAs. Now, starting with simple liraglutide, dulaglutide, coming to latest drugs like oral semaglutide, like injectable semaglutide, like tirzepatide, and also the ritutruride, sarbituride. All these drugs, in India, we have up to oral semaglutide. All these drugs, GLP-1 RAs, do help maximally for protecting against AD and PD. Number two, I must tell you that all other anti-diabetic drugs also do help, but prominent among them are two, metformin and thiazolidinediones, like we have pioglitazone. So let us pass on the message that metformin and pioglitazone do provide neuroprotection, and of course GLP-1 RAs, which are expensive, may not be within the reach. Beyond that, I must also tell you that all other anti-diabetic drugs, through their effect on the blood glucose, are also neuroprotective. Insulin is greatly neuroprotective because it brings down the blood glucose and provides nerve growth. So insulin, maximal, other anti-diabetic drugs also produce neuroprotection.
So, in our developing countries like India, people should not be very much worried that if they cannot use GLP-1 RA, they are not protected.
Absolutely, because metformin are using from 1950s. Americans started using 1993, and today it has become the number one drug, numero uno drug. So we are using metformin. We use also thiazolidinediones, pioglitazone, and the message is, by hook or by crook, you have to conquer the blood glucose optimally. That is important. If you control optimally, they protect against AD and PD. At the same time, these three drugs, GLP-1 RA, metformin, I'm repeating again, and pioglitazone, do provide more protection. But other drugs also are important.
How high glucose, blood glucose, is affecting the nerves? Yeah. Why it is affecting so much?
I think it is very important to remember the high blood glucose usually affects the vasculature, the small vessels, and therefore the microangiopathies, be it nephro, be it retina, and now be it in the nerve. Therefore, we say the neuropathies are both metabolic and vascular. It doesn't affect because of large blood vessels. It is because of the microangiopathy. So blood glucose affects the small blood vessels. Beyond that, also this high blood glucose produces other metabolic aberrations like hypolipidemia. So hypercholesterolemia, hypertriglyceridemia, and low HDL levels do affect the scenario of neuropathy because they also contribute to neuropathy.
In our day-to-day clinical practice, we find some elderly people come, they are not Alzheimer's, but they are forgetful. Yeah. They do not remember things as they were. And on CT scan, we find lacunar infarct.
Yeah.
How do you collaborate this? And
I
what
think
is the
very
way forward?
it is very important observation. I must tell you, Alok, diabetes per se, more often diabetes with hypertension, which we say two-in-one disease. Diabetes has the best company of hypertension. They produce liquidar infarct, again a small vessel disease in the brain, and this can produce three things. One is short memory loss, number two, change in the mood, and third thing, very, very focal neurodeficit, like not able to speak, or small affections of one part of the limb or small part of the face, very focal and very small. So these are the manifestations of the microangiopathy in the brain, and this is because of the high blood glucose. Therefore, diabetic and hypertension per se can produce these ischemic strokes, which are very common in diabetic. If you take care of hypertension, take care of the blood glucose control, take care of the hyperlipidemia, they are controlled.
So
Of course, I must tell you, also, some of the new drugs has become very inexpensive because they have been available as generic now. Like SGLT2 inhibitors do also provide protection for the brain because they take care of the microangiopathy also. Therefore, these drugs have stood out. You know, the trials, IMPAREC trial, all DAPA trials, they have all shown that they provide some benefit in the fatal stroke and lot of benefits also in the non-fatal stroke. It was not very pronounced, but the benefit was there.
Because EMPA is also going to be off patent and available in a very cheaper price. It's a good news for our patients.
Yeah, but I must hasten to add, the drugs which have stood out in the forefront for neuroprotection are GLP-1 array and the gliptins. Gliptins are also good drug for the neuroprotection. And of course, metformin and thiazolidines. And the other drugs also do contribute to neuroprotection through their control of the blood glucose.
In peripheral neuropathy, a lot of people complain of problem in the feet, not in the hand that much, but usual prescription goes as methylcobalamin, pregabalin, gabapentin, like that. They are not solutions, I think. What do you think?
I'll come to the point. Now, somebody once asked me, is neuropathy reversible? Two things I want our audience to remember. Neuropathy does not affect the life per se. The longevity of Andrew Bolton always tells us it is always doesn't affect the longevity of life. The life is same as non-neuropathy. But if it develops neuropathic complications like diabetic foot, if it develops neuropathic complications like the autonomic neuropathy in the heart or in the gastrointestinal system or in the bladder, which gives cystitis, GI system, diabetic diarrhea, sudden cardiac arrest, the anesthesia-induced accidents. Am I correct, Alok? So they can shorten the. Otherwise, neuropathy per se does not. But one is to improve the quality of life. The improving quality of life, diabetic neuropathy is possible, and we have wonderful drugs in the armamentarium, starting from, now we do not use nowadays amitriptyline. We normally use SSRIs. We use drugs which, you have to take care of the cause of diabetes, cause of diabetic neuropathy, then they will be clear. Now, cause of diabetic neuropathy are three, like electrical impulses going from the nerve, can be controlled by anti-arrhythmic, anti-epileptics. Now, if the patient has got altered metabolism, by taking care of the blood glucose control. So anti-epileptic, anti-convulsant, anti-arrhythmic, these are the causes, they affect the cause of the neuropathy. Methylcobalamin, B1, B2, B6, there is some evidence for the lipoic acid and all that, but they are all supportive, not the direct effect. As you rightly said, they do not affect the cause. You are correct. But these drugs have been used by habit. They might be contributing some benefit.
Professor Das, we are experiencing younger people in India having strokes, cerebral strokes and other things, hemiplegia and paresis.
Yeah.
Is it only vascular and diabetic or anything else is there?
I think
how to prevent it?
I think there's a study by ICMR which has showed very high strokes in the West Bengal Calcutta region. There was also correlated, Professor Alok, to anemia. They said when there's less amount of blood in the body, ischemia produces havoc. Number two, hypertension. I must tell you, hypertension, which occurs in diabetes. We found in Aishabar in-depth study, the diabetic was 102 million, but the hypertensives were 385 millions. Diabetics were about 11%, but hypertension 35% are low. I want to emphasize the point. If you want to control ischemic stroke, control hypertension, control diabetes, then you can control it.
Right. Any other systemic disease can affect the nerves in a diabetic?
I think you have asked a very, very important question. There are many systemic diseases which can affect, and one has to differentially diagnose and eliminate them before coming to diabetic neuropathy. I'll give 3 examples. Say alcohol. Alcohol produces alcoholic neuropathy. Malnutrition, like lack of vitamins, can produce. It can be produced because of the entrapment syndromes, like entrapment in the hand. It can be produced because of genetic neuropathies. It can be because of hypertrophic neuropathy. So there are immunological neuropathies. It can occur because of the systemic diseases like sarcoidosis, vasculitis, SLE. It can occur in various infectious diseases which can produce neuropathy. So neuropathy causes are wide. One has to exclude all other causes before diagnosing neuropathy.
COVID has affected nerves like any other parts of the body. What is your message for that?
I must tell you that the long COVID that we are talking about, we find still people having the aches and pains and neuralgic pain. We give them symptomatic treatment. But look, one good thing, that within the course of time, this long COVID neuropathy is also improving. Long COVID encephalopathy, like they don't get unconsciousness, but they get mental haziness. You must see many patients, they get mental haziness. We are not remembering, we're suddenly becoming clogged in the brain. Mental haziness also improves. So the beauty of the long COVID, that if you give supportive treatment and assurance, they also improve in the course of time.
Right. Thank you, Professor Das. Excellent deliberations, and you have really added so many important points for clinicians and diabetologists to detect, diagnose at the early stage, and to manage it and to prevent it. So, what is your last message for the mass?
My message for the masses are very simple. Number one, neuropathy is a part and parcel of diabetes. It occurs in almost 70 to 80% cases if you take the subjective symptoms of numbness and tingling numbness and pains and needle sensation. Number two, if you go by the ankle jerk loss, positive negative symptoms, it's about 50%. It increases with the duration of diabetes. Third point, at the end of 10 years, almost 60% people have this neuropathy. This diabetic peripheral neuropathy goes pari passu with autonomic neuropathy. Therefore, please always do a autonomic function test. Very simple. Postural hypotension. Lying down blood pressure, you know it. And sitting blood pressure, standing blood pressure. Lying down and standing. If there's a drop of blood pressure, systolic 20, diastolic 10, the patient has got autonomic dysfunction. We must do a cardiac test to find out. There are 4 tests: heart rate to beat with variation, Valsalva, and 30th beat by 15th beat ratio. If it is there, you must give it this clue to anesthetist. So anesthesia-induced accidents can be prevented, and every person going on major surgery, nowadays you do autonomic for normal evaluation. Fifth point and final points, that this neuropathy is not reversible, but they're controllable. Early on, if you diagnose early on, repeating early on by doing tests, by doing the biostoichiometry, by early on symptoms, it is controllable. By controlling blood glucose, it is controllable. But later on, it is not controllable, but it is not reversible, but controllable. The quality of life you can improve because we have wonderful drugs like antiarrhythmics, anticonvulsant, and these drugs are very good, and SSRIs are next used. We don't use amitriptyline anymore. They produce change in the pain perception. There are also other methods like TENS, all that. I have used it, very useful. Final point, in the diabetics, the neurodegenerative diseases like Alzheimer's, and Parkinsonism are more common than general population. We can keep it abeyance by doing a good blood glucose control and good blood pressure control. You highlighted the small vessel disease in the brain and elsewhere in the body. They're only amenable to two things: good blood glucose control and good blood pressure control. And the drugs which can produce maximum neuroprotection are the new drugs, the GLP-1 arrays, the gliptins, of course, metformin, the king, metformin, and the thiazolidine. Thank you. Thank you, Alok.
Thank you. Thank you.
Lalit? Lalit, you can take over, Lalit. Stuti, take it out.
Yes, sir, it is done.
Yeah. So now, Lalit, please carry on the panel discussion. Very brief.
Right. Ashok bhai, you have to lead the panel. Lalit can be with you. Professor P.K. Sahu, cardiologist, will not be available because there is a patient in emergency. He has gone to the cath lab. So Professor Pratap Pani is with us. He is the famous neurosurgeon from Bangalore. And Manisha is there and you are there. So
Thank you.
either
I'll
you
very,
take
very
first.
brief panel discussion. My first question to Professor Pratap Pani. Sir, what had been your work in the Bangalore? Which hospital? Nimhans? Where in Nimhans?
No, sir. I was working in St. John's, then Sagar Hospital and Brain Hospital now. Thank you, sir.
In the neurosurgery, how do
Yeah.
you find the diabetics versus non-diabetics faring post-op?
Sir, in neurosurgery in general, you mean to say, sir?
Yes, sir.
Yeah. Definitely, sir, for diabetes, it is a lot of complication will happen. Especially if we come to the stroke, in stroke also, the treatment, I'll go detail also, in stroke, this in diabetes, it is more problematic than non-diabetic. Before that, I just want to know, in stroke is now one of the leading cause of the death in world. It is the second leading cause of death in the world. According to ICMR study, you must be knowing, sir, this is the fourth leading cause of death in India. And most important is Delhi, disability. Disability is more in stroke. So let us see how stroke happening in diabetes. I will concentrate. I have listened to your lecture. BP and diabetes, BP blood pressure is more than the diabetes. I agree with you, but at the same time, what happens, sir, in blood pressure, people used to take the medicine, all these things happen. But in case of diabetes, many times people, they don't know they are suffering from diabetes. Even if they suffer from diabetes, what they do, they measure whole night, they will not take any food, and next day will go, they will be happy that our blood sugar is within the control. This is happening, sir. It's in regular practice, it is happening. However, what happened in diabetes, what happened, how it happens, what happened, the damage of blood vessels causing stiffness and built up fatty deposit, which leads to blood clot that can be traveled to the brain and causes a stroke. This is the cause for the stroke in diabetic.
Correct.
Okay. So not only that, this is one part. Second part, what happened? It has been seen. If you suppose some persons suffer from the stroke, whether it is ischemic stroke or
thrombotic,
ischemic stroke, that is thrombotic, or vascular bleeding stroke, hemorrhagic stroke. Okay. In that case, what happened in both cases? What happened? It has been seen when there is a hypoglycemia, increases the volume of mean size lesion in diffuse weighted image by 118%. Not only that, the cerebral blood flow also decreases by 37%. What happens in case of a stroke, in a brain stroke, if will not, during stroke, it will not maintain the glucose level in the body, whether in diabetes patient, it increases the risk of the stroke complication. That is one point. So it develops, stroke developed is one of the cause diabetes. At the same time, during treatment period also, it should not be hypoglycemic also. Hypoglycemia, sir, brain
Yes,
nutrient got by glucose.
like most susceptible to glucose.
Glucose. Okay. So it should be optimized. So this is a very, very important during stroke treatment. It should be within control.
Correct.
If you are diabetic, it should be within control. At the same time, what happened in this stroke, there is a increase of glucose level also due to hormonal stress hormonal release.
Correct.
So what happened in stroke, sir, you should be optimized. If it is less, also dangerous. If it is more, also the outcome is bad.
Correct.
So there is a hand and gloves like in the stroke, and
I think you have said the crux of the issue. Optimal glycemic control is a paramount importance for the stroke, both for the medical and surgical management. And also you highlighted both hypoglycemia, hyperglycemia, especially hyperosmolar coma. You must have in the hyperosmolar coma, when the blood is very thick, then there is also chance of the deficit and including stroke, and that has to be controlled. My question to Monica next is a very important question. Monica, today there's a paradigm shift in the diabetes management. We do not only glucocentric, we're also now focused on the organ protection. So you have highlighted the organ protection by the SGLT2 inhibitors. I want little more on the Fidelio trial from the Finerenone, its organ protection potentials. If you have any experience of the organ protection potential from the FLOW trial, semaglutide, and organ protection potentials, there is also some evidence that pioglitazone also organ protects, and things like that for our audience who have joined today. Organ nephroprotection using these drugs.
So in fact, you are better qualified to answer these questions, but since you have asked me as a nephrologist, I'll give my point of view. So we were a part of the CREDENCE trial, the largest trial for SGLT2 inhibitors. And initially when the trial started, we were skeptical. We were worried like whether this, and that was in 2016 when SGLT2 were not the standard of care. So we could see a clear difference between the patients, like placebo group and the study group. We were blinded, we didn't know. So weight loss was quite significant. Sugar control was quite okay. And the rate of progression of albuminuria and GFR stabilization. So that convinced us that these drugs work. And then there was evidence from many other studies as well. There was CREDENCE trial, then we have the EMPA kidney trial, then we had the DAPA CKD trial. So in fact, as you are aware, these drugs are nephroprotective because they reduce the hyperfiltration, and that's how they contribute to organ protection. They reduce the renal work. They are some sort of anti-inflammatory molecules also, anti-fibrotic molecules also. So there are many animal studies which show these properties as well. So apart from beyond glycemic control, they have so many other effects. So they reduce the hyperfiltration. And remember, for organ protection, especially the kidney, the hyperfiltration is the major cause of progressive renal damage. And these are the drugs which beautifully block it. Now, regarding the Figaro and Fidelio trial, so Fidelio was done for kidney disease and Figaro was done for heart failure patients. And Finerenone was found to be very, very useful in both the conditions. A straight 30% reduction in renal events as well as the cardiovascular events. So definitely a very good drug to use. But the main important point is that there are some rules about Finerenone. First thing is we should not start it. It's a costly drug. We shouldn't start it upfront. We should first follow the same flow chart, meaning glycemic control, hypertension control, diet control, everything you highlighted. Then go to the drugs. RAS blockade should be the first drug. and then subsequently SGLT2 inhibitors, because now they are easily available and the generic versions are cheap, and then still not controlled. You can go for GLP-1 RA, but again, GLP-1 RA, as you rightly pointed out, as of now, we have oral semaglutide. We don't have injectable right now in India. The FLOW trial was mainly with injectable semaglutide. We were again very happy to be part of this global trial. And our center was one of the centers with a very good recruitment of patients. And again, the weight reducing property was it was there for everyone to see, apart from the renal protection and the cardio protection. So organ protection now has become very important. We are talking about the holistic approach, the 360-degree approach, not only just controlling the sugar, but using those drugs which go beyond glycemic control. So both these drugs offer this benefit, in addition to the non-steroidal MRA, as we already discussed, Finrenone. So we have lots of molecules now in our armamentarium. In earlier times, whenever the patient used to come to us, we just used to adjust the dose of RAS blockade, give them dietary advice, and we didn't know what else to do. But now you have these major molecules which can be added. And that is what we should all think of nephroprotection. In one of my slides, which has given a big impact to me as well as a nephrologist, is the SGLT2 inhibitors. The EMPA kidney has shown they delayed the dialysis by 26 years. So 26 years without dialysis, do you think it's a small amount? It's a huge number. So if you start them early, if you start them when the GFR is around 80, so normal GFR should be about 90. Most of the Indians have a GFR less than that. And diabetic Indians, kindly, if we check the GFR, the main problem what is happening is that despite all our efforts, all our combined efforts, still we are appalled to see the prescriptions coming without the RAS blockade or the inadequate dose or without the SGLT2 inhibitors. So start early is the key. We have all the drugs available, but starting early is the key. Think of nephroprotection. We should treat the patient as a whole. He is not an organ system that cardiologist sees the heart and nephrologist sees the kidney. No, the nephrologist should be aware of pro-BNP and the latest advances in cardiology. Even the cardiologist should do a urine examination. Urine examination is liquid gold. Many of the times ECG is there, echo is there, angio is there, and there is no urine examination. So the thing is, all are important. Even a gynec for that matter can't say that diabetic, I don't know anything. You should know that you have to screen for this and aim for organ protection. So that's what my answer to your question would be.
You. I think I have to have a very sensitive question, but I just want to know, because both will be available now. For the DAPA has scored maybe little more than EMPA in the cardiac protection, except for the reduced fraction. Now the EMPA is going out of patency, and we will be both EMPA and DAPA almost priced it at the same price. For a nephroprotection, we have the EMPA kidney trial, we have also DAPA kidney trial. What would be your take on that? Which one will you prefer?
Okay, so that's very practical question. So in the DAPA CKD trial, the drug was used for patients who had proteinuria and the GFR was more than 25. So in EMPA kidney trial, remember, the cutoff GFR was 20, and they showed that it could be used in patients without proteinuria as well if the GFR is less than 45. So the EMPA kidney trial, it expanded the use of SGLT2 inhibitors. Now, if you ask me, what about if both drugs can be used, if the patient fits into that criteria, what should you do, DAPA or EMPA? So as of now, the kidney trials and the kidney evidence and the KDIGO guidelines clearly state it's a class effect. Though there are many studies saying one over the other for cardio, renal, all those things, but it's a class effect. But we should remember that DAPA CKD, the cutoff GFR was 25 there, and proteinuria was mandatory. Whereas in EMPA kidney, you could go up to 20, and there no proteinuria also, you could go ahead with the drug. But as of now, guidelines, it's a class effect.
Thank you very much, Manisha. I cannot, I cannot thank you. I can only show my love and my good wishes. Thank you, Manisha.
Thank you, sir. That's appreciated. Thank you.
One more thing, sir. Can I add on, sir?
Yes, please.
Yes, sir. What happened if any stroke patient comes within 400, treatment is over, especially in ischemic stroke, the result is very good. But it has been seen, those who have diabetics, hyperglycemia, the result of giving TPA is very poor. This is seen. This is the observation by the those who are stroke specialists. This is also glucose level, especially during the treatment period. If it is high, the effectiveness TPA. Otherwise, actually 78% of the stroke are ischemic stroke. And if they come to the hospital early and treatment is over, this golden period is 4.5 hours. Especially it is seen that the TPA acts very nicely, but if patient is hyper-diabetic, the effectiveness is
I think it's a
really
great knowledge because, sir, Professor Pani, we are doing the TPA administration within a golden hour, left, right, and in the middle. We have set criteria which we have brought down. We don't go for the MRI and everything, those criteria, but we do it, and it has saved many brains. And as
yes,
I said,
yes, sir.
hyperglycemia has to be combated. Thank you
Yes.
very much, sir.
Thank you,
Dear
sir.
friends, it is now time to thank Professor Pani, thank dear Manisha, thank Professor Prashant, and thank everyone
you, sir.
who contributed in this session. And also sincere thanks to my very dear friend Lalit Meher. Professor Lalit, you would like to say last word? Lalit, are you there? If Lalit not there, thank you very much, Manisha, for this session. Bye. Over. We'll pass on to the next session. That is session 3. And I have my great pleasure to call Dr. B.D. Sahu and also to call Dr.
Dr. Sambhu Datta.
And Dr. Sambhu Datta for this session. We have 4 talks in this session. So I will start. I'll hand it over to Professor Datta and Professor B.D. Sahu.
Thank you, sir. Thank you, Professor Ashok Das, sir. I am suffering from this acute URI. I think got it from the BG hospital schedule. So my sincere pranams to my Professor Ashok sir, who was my external in my MBBS exam, and I met sir during one of that clinical trial in Chennai. And in fact, sir was rushing to Pondicherry, and I had to rush. And after many years, I met sir. And in fact, today in Vizag steel plant, the physician, a friend of mine, Professor Naveen Kumar, HOD steel plant, he was also telling that how can you chair a session when Professor, our guru, is talking, and his MD examination exam at JIPMER, he did DNB in JIPMER. So sir was the...
I remember Naveen tell him.
Yes, sir. Thanks, sir. Thank you, sir. So we'll proceed with that, sir. So can we, sir, can you know who is talking first, sir?
Yeah, Dakshata. Dakshata is the first talk. Invite Dakshata. I think her the things has come on the right.
Yeah,
and
yes, sir.
you can just ask her to speak. Dakshata is, if you do not know her, I'll tell you, this is a young girl of a high repute and great mastery over diabetes. She had her undergraduation, but she had got a diploma diabetes, a full-time 2-year program, and has excelled in the patient care, teaching, and research in this field.
Thank you, Dakshata ma'am. Now, basically, you will be talking on insulin. I know that you'll be talking about insulin, which conventionally we use basal bolus for all uncontrolled. But here we'll be talking about a prandial a bolus insulin, which will prove as good as giving basal bolus. So in our OPD practice, we generally, whenever we go to insulin, we give a basal plus regimen, and we are very successful in that. And well, it is uncontrolled, then we give basal bolus. Of course, till few years back, we are practicing Nucd, and in fact, the famous Professor Ashok Das sir was there in that advisory group in that JAPI journal. We used to that for our. Still, we are using because we are resource
2009, we wrote
yes,
that.
Sir, yes, sir. But still gradually as the glargine price reduced, and we are still using little bit of Nucd, but mostly. But today it will be very interesting and very eye-opening topic that we will be using a fast-acting insulin like Fias and in a day-to-day type 2 diabetes control. So over to ma'am. In case my co-chair...
Start.
Dr. B.D. Sahu, sir, 2 lines.
Yes.
And topic for Dakshata is early insulin intensification with insulin aspart. Dakshata will speak after BD Sahu speaks for 2 minutes.
Good afternoon, everybody. Am I audible, sir?
Yes, 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 sir.
Actually, onset, I give my sincere thanks to Dr. Alok Kanungo, the founder and director of the Kids Multi-Specialty Hospital, and the Kanungo Diabetes Center for giving me this opportunity to chair this session. You must be knowing that Dr. Alok Kanungo is the great son of the great person, Padma Shri, Dr. Vinod Kanungo, the eminent freedom fighter and the educationist, and who has written the first encyclopedia in Odia, the Gyan Mandal. I also thank Professor Ashok Das and Professor Jayant Panda for organizing this mega conference. So now first coming to this session has 4 topics. Modern therapeutic approaches in diabetes management. In this session, we have got first topic, the early insulin intensification with insulin aspart by Dr. Dakshata Padya. Next, advancing metabolic care with fixed drug combination of SGLT2 inhibitor, DPP4 inhibitor, and metformin by Dr. Jagjit Singh Wasir. Third is glucocentricity still matters in diabetic care by Dr. S.K. Sharma. Next, pioglitazone, a comprehensive approach to type 2 diabetes mellitus and metabolic health by Dr. Ashok Das. So now I first request Madam Dr. Dakshata Padya to start his topic.
Hello everyone. At the outset, my apologies to Team NUCD for not being present physically. So my topic given today to me is early insulin intensification with insulin aspart, and why does it matter? Okay, so I'm going to start with Wikipedia study. It is the study which gives the importance of metabolic coma. After 44 years, we still see there is just 1% reduction in HbA1c can reduce lower extremity amputations by 43%, microvascular diseases by 37%, heart failure 16%, stroke 12%. So even after study is being stopped, 20-year study duration, and post non-intervention period for 10 years is still showing improvement in glycemic control to reduce the risk of complication. This itself signifies how much it is important to control HbA1c in the initial period of diabetes. Now let's talk about something in over-basalization. What is over-basalization? It is the titration of basal insulin beyond an appropriate dose. So to achieve glycemic control, when we are giving once a day basal insulin, we are very much reluctant to start the bolus insulins, which are the multiple daily doses, multiple pricks. What do we do? Basal insulin doses increase further after fasting plasma glucose. Yeah, fasting plasma glucose is achieved, A1C is not in control, and postprandial is on the higher side. So rather than adding any new insulin, we keep on increasing the basal insulin. And in that process, what happens? Basal insulin dose exceeds 0.5 unit per kg per day. Post-meal sugar is remaining consistently above 180, and A1C is not at all at the goal. And bedtime and morning difference is between more than 50 milligram%. Now, more patients achieve A1C target by adhering to postprandial target. We all know if fasting plasma glucose is under control, but still A1C is not under control. So fasting plasma glucose is controlled in 64% of the patient and not in 36% of the patient. Still A1C is not controlled, but A1C will be controlled if your postprandial glucose is more or less than or equal to 140. So it is very much crucial that control of postprandial hyperglycemia for achieving HbA1c. As focused and clinical diabetologists, we all agree with this. Now, how do we intensify basal insulin? Basal alone monotherapy is not working. So what are the options for intensification of insulin therapy? We can give basal plus insulin. We can give basal bolus regimen. We can give premix in either twice daily or thrice daily pattern. Now, this timely intensification of basal insulin is absolutely critical for maintenance of sustained glycemic control and prevention of progression of adverse metabolic effects, so there has to be a stepwise intensification. It has to match the physiological pancreatic insulin delivery. It should be patient friendly, and it should have better safety and flexibility as well. So when do we stop titrating basal and go on adding prandial insulin? What is the current opinion? So A1C target is with 0.5 unit per kg per day is not achieved, you add prandial insulin. A1C goals despite normal fasting plasma glucose with basal insulin is not achieved, you add prandial insulin. And if your targeted postprandial level is persistently above 180 or 200, you definitely add prandial insulin. Now, how do we sequentially add prandial insulin, that is aspart, to one or more meals? Definitely, it is going to improve the glycemic control. Now, 75% of the patients on basal insulin, they fail to achieve glycemic control within 1 year, which shows that the need of early prandial insulin is absolutely, should be taken care of. When do we intensify? Basal alone fails to achieve glycemic control within 1 year. You may need to add an intensified treatment. When do we do it? If it is more than 1 year, if dose is exceeding more than 0.5 unit per kg, suppose patient is 60 kg weight, if the basal dose 30 units alone is not able to control A1C, please add prandial insulin. Now, what are the differences between when we give bolus insulin? Which bolus insulin has to be chosen, whether it is rapid acting insulin or regular human insulin? Now, let's see the differences. With onset of action, regular insulin, it is less rapid acting and short lasting, definitely. But we need to match the so more rapid acting insulin will be definitely appreciated. In human insulin, there is a risk of postprandial delayed hypoglycemia. With rapid acting insulin, less postprandial hypoglycemia, we all know that. CKD, the safety is definitely better with rapid acting insulin. Mealtime compatibility, it can be taken just 15 to 20 minutes before. No, they don't have to wait for 30 minutes to 45 minutes. Then consistency at different anatomical sites, whether it is abdomen or thigh, everything, everywhere it is same. There is a less variability and in the PKPD profile as well. And when we are comparing basal plus and premix insulins are associated definitely with weight gain and hypoglycemia. With basal plus, there is definitely flexibility. The regimen is favorable for patients who have, irregular meal pattern, business class patient, type 1 children. Basal plus definitely will be more appreciated. Premix insulin are very much not, adapting to individuals' lifestyle. And in terms of specific glycemic needs, here there is a lot of treatment satisfaction with basal plus bolus, and prandial intensification can be done in a customized fashion. Now, this is one study in which clinical efficacy and safety of insulin aspart compared with regular human insulin in patients with type 1 and type 2 diabetes. This is a systemic review and meta-analysis which showed that the group on rapid-acting insulin experienced less nocturnal hypoglycemia, and the severity of the intensity of severe hypoglycemia incidence was almost similar in both the groups. Now, this is a study with a huge subject number, more than 3,000 hospitalized patients from 136 centers in India. IV insulin aspart was studied in hospital settings, in which the patient profile was both type 1 and type 2 patients were added. Treatment naive patients, DKA patients, perioperative patient, infection patient, all the category patients were added. Indian HCP preference was they expressed a preference to use aspart insulin in future post-study. The reasons were rapid achievement of target blood glucose, safety profile, and then when patient gets discharged, before getting discharged, the shifting from IV to subcutaneous route in case of aspart was very, very smooth. So definitely it is effective and well-tolerated option with less hypoglycemia. Now, what kind of insulin errors happen in the hospital? prescribing error, dispensing error. Barring that, administration error, it can be communication of the concentrated insulin doses. There is a poor coordination between insulin and the meals and the glucose monitoring. Then you have to have specific protocols. If you lack that, definitely there is going to be a problem. Risk assessment to identify hypoglycemia, hyperglycemia, you need good training. Injection techniques need to be monitored. Wrong patient, wrong insulin, sometimes wrong dose, wrong glucose values. So this covers poor coordination of insulin with meals and glucose monitoring. So lack of protocols are going to cause a lot of problems in this therapy. Now, insulin aspart in hospital ward settings. Rapid acting insulin analog is ideal definitely for managing hyperglycemia in hospital ward setting because it has a quick onset, quick control, short duration of action. Maybe then the risk of hypoglycemia will be lesser and effective for controlling postprandial glucose, which is very much crucial for controlling infection and other emergencies. What does ADA recommend? They recommend the scheduled subcutaneous insulin regimen, including basal nutritional correctional components. Over sliding scale insulin alone in non-critical settings. Aspart integrates well into this regimen and it fulfills all the criteria. Clinical efficacy shows that subcutaneous aspart is an effective and safe in intravenous setting in DKA, including suitability for acute settings as well. Endocrine Society also supports the rapid acting analog like insulin aspart for achieving better glycemic control in hospitalized patients. Now, when we are looking at insulin aspart versus regular human insulin intravenous in post-cardiac surgery, safety of intravenous aspart compared to regular human insulin in patients undergoing ICU monitoring post-cardiac surgery is very much. The subject size was around 203. 103 patients were on aspart, and rapid acting human insulin, almost 100 patients were there. Endpoints were the side effects and serious side effects and hypoglycemia during hospitalization. And the key results were there was reduction of hypoglycemic episodes, nocturnal hypoglycemia, and switching from IV to subcutaneous dose was very much smooth for aspart. Time for insulin infusion withheld was significantly less in aspart, which is better recovery from hypoglycemic episodes. This is very important. If you have to withhold insulin infusion, that means patient is heading towards life-threatening hypoglycemia. So this time overall for withholding IV insulin infusion was very much clinically less in aspart patients. Now, what about diabetic ketoacidosis? This is something which we are always where we want insulin, which is as much similar to physiological human insulin. So, as there was definitely estimated cost effectiveness of subcutaneous insulin aspart in the management of mild ketoacidosis among children. Now, in this group, there was mean reduction of 16 hours, which was statistically significant in the hospital stay. Imagine a patient has to stay for lesser time in the hospital for ketoacidosis. That is going to cause less trauma to that patient compared to other group of patients. The cost was also the subcutaneous cost was around more than $1,000 compared to $1,600 for human insulin. So it was absolutely cost effective and safe in diabetic ketoacidosis children with diabetic ketoacidosis. Now, this therapy in managing diabetes with kidney disease, this is also one more area where we have to be very, very careful. You can easily give these patients in peritoneal dialysis where A1C reduction without significant hypoglycemia patients were managed absolutely easily. No dose adjustment is required in CKD patients. No significant pharmacokinetic changes in severe renal insufficiency as well, which makes it very, very safe molecule. In preconception pregnancy period, you can use this molecule, and in type 1 patients and pregnant patients with type 1, the safety is already established. Liver disease patient, it doesn't change the pharmacokinetics of insulin in any hepatic impairment, maintains stable and pharmacokinetic parameters across varying degrees of liver impairment. So it can be given safely in liver patients, hepatic impairment patients. Now, what about using this insulin in insulin pump? So closed loop hybrid pump on the adults with type 1 diabetes is definitely showed modest improvement in overall sugar control. The TIR was much better. 1.9% difference in TIR with aspart was observed. So this is a molecule which was launched in 1999. We have a safety data and efficacy data of last 25 years. These are broad label indications: type 1, all age and group; type 2, pregnancy, it is very much safe for GDM and pre-existing diabetes. Elderly patient, renal patient, hepatic impairment patient, you can give it with safety profile. DK patients, insulin pump, these are the broad label indication where the safety and efficacy is already established. Now, when we are comparing with new generation insulin, with this 25 years of legacy effect, similar 2 hours postprandial glucose reduction was observed, and there is no significant difference in severe hypoglycemia when we are comparing with new generation insulins. Now, when we are talking about the originator insulin and the recombinant insulin aspart, conclusion is extensive biological characterization demonstrates a high degree of functional similarity between the biosimilar with innovator product, and immunogenicity is similar, comparable. There is no increase in immunogenicity, and there is no impact on biological activity of insulin. This is the phase 3 clinical study design, biosimilar insulin aspart. The aim is to compare the efficacy and safety of recombinant insulin aspart to adult patient with diabetes mellitus. And the results have shown that it is comparable between 2 treatment arms with significant decrease in the HbA1c from baseline to week 12 and baseline to week 24. Now, in this phase 3 clinical study design, biosimilar insulin aspart and innovator were comparable and equally effective in lowering A1C, fasting plasma glucose, and postprandial glucose as well. Now, what is the impact of biosimilar aspart on the diabetes management in India? Let's see what is the scenario in India? It is absolutely cost effective. Here, there is local production of biosimilar insulin aspart, so cost effectiveness is established. There is a strategic importance as it reduces the dependence on imports, ensuring the steady supply, which is very, very important for even rural area and remote areas. Lower cost and increased availability facilitates the timely insulin initiation and the adherence as well. So finally, decreasing micro and macrovascular complications. Now, the success of biosimilar insulin production motivates further R&D and creating new ecosystem. So self-reliance, less dependent, and make in India initiative. Thank you so much. And with that, my apologies to the team NUCD once again. I couldn't be here physically on the virtual platform. Thank you so much.
Thank you, Dr. Dakshita Beda Madam, for your elaboration regarding the early intensification with insulin aspart. Next, we'll go to the next topic, advancing metabolic care with fixed drug combination of SGLT2 inhibitors, DPP4 inhibitors, and metformin by Dr. Jagjit Singh Vasir. Dr. Jagjit Singh Vasir is the Director, Division of Diabetes and Endocrinology, Medanta Medicity Hospital. He has done his medical training from the prestigious Institute of AIMS and Maulana Azad Medical College and University College of Medical Sciences. He is a new age metabolic physician with core experts and excellence in all forms of diabetes, including managing the very complex and complicated patient profile like post-transplant diabetes, obesity, thyroid disorders, PCOS, fatty liver disease, lipid and cholesterol disorders, insulin resistance, and metabolic syndrome. Added with recent strategic center for obesity professional education certification by the World Obesity Federation. Pursuing his passion for clinical teaching, he has successfully mentored young doctors and diabetic educators as teaching faculty and course director through the certification course in evidence-based diabetes management THFI and advanced certificate course in prevention and management of diabetes and cardiovascular diseases. So now I request Dr. Jagdish Singh Vasir to start, please.
Thank you very much, sir, for the kind introduction. So I'll just share my screen. Are the slides visible?
Yes, sir, absolutely.
Okay,
Yes, yes.
thank you. Thank you very much. A very good afternoon, dear friends and colleagues. So we change gears here where we heard very elegantly about using insulins in the management of diabetes. We change gears onto the oral therapy for type 2 diabetes with a special reflection or discussion about fixed drug combinations of three drugs, including a SGLT2, a DPP4, and metformin, and see how relevant it is in our day-to-day practice to achieve good glycemic control. We all understand why are we having sessions on diabetes, very well understanding that type 2 diabetes has become a pandemic with not just one country, it's the entire globe, which is with with the explosive increase in the occurrence of diabetes and its complications. And the very famous and often quoted the ICMR INDIAB study, these are projections for metabolic diseases in India. And I'm very sure, and all of us agree with the fact that there is an underrepresentation of the actual occurrence of diabetes and or its complications. Now, for a physician, what is very important is not just one part of it, which is diabetes, it is coexistence of all of these risk factors finally culminating into the reason why we treat diabetes is prevention of complications of diabetes. So with this base in mind, in the fact of importance of the prevalence of diabetes, the aggregation of multiple risk factors in our patients with diabetes, and addressing this holistically to decrease the occurrence of complications being the core efforts for managing diabetes. We all understand, and the very basis of treating diabetes with the landmark trials, the UKPDS, the Accord, the Advance, the VADT, and the Steno-2 trial indicating a early aggressive management, including glycemic control and addressing multiple risk factors, is the only way forward in reducing the complications of diabetes, with the microvascular complications being reduced in the short term. And once we maintain the legacy of good glycemic control and address the multiple risk factors, we're able to reduce the occurrence of macrovascular complications, the most important being cardiovascular and renal complications. So whenever we start treatment of diabetes, there are a few guiding principles, or there are a few ways where we can address the growing menace of diabetes and uncontrolled diabetes. One is to address the multiple pathophysiological factors behind diabetes or hyperglycemia. That's one approach. Secondly, very simply, this point indicates that to prevent the complications of diabetes, we need to address the A, B, C, and O. A being HbA1c, B blood pressure, C cholesterol, and O is obesity or weight management or best weight for health. Only when we address these four targets, and it is actually not just addressing them, it is agreed to target these four things, can we tell our patients, yes, we are giving you the best protection for prevention of complications? And we also need to address the collateral damage associated with the more traditional therapies like sulfonylureas or insulin, while being aggressive in managing diabetes, is the chances of hypoglycemia and or weight gain. So all of these put together is the kind of thing we have to do day in and day out while addressing type 2 diabetes. Now, for a moment, let's just think about a patient. What does the patient actually desire? All these things have a kind of more of a medical background in it. So my strong view about this, the patient's desire is a convenient treatment, a comfortable treatment, a safe treatment, a durable treatment, which ensures glycemic control and prevention of complications, of which the first two, the convenience and comfort part, are very important for the patients. Now, with this background, let's dwell on the relevance, the effectiveness, and the safety of fixed drug combinations of these three drugs with the Indian perspective. While using these drugs together, including the SGLT2 inhibitors, a DPP4, and metformin, all together, as we can see here, the next slide makes it much easier that these three drugs, co-use of these drugs, addresses virtually all of the pathophysiological defects, whether it's insulin secretion, the incretin effect, the hepatic glucose production, lipolysis, glucagon secretion, the renal part of glucose reabsorption. All of these put together are would be addressed by a combination of these three drugs. Very simply, if we were to explain this very combination to a patient, I would at times tell them that 1, 1, and 1, where these are the three drugs, total to 111, not 3. They basically are multiplying the benefits of using these drugs together in not just providing good glycemic control, but going beyond glycemic control in helping in weight loss, providing a major protection to the organs with the simplicity, the comfort, convenience, and the added safety of using these combinations together. Well, it's more of a recent thing using combinations. Earlier on, the Diabetes Association kind of distanced themselves by endorsing using the combinations. But over the decades, be it the ADA, our own RSSDI, or the ACE, all endorse even starting therapy of type 2 diabetes with combinations, especially so when the patients have very poor glycemic control above the targets or at a high risk for either atherosclerotic cardiovascular disease, heart failure, diabetic kidney disease, which is more or less, all patients with diabetes. That's very, very clear. So the endorsement is there, and we have a wealth of scientific evidence, again, indicating that early aggressive therapy using combinations leads to a better, not just a better glycemic control, a better legacy of glycemic control, a better metabolic memory, and better chances of protection of the organs. People who are started or patients who are started on these combination therapy, there would be a greater delay in requiring intensification of therapy and or requirement of insulin later on. So that's the kind of scientific evidence we're talking about by the early usage of combination therapy while treating type 2 diabetes. So various fixed drug combinations which are available, including the one we're talking about, a combination of SGLT2 inhibitor, a DPP4, metformin, where the SGLT2 inhibitor usually would be dapagliflozin, a DPP4 would usually be sitagliptin or vildagliptin, and metformin is already there. So let's very briefly look at the current evidence, and very proudly, I'll very briefly discuss data generated from our own country. So the last speaker did talk about made in India, the insulin biosimilars. So similar on the same lines, we talk about our own data about the relevance, the safety, or the effectiveness of this particular FTC in our patients. The first study I'll briefly be talking about is the MESIDA trial. It's a multicentric, randomized, double-blind, active controlled phase 3 study where about 300 adult patients with type 2 diabetes were divided into two groups, followed up over a period of 16 weeks, with the primary endpoint was to demonstrate efficacy, the safety of using a combination of dapagliflozin, sitagliptin, and metformin at the end of 16 weeks. The secondary endpoints being other glycemic parameters like fasting, postprandial, effects on body weight, and other safety aspects of these particular drugs. This is the basic study design. And at the end of 16 weeks, as we can see here in the green, very significant 1 point, nearing 1.5 reduction in the A1C. And so I am more concerned about the triple drug combination. And when compared, obviously, with a dual drug therapy, there was a 1% reduction. But this is the very point where a single pill having dapagliflozin, sitagliptin, and metformin together. So here you have a lesser pill burden, the comfort, convenience of consuming it once a day with the super results of a 1.45% reduction in the A1C in a very short period of 16 weeks. That's that's an excellent 5-star result of for any drug used in diabetes. Similar results of reduction with the triple therapy in their fasting blood glucose levels, their postprandial blood glucose levels. So in conclusions, the authors suggested and proved over 16 weeks using a combination of a single pill led to an excellent A1C reduction, which translated into better fasting and postprandial blood glucose levels, no significant safety concerns, with an added benefit of weight reduction, overall reducing the cardiovascular risk in this particular group of patients with type 2 diabetes. The second study was had a similar approach of patients who were inadequately controlled on metformin monotherapy. So DAPA, CETA, and metformin combo, that is a single tablet of 10, 100, and 1000. Again, similar time period of 16 weeks, the outcomes being A1C, the fasting postprandial, the weight, and in addition to that, proportion of patients achieving an A1C of less than 7% were the benchmark or the outcome parameters of this study. Very importantly, you see the retention rate here. Almost all the patients, they started on 137, 132. Excellent retention of the patients. Kudos to the investigating team to have such good retention rate for the patients. The primary endpoint, like in the last study, we saw 1.45 reduction in A1C. Here we had a 1.72% reduction in the A1C with a combination of DAPA, CETA, and metformin. And fasting postprandial, obviously with such a great reduction in the A1C, we expect a very significant reduction in both the fasting and the postprandial levels. And when we look at the pathophysiological ways in these drugs are acting, so we have drugs which are acting on the preferentially on the fasting levels, the incretin-based therapies, which have an extra benefit on reducing the postprandial blood glucose excursions. So a composite translates into a better A1C globally in tune of nearing 2% in these patients. So about 55% of these patients achieved an A1C of 7%, less than 7%. And obviously, along with the safety aspect, with just genital tract infections happening more in those patients being given SGLT2 inhibitors, with that extra benefit of weight loss, reducing their overall cardiovascular risk. The third study, again, in similar lines to the previous one in type 2 diabetes with uncontrolled on metformin, similar follow-up, but in addition to that, there were 3 arms. They were randomized into 1:1 ratio with sitametformin, and dapametformin, giving us a greater comparison of using these drugs in various combinations. Endpoint again being 16 weeks, and the benchmark being A1C reduction. A1C reduction with a triple drug FDC, again ranging nearing 2% of less than 1.73 reduction over 16 weeks. And believe me, 16 weeks is actually a very small, short period indicating the potency or the 1 plus 1 plus 1 leading to 111 effect on the efficacy of these tablets, very well tolerated, and the largest percentage of patients achieved A1C less than 7% as compared to the other 2 drug combinations at the end of 16 weeks. A very brief reflection on the other DPP-4 inhibitor, a retrospective study of vildagliptin, dapagliflozin, and metformin combination, including about 30,000 plus patients who were retrospectively studied with a duration of diabetes anywhere in between 5 to 10 years, poor glycemic control, most of them ranging in between 7 and 9%. There was again a very significant drop in their A1Cs over a period of time, with most of them averaging around 1.5 percentage reduction in the A1C, and large number of patients achieved a good glycemic control. And as the rule goes, greater the starting A1C, greater would be the reduction at the end of a study. Here, with those who had a A1C more than 9, there was a nearing 2% fall in their A1C. The weight loss, mainly being contributed to by the SGLT2 inhibitor, was very impressive at 6 months, ranging approximately 4.3%. And here we can see the distribution, with nearing 25% of patients actually losing more than 5 kgs of weight. And greater the weight loss, greater is the global cardiovascular risk reduction in these group of patients. This was more of a physician-based, opinion-based consensus done on fixed drug combination, through which, indications which are also endorsed, which I presented earlier, be it the RSSDI, the ADA, the ACE. So those patients who have very significant uncontrolled blood glucose levels and high risk for atherosclerotic cardiovascular disease, heart failure, or CKD are the candidates in which a fixed drug combination right at the initiation not just provides effective control of their blood glucose, but provides the comfort, convenience to the patient, which directly is related to greater durability of the treatment, greater chances of them persisting with the treatment. So a meta-analysis of all the trials done with the FDC in our country is now presented here. Again, a repetition, low pill burden, improved patient compliance, definitely adding on to the economic advantage of using a FDC, which would be cheaper than using the individual components separately. Low risk of side effects. All these 3 group of drugs carry an excellent safety profile, along with effective management of their blood glucose levels. So all these studies, which I have presented earlier, are summarized in this meta-analysis, indicating the FDC being far superior to using these separate drugs, either sequentially or in different combinations, in providing an excellent A1C control, excellent fasting blood glucose control, excellent postprandial control, either weight neutrality or weight loss happening with this group of combinations. When these particular combinations, durability is the other part of the diabetes. So 2-year follow-up data of about 170 patients. They maintain their glycemic control, as we can see here. They achieved a good glycemic control, which was maintained up to a period of 2 years. Here we can see the initial fall along with durable maintenance of their glycemic control. The the hepatic and the renal protection, again coming from a reduction in their SGPT, their urine protein creatinine ratio reduced and stayed reduced over a period of 2 years, again substantiating the Indian aspect or the Indian perspective of using these drugs for a safe, effective, durable glycemic control, along with reduction in their overall their cardiovascular risk by weight reduction, hepatic and renal protection being provided by these combinations. So with this, I would like to end today's presentation with a key of initiating, of providing our patients with early on intensive glycemic control wherever required or appropriate by using these combinations of SGLT2 inhibitor with a DPP4 inhibitor and metformin all put together, providing our patients with comfort, convenience, translating into better glycemic control, which is durably maintained, the added benefit of blood pressure lowering being contributed to by the SGLT2 inhibitors, and renal, hepatic, and cardiac protection being provided by all of these together. I thank all of you for your kind listening.
Thank you, sir.
Thank you, Professor Vasis, for your excellent presentation regarding fixed drug combination. Actually, it is very helpful and also it is patient becomes very compliant by this fixed drug combinations and side effects are very low. So
I think I must add that both the presentations we had by Dakhyata and by Dr. Washir, my dear friend, was absolutely fabulous. Thank you, Washir. I was watching absolutely. I'll be using some of your slides in my talk also. Fantastic. Now I am also here to welcome my very close and very dear friend Surenderji, Dr. Surender Sharma, and I over to the chairpersons. I just came, Surinder, to personally welcome you, and I'll be entirely listening to you. Thank you. Please carry on.
Thank you, sir.
Please carry on.
Okay, sir. Our next topic is glucocentricity still matters in diabetes care, which will be spoken by Professor S.K. Sharma. He is DM Endocrinology from PGI Chandigarh, Consultant Endocrinologist, Galaxy Specialty Center, Jaipur. He is the past Professor Medicine, Mahatma Gandhi Institute of Medical Sciences, 26 research publication in index journals, the chairperson, Diabetic Welfare Society, chairman, Diabetes, Thyroid, Endocrine Conference, regional faculty, awarded oration of Vijayawada Balmanch Diabetes on 2012, awarded oration RSGI 6th and 7th February 2016. At Jodhpur, awarded oration Dr. Naresh BHU on 2016, awarded Times of India Rajasthan Health Award Endocrinology in 2013. So I now request Professor S.K. Sharma to start his topic. Glucocentricity still matters in diabetic care.
I also invite our dear friend Dr. Sharma for this meeting and welcome Dr. Sharma for this 2025 NUCD.
It's Thank you, sir. It's always a pleasure to be with all the stalwarts, Dr. Das, Dr. Kanungo, and all the friends. So, dear friends, today I am going to speak on a slightly controversial subject. I am taking you back. Now we were all talking about organ protection, but I will be taking you back and looking into what is our primary object of looking into glycemic control in our diabetic patients. So I think I should be sharing my slides. Can you see my slides?
Not yet.
Yes.
Yes.
Okay. So may I make them full screen? So
Yes.
are they changing?
Yes, sir.
Okay. So dear friends, my talk will be regarding glucocentricity. Once we say diabetes, the definition of diabetes is that it is a condition which is characterized by chronic hyperglycemia. So glycemia is there right from the beginning, or you can say in the definition of diabetes. So there are 4 important vital signs like temperature, pulse, blood pressure, and respiratory rate. But now I will be highlighting that 5th vital sign should be a glucose level in our patients, because we know that if the patient is having impaired glucose tolerance or high glucose, then the chances of subsequent development of diabetes or subsequent development of mortality will be higher, increased chances of disease control, disease complications. So why it is important to look at glycemia? There are several observational studies that have shown the prevalence of hyperglycemia in patients even without diagnosis of diabetes, or there is no history of diabetes before a hospital admission. So there are 32 to 38% patients in community hospital who are having high glucose. 44% patients are having heart failure with high glucose. 41% critically ill patients who are having high glucose, and 80% of patients in cardiac surgery will be having high glucose. And it is should be considered as a 5th vital sign in our day-to-day practice. We all know that during COVID pandemic, there were suggestions that if the patient is admitted in hospital and his blood glucose is very high, more than 126, the chances of cardiovascular, or you can say COVID death, will be higher in these patients. There are so many other studies linking high glucose to associated morbidity and mortality. These are those studies. So once we say hyperglycemia, we all know that it is because of 8 pathophysiological defects, which was highlighted by Dr. D. Franjo. And we all know that diabetes develops gradually with insulin resistance and decrease in glucose, decrease in insulin secretion from beta cell. So during the early phase, while the glucose intolerance is developing, macrovascular complications are still there because of obesity, dyslipidemia, hypertension. But most of the time, microvascular complications start developing once a patient is diagnosed with diabetes, and we say that now the glucose profile is in the range of diabetic range. So we have to look at evolving treatment approaches where we say that we have to prevent micro and macrovascular complications. Early glycemic control is very, very important to retard the development of complications. Comprehensive management, not only glucose, but also risk factor like hypertension, dyslipidemia, obesity, and smoking is to be done. And it is a multidisciplinary approach. So why glucose control slipped under the radar? So we all know that earlier we were talking about anyhow control hyperglycemia, but then we realized that these patients will develop hypos and weight gain. So we considered that 2 aspects again. And then, of course, cardiovascular risk factors were there. And we know that diabetic patients are dying mainly because of cardiovascular disease. And that's why we looked into those risk factors. After cardiovascular outcome trial, we realized that few group of drugs like SGLT2 inhibitors and GLP-1 receptor agonists are organ protective drugs. And that's why now all the emphasis was shifted to organ protection. So there was a shift in the management after 2018 ADA-ASD guidelines. Then emphasis was done on cardiorenal protection with the help of SGLT2 and GLP-1 receptor agonist. And then people were saying that you should use these drugs independent of glucose lowering therapy, because, and you can also use them in non-diabetic patients. So once you look into impact of this cardiovascular outcome trial, you find that there is a great paradigm shift with these drugs. But the important point is that in most of these CVOT outcome trials, the patients were of long duration of diabetes and they were having multiple cardiovascular risk factors. So these findings cannot be, you can say implemented on those patients who are newly diagnosed or having short duration of diabetes and not suffering from pre-existing atherosclerotic cardiovascular events. That's why we say that glycemic control as a part of holistic multifactorial risk factor management is required so that we can minimize the complication and premature mortality. It should be personalized, evidence-based, and cost-effective, and therapeutic strategies in the form of intensive glucose lowering is important, and we should avoid inertia in uptitrating the doses and bringing in combination of therapy. So combination therapy is now a you can say important concept of treating our type 2 diabetic patient. And one of the study like verify randomized control trial tell us that if you combine metformin with DPP4 inhibitor like vildagliptin, you will delay the treatment escalation in these patients. So multifactorial risk factors are to be looked into, what we say ABC control, where A stands for A1C, B for blood pressure, and C for cholesterol control. And we have a landmark study by the name of Standard 2 trial, which showed that multifactorial intensive intervention will lead to reduction in both microvascular and macrovascular complications in our patients. And glycemic management is still a pillar in the management of our diabetic patients. To reduce the diabetic complications, we say we have to have good control of glucose with addition to blood pressure control, lipid control, and of course, if the patient requires and if the patient is having those atherosclerotic cardiovascular risk factors or atherosclerotic cardiovascular disease, of course, we will be using those organ protecting drugs like SGLT2 or GLP-1 receptor agonist. Glucose is important because we all know right from the days of DCCT and the UKPDS that if you reduce HbA1c, you have significant uh, outcome. So there you find 12% reduction in diabetes-related endpoint if you reduce the HbA1c by 1%. There is a 25% reduction in microvascular endpoint, and of course, even macrovascular complication like myocardial infarction was reduced by 16%. And of course, in long duration of these studies, retinopathy and albuminuria was reduced once we have good control of hyperglycemia. So most of our patients are uncontrolled. They are having a HbA1c of 9 or more. So we have to go for multiple drug use to control hyperglycemia. So glucose centricity do matter, and these are the evidences. One evidence is UKPDS. We have clear-cut evidences that if we are using metformin, sulfonylurea, or insulin and achieving tighter control, there is definite reduction in the microvascular and to some extent macrovascular complications. Another important thing is that delaying the control of hyperglycemia is always bad. So here you can see this line suggests that these are the patients who are having a HbA1c well controlled, intensively treated, and they achieve good control within a period of 1 year, and then they were followed for a period of 5 years. And these are the this line, second line is suggesting these are the patients who are not able to control HbA1c below 7 in first year. And we see that those who are uncontrolled in 1 year are having huge amount of myocardial infarction, stroke, heart failure, and composite cardiovascular events. So it indicates that if you are not able to control hyperglycemia early, then patient is accumulating the dysglycemic legacy, and this drives the complication in our diabetic patients. Other study was Discover study, where they looked into to achieve HbA1c below 7 in patients, and then these patients are followed for a period of 3 years, and you find that those who were able to intensify the therapy, able to achieve good control early as compared to those who are not able to achieve good intensification in the early part of their natural history. Intensive A1C control also reduces A1C with, you find here, nephropathy like new onset microalbuminuria, new onset worsening of nephropathy, or new onset microalbuminuria in accord. So UKPDS, accord, and advanced studies are telling us that if we control hyperglycemia, we can retard the progression of kidney disease. Nowadays, we are using more and more of CGMS, and we know that we want the time in range, that is the blood glucose between 70 to 180 milligram should be more than 70% in a day. So patients should spend at least 17 hours a day in this range of 70 to 180 milligram. But if the time in range is reduced, we find that there is a 64% increased risk of retinopathy in our type 1 diabetic patients and 40% increased risk of microalbuminuria in our diabetic patients. So glucose control is important. In type 2 diabetic patients also, we see 25% increased risk of peripheral neuropathy if the time in range is reduced by 10%. There is, of course, a minor, you can say, differences here as regards cardiovascular mortality of 5% and all-cause mortality of 8%, which is increasing once we are having time in range which is reduced by 10%. So we all know that glycemic goals are not similar. If the patient is having short duration of diabetes, low risk of hypoglycemia, and he is having no vascular events or no comorbidities, we will try to go for tighter control. If, on the other hand, if the patient is having long duration of diabetes, more chances of developing hypos or having comorbidities, we will be relaxing the HbA1c target to 7.5 or even 8 in many of our patients. So now looking into cardiovascular outcome trial and comparing them to glucose controlled trials, you find that in cardiovascular outcome trials, patients were having long duration of diabetes, they were having shorter duration of trial, they were having macrovascular or microvascular complication on board as compared to those patients who are given a intensive glucose lowering trials. So in these trials, we know that DPP-4 inhibitors in cardiovascular outcome trial was telling us that they are neutral, but SGLT2 and GLP-1 receptor agonists are cardiorenal, showing cardiorenal benefits. So learning from this cardiovascular outcome, we know that these patients are definitely benefited. But the important thing is we can't ignore glucose level. So in addition to these drugs, we have to give uh, anti-diabetic, or you can say glucose lowering drugs in addition to SGLT2 or GLP-1, because in many of these trials, these drugs were already used. So intensive glucose reduces cardiovascular disease, retinopathy, nephropathy. Definitely microvascular complications are significantly reduced, and they are associated with legacy effect. If you control glucose early, there is a good legacy as compared to the bad legacy where the patient is having uncontrolled hyperglycemia and therapeutic inertia is there, then it will lead to more problems. In that regard, controlling hyperglycemia in the background of a sulfonylurea therapy is also important, because many times we see that people try to avoid this sulfonylurea. Now we are using second generation, or you can say that's newer sulfonylurea like glibenclamide. So sulfonylureas are very effectively reducing HbA1c to a tune of 1 to 2%, and newer sulfonylureas are having less chances of weight gain and hypoglycemia. So glimepiride was tried in large number of clinical studies, particularly if you look at Carolina, it tells that glimepiride is having same cardiovascular safety as linagliptin. In GRADE study also they were using glimepiride, and in UKPDS 91 again sulfonylureas were used and showing their effectiveness. So in patients who are in Indian context say that we have these drugs which are safe and smart, they are economical, and most important thing is that they are very potent in reducing hyperglycemia in our patients. So we say that there should be 4 A's. A means appropriate, available, affordable, and accessible. So clinicians are assured about the cardiovascular safety of glimepiride, and we all know that these are the economical drugs, so they are patient friendly. recommendations are that we should try to achieve glucose control as early as possible. These are the ADA 2025 guidelines. Of course, they say that stratify our patients, whether they are having atherosclerotic cardiovascular disease or heart failure or CKD. But on the extreme right, we also know that to control hyperglycemia, we have different group of drugs, very high potent drugs, which are reducing HbA1c to a tune of 2.5 or so. And then, of course, high potency like sulfonylurea and other old anti-diabetic drugs. So that we have to use them. So, dear friends, in the end, we will say challenges are there. Current state of hyperglycemia is there. Large number of our patients are suboptimally treated. Goal is to achieve early glucose control and maintain the glucose control. We have to look at safe and effective glucose lowering drugs, managing these patients in such a way that we can also provide cardiorenal protection, and holistic and personalized management is required in addition to lifestyle and diet and exercise. We have to give combination of drugs, and many of our patients are on combination therapy. On one hand, we are targeting glucose level, and on other hand, if required, we are giving these organ protective drugs instead, in addition to those glucose lowering drugs. So I think I should stop here. Thank you very much, Dr. Anungo again.
Thank you, sir. Yeah, thank you, sir. It was an excellent talk, actually. And this actually opens a lot of our eyes that because of a CBOT trial popularity and other things, we had for a time we are shifting. Most of the CMEs were only on the SGLT2 inhibitors or GLP-1s. Now that we know that, and most of you have shown very clearly that long-term glucose control definitely will go and do all the better things like which the newer drugs are telling. In fact, Professor Ashok Das sir also will be talking about a drug which was almost going to be forgotten, but again coming back in a great way. So definitely, in fact, I also had a question to the previous speaker sir also, that in the triple drug combination, as which Professor Das sir, Ashok Das sir will be speaking, that can we add in place of metformin pioglitazone?
I think we'll
And
come
one
to that,
SGLT2
Dr.
that
We'll
will
come to
come.
that
Yes,
in the panel
sir.
discussion.
Yes, sir. Yes, sir.
Panel discussion. We'll come back
Yes,
to
sir.
that.
Thank you, sir.
So, dear friends, we have a very short presentation on the pioglitazone. Can I just share my slides? Yes. Dear friends, why we are making this presentation? As our chairperson very beautifully pointed out, this drug has staged a great comeback. And you have heard in this meeting itself that pioglitazone has been praised for its property on the hepatic fat, pancreatic fat, and also the renal fat. And this is beautiful to produce the amelioration of diabetes. Dear friends, you'll also find that pioglitazone has a lot of other benefits which are not available in many of the drugs. So that's why. So we are going to speak the broader. We are taking very broader view of implications of the metabolic health of pioglitazone. Next slide. Next slide, please. Next slide, please. Next slide. Now, this is what Dr. Washir also projected. This is the metabolic map of India. Diabetes is not a single disease. I was sitting in Bangalore next to Professor Abdul Kalam Azad in a meeting about a dear president, the best president we had. And at the end of the meeting, he asked me, is diabetes a disease or a syndrome? You will agree with me from this metabolic map of India. You see, diabetes only 102 million. Look at the hypertension, 315 million. Dysglycemia, 326 million. The hyperlipidemia is about 185. Hypercholesterolemia, 213. Obesity, 300 plus. So therefore, diabetes is a syndrome. We need drugs not only for the glycemia, not only for the heart and kidney. We need a broader view, a broader view to manage diabetes mellitus. Next slide shows in the graphical form, Indian map, that you have diabetes only 11.4%, but we have pre-diabetes more than that, 15%. And do you have any drug which also takes care of this if you give to diabetics? Can it also prevent diabetes from occurring? Next slide. That's the broader view that we'll describe today. Dear friends, type 2 diabetes, let us see the pathophysiology. I'll highlight three things because I have to save time. Number one, insulin resistance on the receptor is the number one on the cell surface. This receptor gives rise to the compensatory increase in the insulin production and secretion, but ultimately it fails at certain point, beta cells, and there is accelerated beta cell destruction because of the compensatory increased hypertrophy. There is a damage, decrease in insulin secretion, and then the pancreatic beta cells are effete or emptied, and we give rise to the insulin resistance plus inadequate secretion, giving rise to type 2 diabetes mellitus. So we're looking at a drug which can take care of this basic insulin resistance, which is starting point of type 2 diabetes. Next slide. Dear friends, you have to go a little fast to think. Now, if you look at the insulin resistance, I'll highlight only 3 points: lipodystrophy, lipotoxicity, inflammation. There are 3 important causes of insulin resistance. It occurs in overweight people, and we found in the beginning talk itself, 82% of our diabetics are either overweight or obese. There is oxidative stress, glucotoxicity, and so what takes care of this IR? Now, what does it produce? It produces stroke, atherosclerosis, CKD, and diabetic obesity. It produces important fatty liver disease, and today it is most important disease standing out. It produces LDL, HDL fractional disturbance, chronic inflammatory state. Do we have a drug, cheaper drug, which can take care of the chronic inflammation? That drug is pioglitazone. And lipid metabolism alteration. Dear friends, so any effective insulin resistance on the type 2 diabetes mellitus. Next slide. It shows, next slide, please. It shows that, type 2, no, previous slide. That type 2 diabetes and NASH, I'll repeat again, type 2 diabetes and NASH are both the consequences of IR. So if you want to treat the cause of type 2 diabetes mellitus, we have to treat IR. And insulin resistance contributes to NASH and to type 2 diabetes mellitus. And it is a very important complication, sometimes not recognized. NASH is not recognized. Next slide. Next slide shows the benefit of oral and hypoglycemic drugs, which Surinder beautifully spoke about. We have major drugs. We have details a bit to save time. Biguanides targets insulin resistance, but it targets mainly hepatic insulin resistance. But the insulin sensitizer, please mark the difference. Insulin sensitizer, that is thiazolidine and pioglitazone, it targets the adipocytes. Please remember, it targets the adipocytes and the muscle insulin resistance. So we need a drug which can take care of the adipocytes and muscle IR. Next one shows, next one, Stuti, next one. No, next one shows that next one. Now it shows that if you look at the metformin works through AMPK, reduces fatty acid synthesis, lowers SBRS1 level, decreases liver glucose production, while increases muscle glucose intake, which is good. Next slide. However, if you come thiazolidine, it activates PPAR gamma. It also activates AMPK. I'll come to a minute. It in the adipocytes, not in the liver, improving insulin secretion, insulin sensitivity by promoting fat cell differentiation. That is very important. We want fat cell differentiation. Discussing it since morning. We want adipocyte hypertrophy to be retained, not to hypertrophy. We want the redistribution of the fat where it will be metabolically more appropriate, and it reduces lipolysis and altering the adipokine level, lowering TN alpha and leptin, which is not done by the metformin. This leads to better fat storage, proper fat storage, and lower FFA. Next slide shows a differential analysis. Only 2 slides have brought metformin plus pioglitazone. Next slide. If you look at the differential, metformin versus pioglitazone as insulin sensitizer. Look at the slides. There's a statistical difference between the treatment groups in favor of pioglitazone because it increases insulin sensitivity as assessed by HOMA-S. It increases by 0.005 at the end of 32 weeks of study endpoint. So, dear friend, there's been a study which was done comparing PIO with MET, and PIO has scored above MET. Next slide. Now, if you look at the pioglitazone, which reduces the insulin resistance, there's a very famous study, all of you must have heard, called IRIS study. This IRIS study stored in 3,900 patients with recent ischemic stroke or TIA with no history of diabetes, but they had history of ischemic stroke and TIA. They found, but FPG was normal. HOMA-IR score was more than 3, were randomly assigned to pioglitazone or placebo. After 1 year, the mean HOMA-IR resistance, insulin resistance declined by 24%, in contradistinction to 7% in the people who are on placebo. So even in normal subjects, pioglitazone promotes reduction in the HOMA-IR. Next. So therefore, it's a great drug for the resistance. Now, what are its effects on the heart? Number one, it decreases the persistent auricular fibrillation after catheter ablation. It increases sinus rhythm preservation and reablation rate, but it decreases the 30% the auricular fibrillation risk from a meta-analysis. If you do the neurohormonal activation, you will find it decreases the BNP level, but some studies have shown increases BNP, NT-proBNP, which are the heart failure markers. Therefore, you will find that I'll putting a slide in heart failure. We do not want to use this drug because it's inconclusive. There is increased renin, aldosterone, adiponectin. It on the remodeling, it has similar effect. There is no worsening, no benefit. Now, if you look at the ischemia in the after STEMI, it decreases the infarct size and decreases reperfusion. But there are some signals that it may increase arrhythmias and myocardial perfusion. In the LV function, there's a clear-cut benefit. Systolic and diastolic dysfunction increases in both diabetics and non-diabetics. Now, in the metabolism, it decreases glucose uptake and increases fatty acid uptake. So therefore, its effect has got some salutary effect on the heart and also the muscle. Next slide shows that if you look at the global epidemiology today, the disease which has stand out very eminently is the muscle. Now, 436 million of people with type 2 diabetes. Just imagine, just look at this part of it. 65% of them have MASH. So 65% of type 2 diabetes patients have MASH. 41% have significant fibrosis and 15% advanced fibrosis. Look, this is a clinical gastro-hepato paper. 65% MASH, 40% significant fibrosis, 15% advanced fibrosis. What drug we have to treat this? Next slide. The drug we have in the armament, next slide please. We have in the armamentarium to treat this NASH or what we call NAFLD. You look at this. If for the fibrosis, this stratification, this is FIB4 parameter. FIB4 here is less than 1.3, indeterminate between 1.2 to 2.6. In the high risk FIB4, it is more than 2.67. Now you find if you want to treat all the three, consider that reduces liver fat. Number one, pioglitazone. Consider strongly in the FIB2 is the reduces NASH, pioglitazone. Strongly consider that reduces NASH again, even the advanced stage, pioglitazone. Of course, GLP-1 RA, which is not available in our country and beyond the reach of many people because it's very, very costly. So pioglitazone, the number one drug for the various stages of FIB4 trial. And you know, what it gives, it continues the glycemic benefit, which my friend Surinder spoke about. There's a benefit on the NASH and also continues the glycemic benefit and may continue the fever fibrosis. Next slide. Next slide. So therefore, there are 4 distinct benefits of pioglitazone today. Decreasing insulin resistance, decreasing fibrosis, decreasing lipid concentration, and decreasing inflammation. The vast majority of the meta-analysis have proven that pioglitazone is both safe and effective in treating patients with NASH, even in those who have significant advanced fibrosis. Those 15%. Next slide. Next slide shows very important issue that the liver enzymes, the AST, ALT significantly decrease after pio. Next slide. Next slide. And you know, there is also a systematic review and network analysis with a comparative efficacy of pharmacological therapy of fibrosis improvement and resolution of NASH. Meta-analysis 26 trial with 5,000 patients and 23 interventions. Follow-up duration of about 24 to almost 2 years. Primary outcome, at least 1 or more stage improvement in the fibrosis. Secondary outcome, is the NAS resolution. See which drug did this one-stage reduction fibrosis and NAS resolution. Next slide. Next slide shows that particular drug was pioglitazone. It was found that odds of having at least one stage improvement in fibrosis, primary outcome, was significantly in those patients who were receiving pioglitazone. And secondary outcome of NAS resolution was in those patients who got vitamin E post pioglitazone, is superior to placebo. Next. Now, efficacy in preventing diabetes. Dear friends, I'll be very brief, but I have put you the stories. Why I am telling pioglitazone is a wonder drug which you should use in appropriate cases. Second point about the prevention of diabetes. I'll be very brief. Second slide, this slide. Act Now study. Please have the next slide. Next slide. Now, it is the Act Now study. Objective was to examine whether PIO can reduce the risk of type 2 diabetes in adults with impaired glucose intolerance. 602 patients. Study method was PIO versus placebo, randomized double-blind placebo control, follow-up for 2.4 years. Fasting glucose was measured quarterly, and oral glucose tolerance test was performed annually. It's a very old study. Primary outcome was development of diabetes. Next slide. Next slide. Next slide. Clearly shows, see at the graph how they have separated. During a median follow-up of 2.4 years, diabetes developed in 50, almost 1/6 of the patients of 300 patients in the placebo group, 16.7%, and only in 15 of the 300 patients in the PIO group, showing distinctly that there is an important effect of PIO in versus placebo, where after months of randomization, the development of diabetes was much lower compared to placebo. The annual average incidence of diabetes calculated on the basis of the person years was 7.6% in the placebo group, is only 2% in the PIO group. So definitely prevents pre-diabetes diabetes. Next study, also follow-up study. Next slide. A diabetes outcome progression study. You might have heard about this study. ADOPT study. It was an international multi-center study. It was by another thiazolidine, not pioglitazone, but rosiglitazone. The ADOPT study also showed that this drug, another glitazone, demonstrated superior durability of glycemic control compared to other medications. That was Surinder talking about. We don't want only glycemic efficacy, we want glycemic durability. So that was also provided by the PIO, same group of drug. Next. Next, please. Now, there is also efficacy in renal protection. I think Manisha did refer to the nephroprotection by this particular drug. Expression of the PPAR gamma is in kidneys are there, and this expression of PPAR gamma in the kidney accounts for the renal benefit. Next slide. Next slide. And if you look at the albuminuria, which she was referring very, very prominently, that is a significant decrease in the urinary protein excretion. Those who had proteinuria, low dose pioglitazone is effective, safe, and inexpensive method of reducing proteinuria in type 2 diabetic patients having nephropathy. Next. Next. Now, this is one thing which I must discuss, that there was some signals that it can produce bladder cancer. To make a long story short, today we use only, except for 2 weeks, it has been cleared and it has been shown, next slide, that there is no evidence of any bladder cancer so far. The pharmacovigilance group, next slide, it has been shown that if you use this drug in a low dose, today we advocate 7.5 milligram, not even 15, 30, or 45. Low dose pioglitazone could improve the efficacy, safety, reduce the side effect of the minimum, suggesting that low dose might be the optimal dose. So the Government of India guideline today has said, give it 7.5 milligram freely, take away the patients who have history of bladder cancer or signals, or those who have hematuria, which is unexplained. Don't give them. And it has been safe drug, advocated by the Ministry of Health, and used plenty in our country for the type 2 diabetes and the NASH. This low dose also have less adverse effect on the weight gain, on the edema and heart failure, which are also ascribed to this drug. But when we give 7.5 milligram, which is standard today, there is less weight gain, almost minimal edema, and heart failure is much, much less. So we do not use this drug beyond class 3, class 4. Next. There are a few contraindications like type 1 diabetes because it needs insulin for its action, and the initiation therapy in patients with established NIVH class 3 or class 4. I told you that contraindication of using class 3, class 4 heart failure. The symptomatic heart failure, any stage 1 to 4, you don't use this drug. any evidence of fluid overload, and if there's active or current bladder cancer. I've already discussed about this, and of course, advanced liver disease, or there is a pregnancy. We don't use this drug. Next. So, what are the future recommendations? Now, future recommendations for pioglitazone is its use as alone or in combination. There are two combinations. Next slide. It combinations with the next slide, please. Next slide. It's combination with DPP-4 and with insulin. Next slide. I'll save time. Next slide. Now, it has been shown pio plus DPP-4 versus pio alone monotherapy. It has been compared in type 2 diabetes. Next slide depicts that. Next slide depicts when it is compared, DPP-4 pio OD given once daily significantly and sustained improvement of the glycemic control from baseline compared to pio alone, and combination therapy associated with the 0.61% reduction in HbA1c, as well as a higher propensity in achieving the target. Therefore, the combinations of pio and DPP-4 is available. They are also held as a very good drug. Next. And also it has been used in insulin combination therapy. Next slide. So this drug has been used in insulin with enhancing glycemic control, started low dose, and those who receive insulin, person going to start insulin therapy, but already receive pioglitazone, those should be reduced. We reduce the dose of pioglitazone when there's insulin in the combination. Next. Safety of long-term use of pioglitazone, the last slide. Safety of the long-term use of pioglitazone. Next slide. If you look at this safety, next slide, it has been shown. Next slide, please. It has been shown that that resolution of NASH in the increase in 1 point improvement in the NASH, 1 point improvement in the changing score, and mean change in score, you find both in primary outcome, the 2-point reduction in the NASH in two categories. Compared to placebo, the pioglitazone is almost same to same. Long-term pioglitazone treatment is safe and effective as placebo in patients with pre-diabetes or type 2 diabetes or NASH. In fact, I'll end by giving the concept that pre-diabetes, type 2 diabetes, and NASH are there. That's what Krishna said in the morning, are a continuum. Pre-diabetes, type 2 diabetes, and NASH. And we have recognized, luckily, NASH today as a great, you found 65% having NASH as a great combination syndemic of diabetes. It's a syndemic of diabetes and NASH. So pre-diabetes, diabetes, and NASH are a continuum. Next slide. And therefore, this drug today has a major cardiovascular outcome. It reduces MASH. It reduces MASH in various studies between 23%, 26%, and in various RCTs. Next slide. Next slide. And reduces the event by 53%. Go to the last slide. I'll save time. Next. Next. There are definitely, one has to be careful about this adverse effects like edema and weight gain. Lower dose doesn't have it. If there is a severe weight gain, we normally stop the drug. Bone fracture in elderly women, that has been also highlighted. It can be combated by carefulness and calcium, but one has to be aware about it. Bladder cancer spoke about it. In people like it produce edema in the periphery, it can produce macular edema in few people. So it has to be kept in mind. And once we stop the drug, it reverses. And of course, because of dilution, there is anemia. Next slide. Next slide. Next. I think I won't go to the edema. I'll stop here and we will pass on to the panel discussion. Suffice it to mention that pioglitazone today has got a re-life because of its glycemic efficacy, because of its efficacy in producing good blood glucose control when two drugs existent and is not yet producing the effect. Third thing, it is cardiac friendly. It has got a lot of benefits on the fat. That is a major effect on the various types of fat, epicardial, epipancreatic, and fat anywhere, fat in the liver. It is a wonderful drug, and the continuum of pre-diabetes to diabetes. It can prevent pre-diabetes going to diabetes, and type 2 diabetes having 65-70% NASH. It can prevent, it can cure NASH when we give pioglitazone. Dear friend, thank you very much for a very patient hearing.
Thank you.
Thank you, sir.
Excellent deliberation on pioglitazone, which is a very important molecule.
Yes.
And we have started using it frequently, even in 15 milligram dose, and people are safe, feeling better. It fits into a gap which was not achieved by any other molecule.
Earlier. Absolutely.
Equivalent resistance that is handled by pioglitazone is
Marvelous.
beyond comparison. It is fabulous. And by adding one pioglitazone, euglycemia is also achieved very well. So thank you very much for your talk. Now we have a panel discussion, and for this panel discussion, Dakshata is not there. I will invite Dr. Sankha Sen, who is
Shankar
a
joined
board
already. Welcome, Dr. Shankar.
Thank you, sir. I'm already joined. Thank you.
Yes, and he is a consultant physician at Siliguri, Maharaja Agrasen Hospital, and Basu's Clinic in Siliguri. He is an astute clinician.
He is the king of Siliguri.
No, no, sir, nothing like that.
Oh, come on. I have seen you. Next.
And Dr. Alok, sir, Dr. Alok Modi is also there in the
Oh,
panel. I
really?
saw.
Good, good, good.
If we need more faculty, we can
You
invite
can
him.
call Alok Modi. Please call. Alok from Mumbai, from the Koivalli Hospital. He is Alok. Please join. Alok, please join. We're here for
Join.
set.
Alok, join.
Join.
Yeah,
Join. Yes,
you
Alok.
joined?
Yes, Shankar is here. Alok is joining.
Yeah, Alok has joined. Stuti, you can bring him to the panel.
It's okay.
Alok
Thank
Modi,
you.
I'll introduce Alok Modi in my own way. So it is our conference, so very brief. Alok is the, many of you do not know, Alok is the classmate of Shashank Joshi. I'll repeat again, is the classmate and batchmate giant of Shashank Joshi. And you know, he had been very dedicatedly working in his Kaibale hospital. He has his own chosen field. Where are you, Alok? You are not joining yet. Alok? जन क्या कर दिया तुमने बताया नहीं उनको?
Sir, he has a delegate link, so he is among the delegates. I'm sending him the link.
We will upgrade him. Now we have, he works in AI. He also works in the virtual reality. In fact, I have seen his presentations he made just to demonstrate to me how he uses ChatGPT. He's very advanced. He is the presiding officer of the AI Society of India and Excel. Let us start the question answer to save time. He will join. So I think we can start the call. I will give it. Yes, start.
Before we start, I'll tell Dr. Sheshadri told pioglitazone as differentious molecule.
Yes.
So,
Yes.
yeah.
I'll work upon it. The thing you heard, the diffronjo gives a combination of GLP-1 array, metformin, pioglitazone, always, and one more molecule to all the 4 drug combination in the beginning. Correct. You are correct. Next.
Can we start?
Yes, please.
Yes, sir. Yes, sir.
Please start.
So it's specially designed modern therapeutic approaches for diabetes. We are thankful to USB Pharmaceutical for sponsoring this session, and our speakers, our faculties have done very well. And unfortunately, the quota is not available. And I'd like to Jasjit, you highlighted the goodness or greatness of fixed dose combination and how it is working both in metabolic field and glucocentric approach.
Can I come very briefly? Hello, can I come in? Now this paper with Dakshata, 3 papers he cited. Out of 2 papers, I have been the author. Now we have written very clearly, FDC is a gift of India joined to the whole country. I told you about this also. Like we gifted metformin to the whole country, like we gifted, 4 things we have gifted. Universal testing for GDM, like we gifted the most comfortable diagnosis criteria of DIPSI for GDM. FDC is a gift of India to the abroad country. I must tell you, Sambhu, that what happens that when you give FDC, there are 3 C benefit. There's the greatest compliance, first C. There's the greatest convenience, and cost comes down. In the 3 combination, drug cost
True, sir.
come down 53%. Cost comes down. Therefore, and now this combination is being used in Colombo, I mean in Sri Lanka, in United Kingdom, and of course in USA. So this is our gift to the world, triple drug combination. I must make it clear, I should not talk too much, that beyond 3 drugs, Government of India has not allowed. The 4 drug combination, Alok is not allowed. We can go up to 3 drugs. 4th drug they don't allow. That is the time to go to insulin. Therefore, 3 drug combination, triple combination stood out well. I'll make another one small comment in favor of my friend, Dr. Surender S.K. Sharma. Now, you see the reduction in HbA1c of the gliptins of the SGLT2/4 is between 0.6 to 0.8 or maximum 1. Am I correct?
Yes.
Maximum 1. But whereas we did a glycemic efficacy, the reduction between with the metformin, sulfonylurea, and metformin plus sulfonylurea is 2, 1.5 to 2, even up to 2.5, like insulin. And final point before I close my speaking is that, we have coined a term for this sulfonylurea's benefit. We call it glucose smart, cardio safe. Why glucose smart? Nobody brings down the glucose to 2.5. Am I correct, Shankar?
Yes.
No single drug and 2.5.
Definitely.
Glucose smart drug. Why cardio safe? I think Surinder showed that slide. When it is combined to linagliptin glimepiride compared to linagliptin, it was at par or even little better. So, dear friends, I think Dr. Over to Jayant and Alok to carry out. Please, we can have one question.
Thank you for that very important piece of information. And rightly you have told our approach in when we are using OAD, what we should prioritize and how we should go about. Over to Alok sir for further moderating.
My question was to Dr. Jasjit. Could you hear that, Jasjit? Are you there?
Dr. Alok has joined, sir. You can ask him. Dr. Alok, this is...
a very good afternoon to everybody.
Yeah.
Alok, in your absence, I introduced you. The only thing I didn't tell you that Dr. Mishes Modi is a very famous obstetrician and busy 24/7 round the clock. Yes, Alok. Question you can ask. You can ask the question, Alok, and Professor Modi will answer that.
Yeah, and this for Alok, this session is modern therapeutic approaches, and then we have discussed about all the new therapies like insulin aspart, the metformin SGL2 inhibitor DPP4 FDC, and the glucocentric approach as well as the
pioglitazone.
So first of all, a very warm regards and good afternoon to all the stalwarts over here. And so thank you very much for the opportunity for inviting me here. My humble regards to Alok sir, Jen Panda sir, Ashok sir, my dear friend Shankar, and Shambhu sir, warm regards to all of you.
Thank you, sir.
Can I ask questions? If there are no questions said, I have got 1 or 2 questions to ask. Can I start?
Yes, sir.
I think that in spite of best of the efforts, there is a difficulty and there is a delay in the insulin adoption. That is Government of India's concern that we still have this adoption. Alone insulin in 22% maximum, and insulin with OHA about 33%. So that is the insulin adoption as alone insulin, or as you say, the BITS therapy, bedtime insulin, daytime sulfonylurea, as a combination therapy in about 33-34% cases. My simple question is that, do we combine the insulin in the double drug combination and the triple drug combination?
Yeah.
Alok, please tell. Or Jayant, you tell.
Yeah. Actually, this approach has become almost a cocktail now. So there, we try with drugs of different mechanism of action and try to achieve our glycemic control. The sole aim is to achieve the glycemic control, and depending on what remains uncontrolled in the patient, it's a postprandial hyperglycemia, it's a fasting hyperglycemia, the patient is reluctant for the insulin, or patient is not able to control diet. So those all
considerations we can take. And here, making cocktail with 2 drugs insulin, 1 drug insulin, or even more than 2 drugs insulin also acceptable, which we have done in permutation and combination and got good A1C and good control. So what you have raised, sir,
I
very
think
wisely.
that's a great answer that you gave. Now, the issue is that when you say triple drug combination and to say that you have reached at the maximum combination therapy, there is one caveat. My friend Sushil Jindal from Bhopal, he has given a small clarification. He said, sir, when you say 3 drugs do not work, change over to insulin, you say that one of the drugs must be sulfonylurea, which Surendra spoke about. Like we have hypertension resistant, one of the drug must be diuretic. Alok, resistant hypertension, 3 drugs, one must be. So he has put that idea. We have put that idea in the print. Let us see the reaction. Number 2, when you are giving insulin, as John beautifully pointed out, we give it antipotal time. If evening we are giving tablet, we give morning insulin. Morning we are giving tablet, we giving insulin 1 dose in. So that is quite safe, and we have used it left, right, and the middle. Of course, with little bit of carefulness, and it works wonderfully well. And if it does not work, then you have to stop and go over to whatever you want to do. I mean, you are still mixture has a place, and still, of course, basal bolus, basal plus, or what Dakshata presented, multiple aspart also being used. Thank you.
Sir, I have one submission, sir. In most most of the OPD practices, especially nowadays, we are we are using FDCs. Most common FDCs, at least in Visakhapatnam, is, I can say, that metformin, voglibose, and glimepiride. It is most common combination which comes. Along with that, patient has got CKD risk or cardiorenal risk, CRM, which nowadays we are terming CKM or CRM. We are using dapagliflozin, and on that we are using basal insulin, 10 units or so. So practically many patients are on 4 OHA plus basal insulin, and we are managing quite well. And very rarely we get problem.
Yeah, I get your point, Soma. We, in the landmark study, there are 633 investigators across the country. What you said is true. Even though we said 3 is maximum, people use 4 and 5, and the investigators said that 4 and 5 sometimes helps them, what you were saying. But sometimes it also may not help them. So there is nothing, no harm in trying. So 4th drug also people are using and getting benefit. I agree with you.
There should be some scientific opinion in this platform, which should, that this is doable and this is not doable. So we should clear.
I think if you want, listen, I'll just tell you. All over the globe, there is a ban, not a ban. They have said that 3 oral anti-diabetic drugs are enough. If they are failing, it is go to insulin time. Now, if you are not getting benefit from the combination, which you see out of the 3 combination is said, glimepiride is very efficient. Other combination said metformin very efficient. About the voglibose, the efficiency is time bound. It is only 0.6, and also at the cost of lot of GI effect. And if you give voglibose 3.3 milligram, it is still more. So in that case, I always change over and I put on a SGLT2 inhibitor in place of voglibose. That's personal. So I think we should stick to our recommendations of 3 drugs.
Yeah, then that makes a sense, because when we are combining, we are taking drugs of different mechanism of action. So that intercepts the pathogenetic cause of diabetes at different level. So they have advocated that 3 is optimal to intervene, but unfortunately in India, to achieve the goal, we even add the 4th drug, a 5th drug, and go on titrating without adding insulin or without increasing the dose, which is not acceptable at times. So that makes a sense, and at the end of the day, our aim is to achieve a good glycemic control. That's what the same old aim of management is still exists.
I think GLD, glucose lowering, as you rightly said, Jayant, glucose lowering antidiabetics are our bread and butter, jam, and whatever you call it. We have to use it as you rightly said, very, very efficiently by various permutation combinations. Let us confine to three as per the recommendations. I like to listen from Shankar his opinion about multiple
Yeah.
things.
Thank you, sir. I was waiting for this opportunity. Thank you, Alok sir, Ashok sir, dear friend Alok, and definitely Panda sir, whom I frequently invite, but he doesn't come to meet us. But
No, he does
definitely.
not look at the lesser mortals. He looks at only high people.
Every weekend he has 3-4 meetings. No, he only excludes my place. Okay. Anyway, it's just a joke. Don't worry. So, what is the important point is of this particular panel discussion? What I get to know is very important for us who are practicing in the comparatively peripheral setups. So, what is important is we need a initial glucocentric approach, then definitely with all the additive benefits which you can give to our patients. But it's not like that. What we get patients who get referred to us, or the patients ultimately who are not comfortable with their previous treatment, the treatment is not working or so, when they reach us in the second tier, what it happens is we get to see that patient is looking in, the concept has changed to such a way that in the periphery, that using sulfonylurea is something a crime. The pharmaceutical industry and everything has make it a huge hue and cry in such a way that only SGLT2 inhibitor, DPP4 inhibitor, and metformin are working, nothing else. So when these patients are coming with an HbA1c of around 9 to 10, even then the patient glimepiride hasn't been used. Or we have seen patients who was previously well controlled on a glimepiride of 2, 3, or 4 milligram, which you can safely prescribe, has been deprescribed. So glimepiride has been taken off while adding a third molecule of an SGLT2
I
inhibitor.
agree with that.
I completely disagree with this concept, and probably from our platforms or academic platforms, we should give a message. It's not like that when DP4 inhibitors are available since 2006 or SGLT2 inhibitors are available from 2009-10. It's not like that. A sulfonylurea, which is the best efficacy, should be withdrawn. We should try with the
Shankada,
sulfonylurea. Sir, just 1 minute. We should try with an sulfonylurea to its maximum tolerable dose along with other molecules like metformin initially. We can add, in my preferences with SGLT2 inhibitors nowadays, because we can give some added benefits. And after maximum trial only, I feel in type 2 diabetes patients, when I am using only a triple drug, not more than 3, I agree with all of you, then only we should think of insulin. But without a trial of this sulfonylurea like a glimepiride or gliclazide, I feel we are failing our patients.
Yeah, very, very rational. Rightly, you have pointed out, and Professor Das has also supported adding a secretagogue or adding a glucose lowering drug. But we have to remember, when the duration of diabetes is very long, maybe 15 years and beyond, say 20 years or 18 years, there at times adding a secretagogue is not fruitful.
No, sir, I'm not adding a secretagogue. When I'm needing to withdraw that secretagogue, when it is failing, I will shift to insulin, but I will not continue with a glimepiride or gliclazide. I will go on with the insulin sensitizer. I will go on with an insulin the dose like a pioglitazone or a metformin or a newer drug like SGLT2 inhibitors. But at that time, when I'm needing to add insulin, why shouldn't I add a secretagogue again? Because I'm giving a insulin itself, why I shouldn't? Because there is more chance of hypoglycemia also. And when my medication has failed, when there is no beta cell reserve, theoretically this glimepiride and they shouldn't work. But without giving a trial of that molecule, I can't say this HbA1c is beyond our oral anti-diabetic agents.
Both of you are talking the same thing, that at the 10 to 15 years of diabetes, the beta cells may not be functioning well. So that time, definitely time for changing over to insulin. I think fully agree with that. We can take last 2 questions because we have 3 sessions more. Any other comment?
Yeah. Over to Dr. Alok, sir.
Hello?
Everybody is speaking except the moderator, sir.
Yet about the Dakshata told the new insulin that has come from USB is indigenous, very effective, and I have tried it in ICU. It is working very well. So Fiasp is going to take over because now our students are now fading out. Its new years has a much better scope of taking over, and with low dose, you find a lot of change. And even diabetic ketoacidosis, this new Fias Pinsuquick is working very well. So, Professor Das, Ashok Das, sir, what is your take on this new Fias?
I have used it, Quicksulin, and it is actually very effective. We use it in two situations. We use it in the ICU and also CCM. CCM stands for Critical Care Medicine Unit. ICU is my own ICU. CCM is under anesthesia, but we are the consultant there. The third thing I use it, what Dakota pointed out, I also use it in getting uncontrolled hyperglycemia, not amounting to ketosis. If you give aspart multiple doses, they get controlled. And, you know, there are people who prefer even 3 injections a day because, they need 3 injections a day. It is approved for the pregnancy, approved for the GDM. So it is a great drug, and it definitely saves life and convenient to PWD persons with diabetes.
Regarding these fixed dose combinations, there are many types of fixed dose combinations, like one gliptin, one SGLT2 inhibitor with metformin. Like you can also change from vildagliptin to sitagliptin. And also, dapagliflozin is added to glimepiride and metformin. And all of them are working. Technical purpose or academically, which one you will recommend, or all of them are acceptable as and when required. Where glycemia is high, blood glucose is high, this dapagliflozin with glimepiride 2 milligram is working very well. So none of them have side effects except the balanoposthitis through DAPA. Otherwise, all the three combinations are also working good. Your opinion, sir?
I think you see, as you rightly said, if there is a hyperglycemia, nothing like a sulfonylurea. The best of the prescriptions, because I worked in Delhi for some time, these contain the first drug is always a combination of metformin with sulfonylurea. That is always there. And so I think glimepiride 2 will help if there's a hyperglycemia, because the reduction of H1C through gliptin is only 0.6 to 0.8. And somebody marked that much of reduction also happens with diet restriction. So, it is not great. But gliptin has a lot more other benefits that is important to know. We were doing a trial for pre-diabetes. We found that for the fasting, increased fasting glucose is the drug of choice. It has a lot of other benefits. Then number two, as you rightly said, that DPP4 can produce prostatitis, but now it has come down. If you say them, it has come down, and I do not stop the drug. That message I want to give, that if you get minor UTI, prostatitis, even in females, UTI for 4 5 days, do not stop the drug, because the benefits outweigh the side effect of infection, for which we have wonderful drugs.
Yeah, I'll agree to Professor Das. Actually, we have to teach our patient their frequent cleaning of the genitalia and drinking water, precautions which are required to prevent a SGLT2 inhibitor induced prostatitis. But this is not a contraindication. And as Alok sir has asked this pertinent point, in the patient, we have to find out what are the probable pathogenetic mechanism responsible for hyperglycemia. Is there obesity leading to insulin resistance? Is there secretory defects where insulin is wanted? Is there any other problem like the hepatopathy, diabetic kidney disease, where the OADs have restriction like metformin and the DPP4 inhibitors? So that part we have to work, and as all possible combinations have come now, even DPP4, SGLT2, metformin, and even pioglitazone SGLT2 combinations have also started coming. So all permutation combination has become possible in the oral antidiabetic drug segment. So depending on the clinical assessment of the patient and possible pathogenetic mechanism, we can choose the drugs which one will take, either a SGL2 inhibitor, DPP4 metformin, or a secretagogue, maybe sulfonylurea, alpha glucosidase inhibitor, metformin, or maybe a pioglitazone SGL2 inhibitor, metformin. So this you have to decide, and fortunately the fixed dose combinations are so many. We have all possible varieties are available with us.
It's an open menu system. So you can order for any combination available.
But with every combination, sir, is the PKPD matching? That is important, no? Because all combinations are coming, we're writing right, left, and center.
Your point I take very seriously. You see, what we do, anybody bringing in a combination for the first time, Sankha, he has to do a trial.
Yes, sir.
But if USB has brought it and tomorrow morning some other company has to bring the same combination, we don't insist on another clinical trial. But for the first time, whoever is bringing it, PKPD trial is a must. But those who bring later on, they may not be doing the PKPD, they might be cheating. But today we have said 6 times in a year. I'll repeat again, 6 times in a year, they are monitored and physical verification of the facility and the PKPD on the spot is evaluated now. Because
So I wanted to say something.
Yes,
please. Since we are discussing, this was long back when we were discussing about more than 3 drugs in the landmark study. What are your experiences with imeglimin? I have found some good results with imeglimin.
I'll tell you my
I mean, there are few patients. There's not much data on it, but
the imeglimin is a new compound, and it is a replacement. To make a long story short, replacement for metformin, and 1 gram twice a day is a too big tablet to take twice a day. So I do not give 1 gram twice a day. 500 twice a day I give, and I will not put it above metformin, to be honest with you, because the price is more, there's inconvenience of taking a bigger tablet, and the paper we have from Japan, there's nothing beyond what has been. So I use it, but I use it limitedly.
One submission on imeglimin, the HbA1c reduction is not good. I am also in part of that trial, imeglimin, metformin intolerance one trial is going on. So the problem is
they wanted me to become the chairman of the trial, but
yes, sir, yes, sir. The
because
problem is patients are complaining that their HbA1c or at least fasting and PP monitoring is not that very modest.
Yes, the Shambhu is a trial being done by Zydus, and it is a countrywide trial. And I was supposed to chair that, but I'm not chairing that for some reason. So now we will wait, Shambhu, for the report to come. But Alok, it's a drug. We have very few drugs in diabetes, not like antibiotics. So having one more drug is good, but use it, metformin intolerance, as Shambhu just now said, and see if it is not.
it has not got a place yet. The indications and the arena it should occupy in the diabetic therapeutics is not yet well defined. That's what I feel.
I think we have to wait.
Generally, we are told we have to wait for some time.
I think now
I wanted to share one or two experiences with SGLT2. I totally agree, sir. What I have seen in my practice is most of the time, the moment there is a little UTI, it is the family practitioners or the medical store person who tells them to stop the drug. It's such a valuable drug. I've seen people stop it because some third party tells them there's a slight and there are enough data to show that most of these infections are culture negative. So you really don't know whether these infections are reliable. And there was a very beautiful paper which showed that when you combine SGLT2 with DPP4 inhibitor, the incidence of infections come down. And as I totally agree with this. When we write SGLT2 inhibitors, we don't tell our patients. When we tell our patients that you need to maintain a proper daily daily local hygiene, very seriously with soap and water, the same person who was stopping the drug and who was getting infection, suddenly the infection rate has come down very beautifully. The only thing is we have to take out a little time and educate them that local hygiene is important. And trust me, I've seen many patients after sex or after intercourse or after during bath also, they actually don't take pains to clean the local genitals. And that is depriving them of a very wonderful drug.
Thank
Good.
you,
I
Alok.
think, I think Alok, we're exactly on time. We have to have a break or no break, you decide, because now it is 4 o'clock. If you give a break, people will not come back. So I think we can go leisurely, start the next session. Jayant is there, and we have next session starting at 4 o'clock, which is a very important session.
And Dr. Ramchandra Naik, sir, has joined. We
Yeah,
welcome,
can I
sir.
see Ram? Ram, can I see you?
Hello,
Ram,
sir. I'm here very
hi,
much.
hi, hi.
Good evening, sir. How are you?
I'm
Yeah,
fine.
we welcome you, sir, to Nucd.
Oh,
So
thank you. Thank you. It's a pleasure to be
we are
joining
meeting
with the
Ram.
group.
I'm meeting Ram in 2 months' time. Am I
I
correct,
know.
Ram?
Yeah, that's true. We met very
Yeah.
recently in Bombay. Yeah.
We met in Bombay recently, and so I'm very happy
Yeah.
to. Thank you. Now, Ram, be there. I'll now call the chairperson of the session and hand over the session to him. The chairperson, before that, it's my duty, duty of Joint actually. I'll give that honor to Joint to do. Joint, you do the honor of thanking all the speakers and the chairpersons. But I'm just making announcement that we will be going for the next session directly. Maybe a little bit of leisurely comments can be given by the context setting by Joint.
For the previous session, for the previous session, the first thanks should go to USB for sponsoring the session. And next, Professor Ashok Das, who has done it so nicely, and Dr. Dakheta, as well as Dr. Sharma, Dr. Jasjit, Dr. Shahu and Shambhu are here.
Very good, very well chaired, very well chaired.
Very well chaired. And our invitees and the panelists, Dr. Shankoshen and Dr. Alok Modi.
Call now, Joint. Call me. I'll come.
Sure, sir.
Shankoda has called me many times, and now it's my turn to respond to his call. It's very difficult. So we had a good session, and Alok has joined as a guest appearance. So thank you, Alok. You be part of Nucd, and you will enjoy our academics led by Dr. Alok Kanungo sir. You also bear the same name as Alok sir. So
My honor and privilege, sir.
I must tell you that the next session is absolutely important because of two reasons. Because of the persons we have and the topics we are covering. So I would like to make the announcement. It is better to people. Coming things cast their shadow. So people should know what is coming in the next session, which is fabulous.
Type 1 diabetes.
Type 1 diabetes, is the only session we have.
Yeah.
And we have people in this session who will be setting the context. Joint comes followed by Ram. Ram is our very old, very famous physician, MD, DM from our country, and he has a lot of love for the country. I know him very very well, and for the children's education, he is now staying in the USA. I'm sure he will come back after some. He comes almost very regularly. We have Bansi, we have Alok, who was really pioneered Ram. He has pioneered the type 1 care in our country, Ram. He has pioneered and also has worked with Dr. Sanjeevi in the Karolinska in classifying the type 1 diabetics. So we're talking about the diagnosis of challenges in the diabetes in the young. And we have very important panel I know Archana Sarda, which is symbol of love and affection for the type 1 diabetic. She has done wonderful changes. Vansi gave the oration last week in a meeting, which I was really flabbergasted by. Vansi, have you joined? Vansi? Stuti, where is Vansi?
He is recorded.
Record, he is not able to come. He gave a talk. Then we have Alok and Ramnaik. With this, may I hand over the session to Jan? Jan, please take it forward.
Thank you, sir. Thank you.
1 minute light talk before Ram starts his oration. Yeah. You can give
Actually, this is a privilege with such a galaxy of speakers to moderate this session and invite you all. This is type 1 and diabetes in young. We know type 1 is always a difficult segment for even endocrinologist and diabetologist. And this is a very Herculean task of convincing someone to be on insulin therapy lifelong, and so many complications and the course of the disease is there. So we have 4 sessions in this topic. The first one is the topic presentation by Dr. Ramchandra G. Naik, who will be speaking on autoimmune damage and prevention in type 1 diabetes. So there is a hope that can we prevent the type 1 diabetes, and our most favorite Dr. Bansi Shabu, who is Professor Bansi Shabu now, will be speaking on most wanted topic, that is CGMS, that glycemic monitoring and artificial pancreas, followed by our organizing chair, Dr. Alok Kanungo, will be speaking diagnostic challenge in diabetes, the cause of diabetes in the young, and we'll have the panel with Dr. Archana Sharda, Dr. Bansi Shabu, Dr. Alok Kanungo, and with Ramchandra G. Nayak sir. So with this, I request to share the CV of Dr. Ramchandra Nayak sir, who is an endocrinologist and practicing in NYU Langone Health in New York City. He serves as a professor of medicine and director of diabetes clinical research at New York University Grossman School of Medicine. Dr. Nayak brings over 3 decades of global experience in patient care, clinical research, and pharmaceutical drug development. Dr. Nayak completed his DM endocrinology and DNB endocrinology in 1993 from All India Institute of Medical Science, New Delhi. He subsequently obtained a 2-year JDRF postdoctoral fellowship award, that's 96 to 98, and worked at the University of Washington, Seattle, USA, under the mentorship of late Dr. Jerry Palmer on elucidating the pathophysiology of LADA. So over to you, Dr. Chandra Naik, for the very important session on autoimmune damage and the prevention in type 1 diabetes. Over to you, sir.
Hi,
good afternoon, good evening,
add one
everyone.
sentence
My
on
name
this,
is
Ram.
Dr. Ram Nayak. I'm a clinical professor at NYU Langone Medical
Just
Center,
one minute,
practicing
Ram.
in
Ram,
New
1
York.
minute.
Yeah,
And
sorry. Stuti, can you pause it? Yeah, actually, yesterday we had a recording done, and so I think Stuti Gupta is, I thought that would be fine to just go ahead with that, or if you want me to do live, I can do live.
Before that, Ram, I want to tell about your work, which Joyant knows.
Oh,
but
thank you. No problem.
I mean, you know, Ram has worked with the top guys of type 1, Palmer. And you take a name of type 1 diabetes, he has worked. He has worked in their lab, he has worked in their clinic. So his experience of the autoimmune diabetes is the highest in the country, even better than the best. So that I wanted to and tell you, and welcome you, Ram. Thank you.
Oh, thank you, sir. Thank you.
We'll go ahead. We'll go ahead, Suti.
Yeah.
We can play recording.
Hi, good afternoon, good evening, everyone. My name is Dr. Ram Nayak. I'm a clinical professor at NYU Langone Medical Center, practicing in New York. And I, at the outset, would like to thank Dr. Alok Kanungo, Dr. Ashok Kumar Das, and Dr. Jayant Panda, for inviting me to present on this interesting topic of autoimmune damage and prevention in type 1 diabetes at the 11th National Update on clinical diabetes. And type 1 diabetes has always been an area of clinical and research interest for me for the last 3 decades or so, since I've been practicing endocrinology. I used to be practicing in Mumbai for 15 years before I moved to the United States. So what I would like to highlight here is we all talk about epidemic of type 2 diabetes, but it is also important to know that the incidence of type 1 diabetes and prevalence of type 1 diabetes is also increasing across the world. And most of the information I'm talking is more US based, where I'm currently practicing. So as you can see here, almost 300,000 people in the US are at risk of type 1 diabetes stage 3 clinical. I will come to the exact staging discussion in a bit. And 64,000 people are diagnosed with type 1 diabetes every year, of which 58% are actually adults. And approximately 1.9 million Americans had type 1 diabetes. This is a data little older in 2019. And across all the ethnicities and races, the type 1 diabetes incidence is increasing. And you can see here, what is important to note is that the median survival age of people diagnosed with type 1 diabetes between the age of 11 and 15 years is 12
years shorter than age-matched children without type 1 diabetes. So it's important to identify and intervene to prevent the progression of this disease. As we all know, diabetic ketoacidosis is a common but potentially avoidable complication of type 1 diabetes. It is still a leading cause of mortality, even in the United States. 200,000 hospital discharges for DKA every year, and 30 to 60% of people of type 1 diabetes in the US present with DKA at diagnosis. But what is interesting to note is that the frequency of DKA is 1.5 to 3 times less among the children and siblings of type 1 diabetes. What it means is, if you identify the siblings and first degree relatives of type 1 diabetes and screen them and monitor them, the probability of they, if ever to develop diabetes, getting into DKA is lower, which underscores the importance of an early recognition and early diagnosis. Several studies have been conducted across the world. I won't go into the details in the interest of time, but what we know is, if we screen for type 1 diabetes in an appropriate population, first degree relatives of people, we know that the risk of diabetic ketoacidosis, as you can see here in this column, significantly lower than what is expected without the screening, which again highlights the importance of screening and early diagnosis. So the benefits of screening for type 1 diabetes risk in the high risk population, including the first degree relatives, is obviously one, lower risk of ketoacidosis. Secondly, it allows greater time to deploy glycemic management skills and also implement strategies to prevent the disease progression. Now that we have treatment available for prevention of progression of type 1 diabetes disease process, we can deploy strategies and therapies, and also it provides an opportunity to participate in research initiatives where you can make an attempt to prevent the progression of the disease when such an opportunity is available. And in the last few years, it has been very clearly laid out, and it is recognized by all the diabetes association, including the ADA, American Diabetes Association, that the type 1 diabetes progresses through 3 stages: stage 1, stage 2, and stage 3. I'm sure many of you are already familiar with this. So what I would like to highlight here is type 1 diabetes is autoimmune destruction of pancreatic beta cell, which is mediated by T cells. And in a person, autoimmune triggers, including environmental factors or infection, which we have known for decades, may initiate an autoimmune disease process in the context of genetic predisposition. So people with a genetic predisposition, they have an autoimmune insult, result in development of autoantibodies against pancreatic beta cell antigens. And when the stage in a stage where there are hardly no antibodies or one antibody present, it is called pre-stage 1. And when more than 2 antibodies are detected against the islet autoantigens reflecting a T cell driven beta cell specific autoimmunity, this is stage 1. But here it is important to note that the blood glucose levels are normal, they are still normoglycemic. Then they progress to dysglycemia with presence of 2 antibodies, and dysglycemia referred to as the standard definition of diabetes and prediabetes that we all use today: a fasting glucose of 100 to 125, or 2-hour post 75-gram glucose value of 140 to 199, and A1C of 5.7 to 6.4 is stage 2, and stage 3 is a stage of full-blown hyperglycemia when presents with hyperosmolar symptoms, weight loss, and risk of diabetic ketoacidosis. And the antibodies that are used to identify early stage 1, or what we call stage 1 of type 1 diabetes, are glutamic acid decarboxylase 65, IA2 antibody, zinc transporter 8 antibody, insulin antibody, and islet cell autoantigen. So this shows the location of various autoantibodies within the pancreatic beta cells, and number of antibodies developed is a predictor of risk of developing the full-blown diabetes. And this slide shows the incidence of specific islet antibodies by age. As you can see here, in genetically predisposed population, when there is an autoimmune insult triggered by an environmental insult, the seroconversion from antibody negative to antibody positive stage generally happens maximally between 9 months to 2 years of age. And then this frequency goes down. This is the data for individual antibody development. But the type 1 diabetes stage 3, which is a full-blown clinical diabetes that all of us have been used to diagnosing and treating, it peaks between essentially between 10 and 14 years. What it means is from the time the seroconversion has happened between 9 months to 2 years, by the time the full-blown diabetes has started, which is between 10 and 14 years, there is almost a decade's duration where one can do some intervention to prevent the progression if a treatment is available. This shows the risk of progression from stage 1, 2 antibodies, no dysglycemia, to stage 3, full-blown diabetes, what we see day in and day out. If there are 2 antibodies, there is a 44% risk of developing full-blown diabetes in 5 years. This risk goes up to 70% by 10 years and 84% by 15 years. Now you add another variable of dysglycemia, which is stage 2 of type 1 diabetes. There is 4-year chance of development of progression to full-blown diabetes is 75%. That means if you have a presence of antibodies and there is dysglycemia, the risk in the next 5 years of that particular person developing full-blown diabetes is significantly high. This is what led American Diabetes Association to come up with a classification or the staging of type 1 diabetes. Stage 1, stage 2, and stage 3, that's what I showed in the last few diagrams. Presence of autoimmunity is an underlying mechanism. Normoglycemia, dysglycemia, overt hyperglycemia. Stage 1 and 2 are pre-symptomatic and stage 3 is symptomatic. And the diagnosis of stage 1 is by multiple antibodies, no impaired glucose tolerance or impaired fasting glucose, dysglycemia in stage 2, and full-blown diabetes in stage 3. So this brought the new guidelines, American Diabetes Association, Breakthrough T1D, which was used to be called as Juvenile Diabetes Research Foundation, and other associations have come up with screening guidelines that you need to screen people who are first-degree relatives of type 1 diabetes population who are at the highest risk of developing type 1 diabetes, almost 15 times more than the general population. People with associated allergic or autoimmune diseases are at higher risk of developing type 1 diabetes. So the current guidelines state that if there is a family history of type 1 diabetes, if there is a personal family history of autoimmune disease, specifically in children, one can begin screening at as early as 2 years of age. And based on whether the antibody screening is negative or there are more antibodies, one can decide when to screen next or stop screening to identify the risk. I won't go into the details. I think the slides could be available for review later on for the audience, and you can specifically look at all the specific details. I want to switch gears to C-peptide, which is a marker of endogenous insulin reserve. C-peptide is co-secreted in equimolar concentration with insulin, and use of C-peptide preservation or C-peptide presence is used as a marker for the beta cell function assessment. And as you can see here, the C-peptide levels drop. Stimulated C-peptide level decline in the months before the stage 3 diabetes starts. Hence, preserving beta cell function is an important potential therapeutic objective in people at high risk. It also shows model predicted average C-peptide levels by the age group. Younger the age at onset, greater the decline in the C-peptide. This is the patients with age of type 1 diabetes diagnosis 6 to 11, 11 to 17, and 17 to 20, and more than 20. Younger the age at onset, greater the loss of C-peptide. And why is it important to preserve the C-peptide? Presence of C-peptide preservation is important consideration because C-peptide is associated, presence of C-peptide is associated with better preserved beta cell function. It leads to lesser glycemic variability, and people with a better preserved C-peptide have a lower risk of severe hypoglycemia event or any of the microvascular complications such as retinopathy as shown in this particular diagram. So sooner you intervene, greater the opportunity to preserve the beta cell function and prevent the progression. With this, until 3 years ago or so, we did not have any intervention. We knew that, okay, type 1 diabetes progresses through stages. We can identify, characterize where the patient is, and we know that preservation of C-peptide is important, but we did not have any treatment intervention. But fortunately, today, we have a drug which is teplizumab. It's an anti-CD3 antibody that was been approved for use in people in stage 2 of type 1 diabetes who are at highest risk of progression to stage 3, and this is currently available in the United States for treatment. It is a 14-day intravenous infusion administered in people who have got 2 or more autoantibody positivity and dysglycemia, and with the hope that it will preserve their beta cell function. The study that led to approval is called TN10 study under the TrialNet initiative, where they randomized the relatives of patients of type 1 diabetes aged between 8 to 45 into either teplizumab therapy, 44 people and 32 people in placebo, and followed them up with oral glucose tolerance test every 3 months. And the primary endpoint was time to diagnosis of stage 3 of type 1 diabetes, and secondary outcome was a safety events. And what was found was people in the teplizumab group developed type 1 diabetes stage 3 48 months later, and from the time of median time to from the randomization to development of stage 3 was 48 months, whereas placebo was 44 months, indicating there was a 24 months difference in the median time to stage 3 development of type 1 diabetes, which is important. So 43% of people were treated with teplizumab developed type 1 stage 3, and 72% of those treated with placebo developed type 1 diabetes, and this led to the approval of this particular drug by the US FDA. Although it seems like 2 years is not a big deal, but what is important is the preservation of beta cell function and the consequent benefit in terms of lesser glycemic variability in the long run and reduced risk of severe hypoglycemia or acute hyperglycemic complication is an important consideration when we think of treating patients with this teplizumab in the appropriate population. Lymphopenia and rash were the major side effects, and most of them happened in the early phases of infusion, which got rectified. I won't go into the details of this, but suffice it to know that this treatment is available through the infusion center in many academic and other centers in the United States. There were some limitations being the small size, etc. But again, there was no other drug that met this kind of outcome endpoints before teplizumab in preventing the progression of type 1 diabetes. And further studies also showed that people treated with teplizumab had a better preserved C-peptide level. This was an extended follow-up data for 1 year compared to those who were on placebo. And more recent studies also looked at people with a newly diagnosed type 1 diabetes in stage 3, where the same teplizumab infusion was administered in 2 courses, showed the benefits in preserving beta cell functions. And we also have data to support that residual beta cell function is associated with a longer time in range. Now that everybody is now using continuous glucose monitoring as standard of care in type 1 diabetes, greater percentage of time in range, lower dose of insulin, lesser glycemic variability, and lower A1C in type 1 population. So all this underscores the importance of preserving the beta cell function, preserving C-peptide with interventions in the early stages of type 1 diabetes pathophysiology, so that we can delay the further progression, delay the risk of ketoacidosis, and delay the risk of chronic complications. And with this, let me conclude saying that type 1 diabetes is a lifelong autoimmune condition affecting adolescents, children, adolescents, and adults. It is characterized by 3 stages of progression, which is due to a T-cell mediated damage of the pancreatic beta cell, leading to loss of glycemic control. Presence of 2 autoantibodies constitute the diagnosis of early stage type 1, and nearly everyone tested for 2 antibodies eventually develop stage 3. And if you add a variable of dysglycemia, the risk of progression is much higher. And T1D screening and early detection minimizes the risk of ketoacidosis, empower the healthcare providers and people with diabetes and caregivers, and provides an opportunity to delay the progression with the intervention and treatment. Thank you so much for your attention, and I'm happy to answer any questions during the panel discussion. Thank you.
Thank you, sir, for that nice presentation. It was really very good in its content and the message. And I'll just invite one comment from Professor Das, and then
it was mind-boggling. And Ram, next year this drug will be available in our country.
Oh, excellent! I didn't know that. Yes, Sanofi is
already
introducing that.
1 year more.
Yeah.
Next year you'll get it. They're getting ready.
Excellent.
And it will change the
Okay.
scenario. Change the scenario.
Yeah, it makes a big difference. Absolutely. Thank you.
I think we'll come back to other questions. I have 2 or 3 questions more. We'll come back in the panel discussion.
Yeah. Sir,
Sure.
please stay back for the panel.
Yeah, I will be there.
It's the early morning, 4 o'clock there. What is time there now?
Oh, it is almost 6 a.m. 6 a.m. now, almost.
My God. You did not sleep in the night last night, didn't
No,
sleep?
I generally get up at 4 o'clock, so it is not too early. I'm fine.
Thank you. So nice
Yeah,
of
thank
you.
you.
So kind of you. Thank you.
Thank you, sir.
Then we'll move on to the presentation by Professor Dr. Bansi Shabu, the CGMS and the artificial pancreas. All of us know that Dr. Shabu is the chairman of Southeast Asia chair-elect of IDF, International Diabetes Federation. He is the vice president of diabetes in Asia Study Group and chief diabetologist and chairman of Diabetes and Hormone Clinic in the Ahmedabad, and secretary of the Diabetes India and Indian Academy of Diabetes, as well as past president of RSSDI and ARROW. Without much introduction, because all of us know Dr. Shabu so well, and we can tell him who has changed the situation, scenario, and the modality in which the diabetes was being assessed, approached, and treated in India, and going to affect the whole globe. We present you Dr. Bansi Shabu, Professor Bansi Shabu, for the topic CGMS and the pancreas. Over to you, Dr. Shabu.
Friends, first of all, I would like to thank NUCD organizing committee, scientific committee, particularly my close friend, Dr. Alok Kanungo, Dr. Jayant Panda, and program director, Dr. Ashok Kumar Das, for giving me this wonderful opportunity to talk to you on a very important topic, continuous glucose monitoring and insulin pump therapy. As we know that in 15 minutes, it's really difficult. I can give you some glimpses of continuous glucose monitoring and insulin pump therapy because there is a dedicated conference on diabetes technology where we talk only on CGM and insulin pump for 2.5 days. I don't have any financial disclosure for this particular talk. We know there are 3 pillars to manage dysglycemia. The first time after DCCT and UKPDS, trial had shown that chronic hyperglycemia leads to a lot of complication in diabetes. And what we want is try to achieve tight glycemic control to have less and less complication, whether it's a type 1 or type 2 diabetes. But then the limiting factor was hypoglycemia. Hypoglycemia was a major challenge. If you want to treat type 1 or type 2 for a tighter glycemic control, it is hypoglycemia which is not allowing you to achieve a tight glycemic control. And then we realize even if you achieve a good glycemic control with some hypoglycemia risk also, but still the glycemic variability, which is again very important. So it's a glycemic variability is also responsible for increasing complication in persons with diabetes, and time in range, a new concept have come other than A1C, which we are using in our day-to-day clinical practice. The monitoring is not something which is new. Even before Christ, when the diabetes was diagnosed, Madhume, it was only way of the ants, which were, the sweet urine was the responsible reason for that. And that is to be monitored again, whether the person is still continuously excrete sweet urine or not. In 1971, when the first time a glucose meter had come, and that time people have started using, we had also used this glucose meter in our medical school, but that type of glucose meter was available once in Department of Internal Medicine, sort of that. In 2010 onward, we can say that it's continuous glucose monitoring had come. Rather, before that, this is the Dexcom, but before that, we also started using the Medtronic continuous glucose monitoring, but it was only for 3 days. And in real uses in our country started after 2015, when we had a Libre Pro had introduced to our country. The CGM components are many. They are from the Dexcom. There is a transmitter also along with a receiver and a sensor. But now this transmitter in between has gone. And now we have only sensor and receiver. And again, the receiver has been now changed directly on your phone. So you need only a sensor, and your receiver can be your iPhone itself. So, we are removing two components of it, the transmitter and receiver. In between, the sensor itself is now with the transmitter, and receiver can be your phone too. Why CGM can help? It minimizes the extreme blood glucose fluctuation. It gives you immediate feedback. If you are getting live, you can have immediate feedback also, and behavior can be changed and then know the direction where you are going. There are long-term benefits. See your patterns, how the sugar is getting fluctuated, avoid night low and hypo unawareness, which is very, very important, and a peace of mind from fear of low. Because as I told you, the hypoglycemia is a major limiting factor for a tight glycemic control. And if you put patient on continuous glucose monitoring, many things you can measure, particularly when person is going in hypo, and those who have hypo unaware and those who are getting nocturnal hypoglycemia, they can be taken care. And at the same time, which meal is responsible for their post-meal hyperglycemia, that can be also taken care with the continuous glucose monitoring. We know that almost 30 years back, after DCCT and after UKPDS, we all know that HbA1c had gained the importance, and we all started measuring A1c for our patients. I know that we used to debate before 20 years or 25 years whether we should get for each and every patient A1c, or still the self-monitoring of blood glucose or glucose which is monitored through lab is sufficient. But then we realized, no, it's A1c which is most important thing, because that gives you the average of last 3 months, but it does not predict anything for next 3 months. Whatever the change which you are going to do for a patient, it is not going to give you any information how much it will benefit the patient. Even if you at 9 HbA1c, if you want to change someone therapy, you don't know whether you are going to achieve 7 or not in next 3 months. But we know that increasing A1c is responsible for increasing micro and macrovascular complication. But there are limitations. As I told you, it's a benchmark of last 3 months. It gives you last 3 months average sugar, assessing the blood glucose, and it does not give you any idea of future events. At the same time, not addressing glycemic variability and no hypo and hyperglycemia events also. Patient with same A1c, you may have two different type of persons with same A1c, but still there may be different amounts of time of both high and low blood glucose ranges may found in these two different type of patients. So you may have a persons with 7 HbA1c, one is 100% in a best control, other persons may be having 5% time low and 25% time high, and 70% in time in range, but other persons could be even as high as 20% time of the low, with the 40% of the time they may be high and 40% time in range. And this happens many a times when we put the patients on a continuous glucose monitoring. So now it is better, instead of getting a one single report on your glucose meter or a 3-month average a glucose, A1c report, it is better to have a continuous monitoring. It's like a real photograph or a time of time taking photograph, instead of that taking a videography that is going to give you the 24 hours a complete ambulatory glucose profile. After this AGP software had come, it had become much easier for clinician to interpret, because before that it only used to give you the reports, but there was no software. But then after this software of ambulatory glucose profile, you can see the complete all profiles, all the sugar reports of 5 minutes are plotted in such a way in the graph that, the dark blue color will show that 50% of the time the person is moving in this range, and another time, 90% of the time, actually in the dark blue. With the light blue is actually outlier, which is almost only 10% of the time person is going even those high or low also. So this is a ambulatory glucose profile interpretation become very, very easy for clinician to understand and to teach and educate to your patients too. In 2017, the first time a consensus was there in the use of continuous glucose monitoring. It was along with ATTD, as I am the part of ATTD since last 2015, and I was lucky to be the part of this consensus that we had come out with this paper, which has been accepted by almost all over the world by all associations, that people should use continuous glucose monitoring, at least those who are having hypo-awareness, nocturnal hypoglycemia, who are on insulin, who are on agents which can lead to hypoglycemia, all type 1 diabetic patients, they should be on continuous glucose monitoring. And after that, in 2019, with the followed up, if you put the patients on continuous glucose monitoring, then what should be the target for them? And that concept had come in time in range, and that paper was published in 2019. So continuously, with 2 years, we had worked on it, and we had come out with a time in range concept, which is again accepted by all over the world. People from all association, and complete paradigm shift has happened, that people were chasing the HbA1c, and now for persons to whom you are using continuous glucose monitoring, you have to chase the time in range. And you want that persons with type 1 or type 2 diabetes, anything, they should be on continuous glucose monitoring to see that more than 70% of the time their sugar should be between 70 to 180. Those who are elderly, high risk patient, at least they should achieve more than 50% of the time in range. That is what to be done for persons with diabetes. The continuous glucose monitoring fills the information gap for more complete view. It gives you not only the SMBG or HbA1c is to be replaced at this point of time in our country, but continuous glucose monitoring will give you a lot of information. If you are putting the patient on CGM in compared to SMBG, you will find that even their SMBG report of 4 to 5 times may be normal, but in between they may develop hypo and hyperglycemia, which you can measure only through continuous glucose monitoring. So I always say these 3 core glucose monitoring technology are complementary and essential for most of our patients, unless all of them are using continuous glucose monitoring. Without that, we will never able to replace blood glucose monitor or A1C. But yes, if those who are using continuous glucose monitoring continuously, probably they may not require finger stick testing or A1C. But at present in India, many of our patients who are intermittently using continuous glucose monitoring for 14 days, and again then after 3 months, 6 months, and we have written also what should be their frequency of using continuous glucose monitoring. First time in 2020, in their American Association of Clinical Endocrinology, even for type 2 diabetic patients, after 2019, our paper of time in range, they had put that CGM should be considered one of the important principles of management for type 2 diabetic patients. So using continuous glucose monitoring whenever indicated to assist patient in reaching glycemic goals safely. So time in range is a target for type 2 diabetes, and that's an urgent need. And this paper we published in 2021 from India too, that even for type 2 diabetic patients, they should try to achieve time in range for more than 70% of the time. Let me start with a case, one patient with a A1C of more than 8.5 who is already on a triple drug with a sulfonylurea, metformin, and DPP-4. And patient was having uncontrolled diabetes, had gone to multiple consultants, and everybody had suggested that person should be on insulin therapy. And I fully agree that with all guidelines around the world is talking with the uncontrolled diabetes with a triple drug therapy should be on insulin. And when patient had come to me, I explained that yes, there is something called GLP-1 and SGLT2 which we can use, but let me put you on first on continuous glucose monitoring. First 5 days you can see all the reports are high, and we suggested let us put you on GLP-1. That's say once in a day. Every day we started with SGLT2. We removed the DPP-4, and I decreased the dose of glimepiride, which patient was taking 4 milligram to 2 milligram. And every alternate day, patient was to call me, even though patient was on a blinded CGM. And to our surprise, patient fasting sugar started decreasing from day 3, and then patient call, and I reduced the dose of 2 milligram of glimepiride to 1. When patient had come back to us after 10 days and we had seen these 2 reports, what we could see that all the reports are absolutely fine. So I just stopped the glimepiride of 1 milligram, and we thought that without glimepiride, let us continue with the patient with GLP-1, with SGLT2, and with metformin, with a full dose of 2 gram of metformin, with 10 milligram of dapagliflozin, and with patient was put on a GLP-1, which is liraglutide 0.6 only, and then you can see patient was absolutely well controlled. So the point is how continuous glucose monitoring can help, and to achieve a tight glycemic control, even the guideline is saying that the patient should be on insulin therapy, and we had precisely treated this patient with other 3 drugs, not with the insulin therapy. The second aspect of my talk is on insulin pump therapy. History of insulin pump is not new. In 1963, someone had thought of that why insulin cannot be given continuously. Why not it can be given subcutaneously continuously when it can be given IV. So first they thought of IV continuous insulin infusion, and then they thought of continuous insulin infusion, subcutaneous. We all know that in type 1, we wanted to have the best glycemic control with full normalization of glycemia. This is what a person either has to take multiple shots of an insulin injection, or they have to go for their convenience pump. But now the insulin pump, which are advanced hybrid closed loop system, where they have not to just for the convenience the pump is required, but also with continuous glucose monitoring. If they put the CGM and pump together, that is sensor augmented pump or automated insulin delivery, they can achieve tight control or time in range more than 70% in these patients who are on automated insulin delivery. So despite CGM, when in UK after 2017, almost all patients who are put on continuous glucose monitoring, but they could not achieve a tight glycemic control because CGM alone is not enough, because that requires a lot of education. A lot of times they have to use the correction dose, and still it is really difficult for them to have a tight glycemic controls. And that's how the insulin pump therapy had come. We know that insulin pump in India is almost before 20 years. We had used the older insulin pump also, but with the newer hybrid closed loop system, advanced hybrid closed loop system, which is available to us in last 1.5 years, we started using for a lot of our patients for this pump therapy also. And this had shown that not only decreases A1C, not only decreases risk of hypoglycemia, but it risks of diabetic ketoacidosis. So with the glycemic control, significant difference between patients who are on multiple daily insulin injection in compared to continuous subcutaneous insulin infusion pump, the risk of severe hypoglycemia is significantly decreased, and it is also risk of decreased mortality and severe hypoglycemia too. So I can just show in this city 1983, when there was no pump, patients were put on multiple daily insulin injection, NPH and R, to achieve a tight glycemic control, which they could not. 7.2 was the average for the patient. The risk of hypo was 62. When continuous glucose monitoring after 25 years, they could achieve a glycemic control of 7.1, but the risk of hypo is reduced from 62 to 20. And you will be surprised, with a advanced or sensor augmented insulin pump therapy, they could achieve less than 7 with the risk of hypo 0. And that's what the how pump can help. And now we have much advanced. That was in hybrid closed loop, which is in 2016. And now in 2025, we are using advanced hybrid closed loop system with a 0% hypoglycemia, and probably the A1C will be less than 6.5 for all your patients. Why you need? Because if you put the patient on CGM, you will find that all 4 days, there are patients who have hypo and hyperglycemia, and the same persons with a different days, and how you have to adjust the dose, particularly in night time, particularly in early morning. If there's sugar fluctuation without taking food, it's really difficult. And that the pump therapy can do, because you can put different basal rates in these patients, and you have with automated system, even as the sugar falls, the insulin pump will give you the less amount of the insulin continuously. When sugar increases, it will increase the insulin infusion also, and sometimes even it will stop too. And that's the benefit of this insulin pump. And even it can give multiple time bolus also every 5 minutes if sugar is high and is not getting controlled too. So that's the beauty of this advanced hybrid closed loop system. All older insulin therapy, including MDI with blood glucose monitoring, which is very popular in our country. Some of them are on continuous glucose monitoring with multiple daily insulin injection. Some of them are older insulin pump along with blood glucose monitoring or CGM. And some of them are even older insulin pump with sensor augmented pump. Still, none of them could achieve tight control of time in range more than 70% unless you have hybrid closed loop system or an advanced hybrid closed loop system. And that's what is available. And we had also shown this data in ATTD from India, that we are achieving in our patient almost 75 to 80% of the time in range. This is the data from India, as I told you, in 219 patient data last year we had shown, and this is what 75% of the time they are achieving time in range, and this is which is comparable with any parts of the world. Let me talk last part of this, that a patient with an 11-year-old type 1, 2.5 years of the age, patient was on insulin. We started with MDI. Patient was not getting good control, lot of hypo and hyperglycemia. Relatives were asking that, can we put her on an insulin pump? Can we put him on an insulin pump? It was older pump which we had used with CGM also, but still we could not achieve a tight glycemic control. And the multiple times the HbA1c was still higher, and sometimes the sugar was getting controlled. So only for the convenience, patient was put on insulin pump, which was an older pump, and we had put on continuous glucose monitoring, which was also for convenience. And this is what the story. But before 1.5 years, and this was the sensor reading which we used to get. And as soon as we put him on a advanced hybrid closed loop system, you can see significant change. There is no hypo, and there is a almost 70% of the time person is absolutely well controlled. Even this time patient actually has not taken the bolus dose, and still you can see the multiple bolus was given by automated insulin delivery, and sugar is absolutely well controlled. So this is what the beauty of this advanced hybrid closed loop system. To summarize my talk, HbA1c is the gold standard for diabetes management. However, it does not demonstrate a holistic and very individualized glucose profile. Glycemic variability is associated with increased risk of severe hypo, diabetic complication, and reduced quality of life. Time in range provides a closer view of the person's glycemic status, aids in a better glycemic control. To improve time in range for type 1 diabetic person, use sensor augmented pump, and now advanced hybrid closed loop system is available to our country. International guidelines have now been updated to include consensus on continuous glucose monitoring and use of pump for type 1 diabetes. A need exists to move beyond A1C alone and also consider CGM data and insulin pump therapy for optimal diabetes management. With this, I thank and I invite all of you for World Congress of Diabetes, which Diabetes India is doing along with Diabetes Asia Study Group from 13th to 16th of Feb at Ahmedabad, which is at Forum Convention Center. And we are having more than 2,000 registration already done with 300 fellows who are going to get their fellowship of Diabetes India, and more than 200 abstracts had already been accepted. With this, I invite you also for a technology meeting from 9th to 11th May at Jaipur. Those who are interested in more in CGM and pump therapy, to learn more about insulin pump school and continuous glucose monitoring academy, which we run along with this technology meeting, diabetes technology meeting at Jaipur. So I invite you, all of you. And once again, thank you to my good friend, Dr. Jyoti Dev, Dr. Jayant Panda, Dr. Kanungo, Alok Kanungo, and Dr. Ashok Kumar Das. Thank you. Thank you very much.
Jayant, it was an excellent talk. Jayant is there? Jayant? Am I audible, Alok?
Yes, sir, you're audible. You're audible.
Yes,
So
you
I
are.
think it was excellent talk by Bansi in his chosen area of technology, and we'll discuss about it. He will join the panel, and I'm extremely happy now to invite Professor Dr. Alok Kanungo to speak on a topic which is extremely important: diabetes in the young and the differential diagnosis. And Alok had been working in the young diabetes for a very long time. He's a member of our YDR Young Diabetes Registry, and also had worked with Sanjeevi for some time in Karolinska, and he had a PhD also from the Kotak Medical College and the Utkal University on the diabetes in the young. Many hats in the credit. He has a good number of diabetic in the young, which he takes care. Over to Alok for his talk.
Hello, welcome to Nucd. I am Dr. Alok Kanungo. I have to give a talk on diagnostic challenges for type 1 and young diabetes. In fact, previously, young diabetes means it was always type 1 diabetes. Younger in age group and diabetes, sometimes with or without keto diabetes. But time has changed. Many different types of young diabetes are now coming to our day-to-day clinical practice. In diabetes in the young, first is type 1. We also find a large number of type 2 diabetes in young population. MODY or maturity onset diabetes in the young. A lot of work has been done in the south by Nihal Thomas, Dr. Mohan and others. LADA, we have done a lot of work on LADA, latent autoimmune diabetes in adults. There is malnutrition modulated diabetes mellitus or MMDM, which was primarily done by Professor Samal and Professor B.V. Tripathi from my center. And now we are continuing this work. Maternally inherited diabetes and deafness and other genetic forms. and FCPD, fibrocalculous pancreatic diabetes. They are all coming in the age group of young diabetes. If you look at this cartoon, you can see in age group from 5 to something like 35, you find that a lot of type of diabetes are coming, like type 1, MODY, type 2, MMDM, and maternally inherited diabetes, and many other things. So age is no more a final decision for diagnosing diabetes. So how can we diagnose diabetes at an early stage and correctly? Type 1 is the most frequent endocrine disease in children. Diagnosis in children increasingly is becoming challenging, and that is why correct clinical management starts with timely and accurate classification of diabetes as it guides therapy. Depending on the diagnosis, you will decide the therapy. Early diagnosis of the children with newly diagnosed type 1 diabetes is very important, as there is a possibility of diabetic ketoacidosis, which is life-threatening. Let us come to type 1 diabetes, which is an autoimmune diabetes. What are the features? Young age of onset, mostly children. Of course, nowadays, type 1 diabetes in young adult and elderly has also been accepted. The presence of one or more autoantibodies like GAD65, IA2, zinc transporter autoantibody like that, and absolute insulin requirement for glycemic control. Type 1 cannot be controlled by oral drugs. You need insulin for glycemic control. Decrease C-peptide level. When you measure, C-peptide values are below normal, and that suggests type 1. HbA1c is not very high because onset is not very long. Autoreactive T cells can be found out. NK cells, natural killer cells, can be found out, and your genetic markup helps in diagnosing type 1. But clinically, these are the filters. So age-specific rates of type 1 diabetes can be from 6 months to 35 years, both elderly and younger group. You can have the peak at 10 to 14 years, or 5 to 14 years, 15 years is the peak for type 1 diabetes. You get more cases. You can see this is a normal pancreas on the left side, and insulitis is the second. Histological examination of pancreas tissue shows very severe insulitis with massive mononuclear cell infiltration in and around the pancreatic islets in our patient. Though these red marks are showing that this is problematic. So this is the detail of how we go about. As previously we were taught when we were young that it is a suddenly type 1 diabetes comes, erupts, but it is not the fact. It passes through different stages. Pre-diabetes stage is variable genetic and environmental risk of type 1 diabetes is there. And then stage 1, stage 2, stage 3, and even stage 4. If you look at autoimmunity, it's present in all the 3 stages. Beta cell loss is present in all 3 stages. Dysglycemia is absent in stage 1. Hyperglycemia is present in stage 2 onwards. And symptoms are absent in 1 and 2, but in stage 3 they are present. So stage 3, you can diagnose clinically a case of type 1 diabetes. What are the autoantibodies in type 1 diabetes? ICA, islet cell, insulin autoantibody, glutamic acid decarboxylase or GADA, IA2 insulinoma associated antigen 2, thyroxine pyrophosphate is also IA2 beta A, zinc transporter, and other things. If any one is there, there is a suspicion. If 2 are there, it is a confirmatory, and 3 is a definite thing that this case is an autoimmune type 1 diabetes if 3 antibodies are present. I am presenting 2-3 cases, 4 cases. Case 1, known as Aradhya Panigrahi, a 10-year girl child, thin built, 35 kg, and her C-peptide was 0.56, very low, and stimulated C-peptide was 1.23. GAD was more than 2,800, very high, and IA2 was also very high. So diagnosis was very clear. A typical type 1 diabetes, thin built, with a history of ketoacidosis, type 1 diabetes with hypothyroidism, and requiring insulin for management. Previously, a diagnosis was requiring 12, 6, 4 and Lantus 16. Now also almost managed with little, depending on the work activity. She is feeling better and active after continuous insulinization. My second case is very interesting. Himanshu Raut, symptom of acanthosis nigricans and bedwetting, no ketoacidosis, 10-year boy, 40 kg. And when he came with a diagnosis of type 1 diabetes, we revised the diagnosis by doing certain tests. C-peptide PP level is nearer the borderline, and fasting is also better than type 1 cases. GAD is positive, IA2 is positive. Whereas C-peptide is still retained. And we repeated the C-peptide and the values are coming like that. So our diagnosis is PP was 384, HbA1c 10.9. This suggested that we should look for type 2 in this child. And at present, he is 79 fasting, 96 PP, and his HbA1c is only 6. He is very well controlled. Previously, we started with insulin, Lantus, and then started little vildagliptin, glycomet. Now everything is withdrawn and the child is in metformin 3 times daily, glycomet SR 500 3 times daily, and you saw his glucose values 79 and 96. So this is a very interesting case, and this case can be a double diabetes where type 1 features are there and type 2 features are there. Future will decide where he is leaning more. Case 3 is Himasri Naik, type 2 diabetes with recurrent pancreatitis and PCOS. She has ketoacidosis. She was taking a large quantity of coke and kurkure consumption, and she landed up with recurrent pancreatitis and ketoacidosis. On examination, we found her C-peptide level is preserved, GAD is negative, IA2 is negative. So we rethought that this ketoacidosis can be Coca-Cola induced ketoacidosis or fasting ketoacidosis, some other thing. And we started treatment with insulin, Tresiba and Fiasp. Then Fiasp reduced. Now we added Crayon, and our gastroenterology team thought it is a case of moderately severe acute pancreatitis, either biliary or genetic, 2 episodes of pancreatitis in 6 months, diabetes mellitus recent onset, ultrasound shows no biliary sludge or calculi, serum lipase is 398 and amylase is 527, not very high. So we thought and diagnosed it as a genetic pancreatitis with type 1 diabetes, and the patient is under control and continuing. My last case is, and we also studied the CMBG and other things. His target range was very well controlled, 68% within the target range and 18% on the higher range. So this child is very well controlled with the present medication. You can see his blood sugar is almost in the target range for most of the time. Very few slides it is going up little in the morning hours, early morning. Otherwise, it is fairly well controlled. And these are the very few upsets and downs, otherwise on the range. My fourth and last case is Soumyajit Naik. Detection year is 14 years. Went to he only while playing in the school, he had automatic rounding of his hands like athetosis and chorea, and he was taken to the endocrinology department of local medical college where he was diagnosed type 1 diabetes, and after 4 days he came to me. I found his type C peptide was 2 plus, and C peptide PP was 7.11, GAT negative, IA2 negative, and blood sugar has come down, and he was initially with insulin, and then we have almost stopped insulin for this case. So Soumyajit Naik was admitted to a local hospital, as I told, and treatment was started on basal bolus, and all other investigation did not suggest anything. So early onset type 2 diabetes mellitus in young, this is a very fit case that this is a early onset type 2 diabetes mellitus, is now off insulin. So in type young diabetes, you can see type 2 diabetes in the young, you can see double diabetes, you can see FCPD and other things, and a maturity onset of the diabetes young can be seen. And these are all different types of MODIs, MODI 1, 2, 3, MODI 11, and all those things can be done by genetically, think 3 generation diabetes in the young. MODI can be 14% is glucokinase, 75% transcription factor, and 11% is MODI X. And all these HNF 1 alpha, 4 alpha, 1 beta, all these things have significance. Our second, the third type is malnutrition modulated diabetes, which was worked in our center, Professor Tripathi, Dr. Samal, and then me. Patients with MMDM are young, lean, and resistant to ketosis. Absence of ketonuria and ketosis, in spite of very severe hyperglycemia, is emaciated young subject is the most significant marker of MMDM. Of course, we are no more finding many cases because of malnutrition is getting relieved in this country. In other countries also, they are wear like this. You can see bones in this chest. FCPD is another, not a true diabetes, lean structure, abdominal pain, steatorrhea, no ketosis, X-ray, ultrasound, abdomen, diagnostic features, and you can see some diagnostic features in the ultrasound and X-ray. In level 1, lumbar 1 vertebral level, we find chains of stones, and that is diagnostic of FCPD, where there is abdominal pain and steatorrhea. There is no ketosis. X-ray and ultrasound abdomen are diagnostic. We have done the studies on immunology, genetic studies on malnutrition modulated diabetes mellitus with Dr. Professor Sanjeevi, and Sanjeevi and our group have done many work on MSc class 1 chain related gene A alleles, distinguish malnutrition diabetes from IDDM and NIDDM. And treatment options vary for each type. Type 1 insulin, fulminant diabetes insulin, LADA insulin, sitagliptin in some cases, MMDM insulin, oral tablets, MODI sulfonylurea in some, and insulin in some, neonatal diabetes sulfonylurea, mitochondrial diabetes sulfonylurea, and type 2 diabetes in young on oral tablets. So, some common points: clinical judgment is essential, history provides clues, laboratory investigation like C-peptide, antibody assay, genetic marker, and radiology are important. Therapeutic approach needs careful consideration, and wrong diagnostic leads to unnecessary use of drugs like insulin and other drugs. So, dear friends, thank you.
I think this has been one of the very important talk, Alok, and you have very painstakingly have gone through this, and we'll have some discussion at the discussion time. I would like to know whether the type 1 diabetes, Somjit Naik, whether it was, I thought with the type 2 diabetes, whether he had something like a hyperosmolar state that produced this, because we have seen that, Ram, in the type 2 diabetics presenting with hemiplegia, we know that, presenting with some focal neurodeficit, and wonderful cases, and very forceful, very good talk. And I'm very happy to know that you are still continuing your work on the MDM. We should not give it up. At least one of you, one person from the country is pursuing that. It's a very heartening to note. And with this note, now the next will pass on to the next part of the program. And may I now invite Stuti, call all the people. Stuti. Yes. Now we have finished this type 1, the CGMS and diagnosis. Now we have the panel discussion. I request Jan to moderate this. I will start to invite Dr. Archana Sarda. Archana, are you there? Has she joined?
No, sir, she hasn't joined.
Stuti, so she has joined. Archana, where are you? Can you see you?
No, sir, she hasn't joined yet.
Has not joined, but did you call her?
Yes, sir, I have called her.
She joining, she said? Okay. So I must tell you that Ram Archana is one of the persons in our country who is totally devoted to type 1 diabetes care. And in the city of Aurangabad, and consequently globally, her impact is felt. She has a large number of type 1 diabetics where she provides what you said, 360-degree care. Her psychosocial management, the involving the mothers of the children in the care. He's going to the schools and speaking about it, and fighting for the rights of a type 1 diabetes children, and distinguished her as the champion of type 1 diabetes in our country. And I'm really very happy to, she'll be joining us in some time. And we have the other people who have joined. 1 minute, I'll just see for the others to join. We have Anup, Bansi and
Me
Anup.
and Ram.
So I'll start.
I'm here anyway. So
Can I start the first question? We can have a discussion. I just wanted to know from Ram, what is the status of the vaccination for type 1 diabetes today? While I was in England, and subsequently we have been listening about some peptides being developed into vaccine for preventing, it's the you know it much better than anybody else here, immunogenetic disease. So for the who have the genetic background, whether being vaccine, a peptide vaccine raised against the autoimmune trigger, will it be of any help?
yeah, a lot of studies were conducted during the last 2 decades with vaccines, but currently nothing is, to my knowledge, under clinical development or on the verge of approval. I think that right now the focus is all bringing teplizumab into real world practice, and whether we can use teplizumab in an early stage of newly diagnosed type 1, and whether one course is enough, or should we do 2 courses at 6-monthly intervals. That's one focus. And other focus of work that has been happening is encapsulated islets, islet transplant with an encapsulation to prevent immunologic destruction so that they can produce insulin. So a lot of like Vertex is one company, and a couple others are currently working on encapsulated islet transplant, as that's, I think, is the area where the things are heading right now. Unfortunately, other immunomodulations have not taken off very well. Yeah.
Ram, you remember that we had a professor of pediatrics whose son was also United States, Neil. He was working on this islet cell transplant from the city of Mumbai.
Yeah.
Remember that her son was working, and that time she used to talk about encapsulating the islet cells to prevent rejection and to.
That's correct.
Yeah, so that is still valid. It's going on. That trial
that is still going on. That is one thing that is still going on right now, and expanding the indications and access of teplizumab, because that's the only one after 20-30 years of a lot of immune intervention trials has come up,
And there are studies that are being considered for attacking in a multi-pronged attack. For example, anti-CD3 is one mechanism, and blocking the co-stimulatory signals, anti-CD28, and all those. If you can use more than one immune modulations targeting at different pathways of autoimmune beta cell destruction, whether that's going to be much more of help. But the problem is all these drugs, when we use all these immune interventions, they have a high risk of toxicity, and that becomes a limiting factor. And approval by the regulatory agencies to give something which has high safety, concerning safety profile becomes a challenge. So that's why that needs to be balanced again, the benefit in terms of C-peptide preservation, beta cell preservation, delaying the onset, all those things have to be weighed in. But right now, the interest is definitely moving in these two directions.
Ram, my question, final question from my side is, we have just heard about teplizumab, read of teplizumab. You are the person who have used it. So I'd like to know a fact sheet from you. How do you use it? What is the current status? You are saying now you like to give 2 doses 6 months apart. Will it produce 4 years of remission? What are the evidences? I mean, whatever you know, I don't think you will be.
Yeah, that's right. No, I think the administration
and how much it
is
costs.
done. Yeah, it is. I don't know the exact cost, but it will be quite an expensive drug, because here most of the payment is done through the insurance. If the insurance doesn't approve, most of the people cannot afford it. I think it will at least run, my understanding is 50 to 60,000 US dollars for the entire course. So it is administered at a daily intravenous infusion, which goes over 30 minutes. The dose is calculated per kilogram body weight or per square meter body surface area. And what they do is they start with a small dose, and over the first 5 days, the dose is escalated progressively. And then from day 5 till day 14, they stay on the same dose. So they go to what we call here as infusion centers, where every hospital has an infusion center. The people go there, sit for half an hour, take the infusion, wait for some time, and go. And because of the side effect profile, particularly drop in the blood counts, lymphopenia, rash, and so they had to continuously check their comprehensive metabolic panel, blood counts, and physical exam for any rashes or any other unusual symptoms. Cytokine mediated reactions, all those will be monitored by the nursing team who is supervising it. This was a standard, but the challenge is it's not practical, because it's hard to expect anybody to go every day to an infusion center, sit there for a few days, and then go do that. So the company has come up with some outsource teams where people can do it as at home also. There are home infusions. So the teams go to the patient's home and do that. Or we do a mixed approach where 5 days they do it in the infusion center, remaining 10 days they do it at home. So various methods are being tried. So it is not that they just take a simple treatment at home. It is like giving infusion similar to analogous somewhat to chemotherapies kind of a thing on a daily basis for 14 days. When I said about 2 courses, the one study that I very quickly showed was a study in new onset type 1 diabetes. Kevin Herald's group did it at Yale, and they did it at 2 infusions at 6 months apart. So instead of 1 infusion for 14 days once, if you give it at 2 infusions at a few months apart, whether this has an additive effect in terms of prolonging the beta cell function, especially when you are approaching at a slightly later stage in the natural history, when they have already become stage 3 of type 1. But as of now, it is not approved. We don't use, if somebody comes, we keep getting requests from the patient that, oh, I want to take this teplizumab infusion. But by the time they come here, they have antibodies positive, yes, but they're already A1C of 7. So there is no point of doing, because it is to be given for pre-diabetes or impaired glucose tolerance patients with antibodies. So it is not that we have a huge number. We have a handful of patients who have been taking it, but the number is gradually increasing. Insurance coverage is increasing. That's where it stands today.
Ram, just to add to your opinion, the first teplizumab girl was a twin. Her sister had type 1 diabetes, so she wanted to prevent her, and she started taking it at the age of 14 and maintained up to 17 years. After that, again the diabetes came, and the expenditure was 90,000 USD. So that is what the literature says.
No, that is true. That is a major limiting factor. I mean, affording is a major challenge only when the insurance companies cover it, and they obviously want to make sure that the guidelines based criteria are met. That's the whole thing. Because as I said, the TN10 study, as I showed, the delay in development of type 1 stage 3 was about 2 years. So more than actual delay, nobody can guarantee that we can prevent diabetes, but even if you are delaying, you are preserving the beta cell function and preserving C-peptide. That has got long-term ramification in terms of better glycemic control, lesser risk of complication. That's the whole focus of treatment rather than 100% prevention.
We should hope that the drugs will be cheaper gradually for the mass use, and let us hope for the best.
Yeah, that's what we are also hoping here. It is even in US, it is not an easy thing for this drug to prescribe this. It's a lot of efforts involved. Too many people get engaged. Multiple sets of lab work. It's an ordeal. It's like a process. Yeah.
What do you think of these mixed diabetes with antigen antibody positive but C-peptide normal, and they are responding to somewhat oral drugs? What
No,
is your
absolutely.
take on?
No, it is absolutely. I agree. You brought up a very good point, mixed diabetes, because just because I mean, I have seen there are two ways. People present, we have significant African American population, Hispanic population who are at a high risk of type 2 diabetes. You have acanthosis nigricans. I've seen adolescent African American obese kid of 18 years, 20 years with severe acanthosis nigricans. You present like type 2, you do the antibody profile, and they are GAD positive or IA2 positive. So that means they have both. Just because, I mean, antibody positivity indicated they have an underlying autoimmune disease process, but at the same time, phenotypically, they are type 2. So type 2 is more common. So just because they have type 1 pathophysiology doesn't prevent them from developing type 2 and vice versa. So both coexist, we see very often. And many of these patients, I have put them, initially they present with very severe hyperglycemia. You put them on insulin later, you think that they are type 1, but then all the antibodies are negative. And then they respond very well to just metformin or SGLT2 or GLP-1s, etc. And on the other hand, many type 1s, as they grow older, they tend to gain weight. Just because they become childhood onset type 1, by the time they are 30 years age, they are overweight or obese, and they are having the cluster of metabolic syndrome kind of abnormality. In those people, when I write a prescription, I write diagnosis as because we prescribe them GLP-1 receptor agonist. Actually, just recently, there was a cardiometabolic conference in our center at New York University. I gave a talk on use of GLP-1s in type 1 diabetes. What is the current state? I gave a talk on exactly the same topic. So type 1 diabetes patient, as they grow, they put on weight, they become obese, and they have a superimposed type 2 pathophysiology. And then we add on top of their insulin. So the diagnosis in their chart, I will put type 1 diabetes, type 2 diabetes. I will put both. You can have two diabetes together. There is no one single diagnosis. There are two different diseases we are dealing with here. And I put them on GLP-1 receptor agonist, metformin, and insulin will continue. It is very common. And LADA, as you very well know, when with late Jerry Palmer, I worked on LADA, and we see a lot of patients of so-called phenotypic type 2s manage all many years, and suddenly we find in their 50s and 60s, they become insulin dependent, and late on, suddenly at a much later course of natural history, we diagnose that they had autoimmune diabetes, which is basically fits into our LADA bucket.
We see here similar cases also, and there we have registered them. And this is very interesting to know from you. So we are following the same process here.
Exactly the same thing. Yeah, it's universal. Of course, we don't see, the other type of diabetes you describe. Modi, we do see. We do the genetic testing for Modi, and whenever there is a suspicion of Modi based on 3-generation family history, younger age at onset, we suspect. First thing is we obviously do all the 5 autoantibodies, make sure there is no autoimmune component, Then we send it for monogenic diabetes genetic testing panel to classify whether they fit into MODI and in what group they fall into.
And there is one TCF7 alpha gene. So we are not able to do it here. If it can be done, possibly these double diabetics and others we can decide whether they are more towards type 2 or more towards type 1. TCF7.
That's correct. Yeah. Yeah, that's correct. Yeah. We don't routinely do
type
it,
2.
but if there is a case, we send out the samples sometimes.
But TCF72 is more towards type 2, am I correct?
Yes.
Yeah, it is more towards type 2, correct, if there is present.
The other
Type
thing,
1 is more homogeneous disorder. It's very easy to, type 1 is a more, I would say, homogeneous. Like autoantibody positivity is a very strong indicator. If you do 5 antibodies, if something or the other is positive, that is definitely type 1. But absence of all 5, it is very hard to say it is type 1. We just say that there is no evidence of autoimmunity, although antibodies could have been there and disappeared depending on how long the patient had diabetes. But type 2 MODI and other types is just a heterogeneous bucket. There could be a lot of overlap and very hard to compartmentalize, and there is a lot of overlap here.
In my work, I have experienced that if somebody is IA2 positive, within 6 months he is insulin requiring and goes to type 1. But GAD antibody positivity is also seen in normal persons, controls. So IA2 gives a much better information regarding the progress of the disease, which is very fast. That is my observation.
No, it is, I 100% agree. We see the same pattern here because GAD antibody, you are right. We do general population or even on type 2 diabetes, sometimes they get a GAD antibody. It's very low titer GAD positive. It's been there for a long time. And there are patients who have GAD antibody positive. They don't have any other antibodies, never progress to dysglycemia. They can continue for years. They are following them up. But IA2 or even zinc transporter at times, I think that is a very high predictor of quicker progression.
Right. Archana is there.
Diabetes.
Archana, have you joined?
No, sir, she's trying to connect, but her internet is creating some issues.
The other thing you
Also,
like,
okay,
I'll just ask you one thing, which is a little ridiculous question, but tell me the status of the steroid and cyclosporin for prevention of type 1 now. Given up?
Given up. I don't hear at all anything. Yeah.
Okay. And there was something to do with the nicotinic acid, niacinamide or something like that?
Yeah, that was all there, but nothing is currently being pursued right now.
No.
The third thing, which is our major problem today, Ram, is the type 2 diabetes in the young. And this particular group is increasing. I chair the diabetes in the young in the country registry. And we call it in our nickname, it's a malignant form of diabetes. As you know that that they're obese, they're hyperglycemic, the sugars are very high, they get complications early, the mortality also is earlier. So what is your take on that? If you give insulin, weight will increase further. They're usually obese. Type 2 diabetes in the young, they're usually obese. We give them
Please, sir, go ahead. Yeah. So I agree. We see the same pattern.
Same pattern. So what do you do? It's a very great counseling, CBT, things like that, or are you able to achieve normoglycemia in them by the classical methods?
Yeah, we do use them. We do treat them. We see very often these young people. There are two overlaps that happen here. One, in addition to lifestyle-related unhealthy eating habits, lack of physical activity, weight gain, and all those that we see everywhere. And secondly, the significant overlap with the polycystic ovarian disease hyperandrogenic state in young and adolescent women, because the pathophysiology of PCOS-related insulin resistance, obesity, metabolic dysfunction, cardiometabolic risk, it is very close to the type 2. We do see a lot of young women with PCOS, a kind of a phenotype, and they have diabetes also. And so it is very hard to differentiate how much of each of the genetic predisposition is operating here. And secondly, a lot of people here also have eating disorders in the adolescents, and that is another important consideration. And managing that adds an extra challenge in terms of their achieving good glycemic control. But today, what we do, standard of care for all these adolescents with type 2 diabetes with no antibody positivity, we just treat him like type 2 in adults. I mean, they do metformin first line. We use preferably either SGLT2 or GLP1. We have now that we have Mounjaro available, and we hope that retatrutide could be available in another year or so with a very strong weight loss data that recently got published. Triple agonists, and but Mounjaro is available, although there were supply chain issues, not being able to get the drug very easily, but the things are getting worked out. And here the guidelines are very strict in the sense that if somebody has diabetes, they get either Ozempic or Mounjaro or Trulicity. But if they don't have diabetes, insurance doesn't approve use of these drugs, then we will have to go for Wegovy or Zepbound for these patients. So I think use of GLP
again. Tell the drug again. You go for if the
no the one. See the drugs are of course dulaglutide, which is available in India, Trulicity, that we use it for diabetes anyway. But with the use of Ozempic and Mounjaro, Trulicity use has gone down. So we use semaglutide, Ozempic for diabetes, and the version of semaglutide for obesity without diabetes is Wegovy, WEGOVY.
Yeah.
And
we have just got the drug in our country. Just got the drug.
Oh, Wegovy is available now?
Yeah. Just available.
Okay.
So
Okay.
they have the approval, it is through.
And the second one is our Mounjaro, which is tirzepatide. Mounjaro is available for diabetes, and the version of Mounjaro for obesity is called Zepbound, ZEPBOUND, ZEPBOUND. In the similar, yeah. So that leads to a significant weight loss, 15-20% weight loss, which is very close to what one could achieve with a bariatric surgical intervention. So and morbidly obese people, obviously, we tell them.
Zepbound is also GLP-1, GIP, and glucagon combination, or only
no,
GIP?
It is not glucagon. It is GLP-1 and GIP-1. It is same as Mounjaro, tirzepatide. Yeah.
But
so I think with the three drug combination,
Mounjaro and Zepbound, what is the difference?
It's the same, exactly same as Ozempic and Wegovy. Exactly same.
Okay, good.
So we use the same three drugs, and if the sugars are still not controlled, insulin is a fourth, and I still use pioglitazone quite a lot, except that some weight gain. On one hand, we are trying to make them lose weight with all these drugs, and other hand, pioglitazone. But when the insurance doesn't cover and they don't have they have challenges in paying for the drugs, I still use quite a few bit of pioglitazone today. Yeah, as an add-on drug.
Correct. I think I just wanted to know that all the neonatal diabetes goes to pediatric endocrinologist, or you see them sometime?
No, they all go to pediatric endocrine. Here, the compartmentalization is quite a lot in the sense that we see only 18 and above, and below 18 we have pediatric endocrine department. They manage everything.
We see both transient and permanent, and as Alok said, sulfonylurea has been stood out as the prominent drug for them. Because there are many pediatric endo in the country, so they refer to us. I think we had a very, very great discussion, and it's my honor and privilege to thank Ram first for having come back and given us this great insight. And then, Ram, please join us virtually more often. We'll not trouble you too much.
Yeah, I'm happy to do virtual at this time in the morning is fine, because I'm happy to join anytime and be part of the discussions. And thank you, sir. It's nice, and thank you, Doctor.
You always loved India, so you are coming back to teach. That's great thing happening. Yes, you can continue. Please continue.
Yeah, no. I just wanted to thank you and Alok, and also Jayant Panda for involving me here in this program.
Ram, you accept our permanent invitation for Nucd. Please accept.
Okay.
We want to learn from you. We want to learn.
No, it's a mutual learning. It's a mutual learning, because I learn a lot of things that are happening because I'm kind of out of circulation on a regular basis. Although I visit very often, 2-3 times I come to India anyway, to Bombay. So still have 1 foot there, 1 foot here. So we'll see. Thank you.
Very nice. Thank you. Thank you very much.
Okay, sir. Good evening. Bye. Take care. Thank you.
Good.
Thank you.
Now we pass on to the next session. That is session 5, and it is about it's about a very important thing: future of oral anti-diabetic drugs. And this is a very important session organized by US Pharmaceuticals. And I'll request Alok to take over. We have topics regarding integrating DAPA plus metformin for comprehensive diabetes care with obesity. Very important. And I had a paper recently by Anup Mishra again on this particular combination, DAPA, META, and very important. Second is early diagnosis and intervention of heart failure in people with diabetes. As you know, the heart failure therapy has undergone a paradigm shift. New drugs have come, ARNI, ARB, the dapagliflozin, and of course, I told beta blockers, MRAs, and that has changed the scenario of blood pressure treatments. We have a wonderful talk by Dr. Sibendu Burma. No, sorry, by Dr. Bimal Sanmugam. Sibendu will be giving the first talk. And then we have the two other talks we have a talk by Dr. Bimal Sanmugam. I told about the heart failure. We have Belinda George. I have heard her. She speaks so absolutely fabulously from, I think she is in the St. John's now, professor of endocrinology. Belinda will speak about the real world evidence of vildagliptin, the knowns and the unknowns. I really like the title that you have given, Belinda. Then we have a panel will be headed by Dr. Joyce Siswai, one of the endocrinologists from our place, and the above speakers along with Dr. B.R. Kannan will be the participants. Over to Alok to conduct the session. Alok?
Yes, sir. Stuti here. Hello.
There? heart failure drug, both in diabetics, non-diabetics, and has changed the scenario of that. And we have a lot of papers to that effect. We have the DAPA-HF trial. We have the so many trials of dapagliflozin with heart failure, which have proved, which has put dapagliflozin on the top of the world. And we'll be listening about it more, and we'll take it forward. Now, Belinda will be going to speak to us regarding the very important topic. She's going to talk about the vildagliptin.
Real world evidence of vildagliptin, the knowns and unknowns.
Unknowns and no, vildagliptin has stood out in our country as a great drug. It can't go to USA. They don't want to take it to US either. And vildagliptin is 50 and 100 strength is available plenty in our country, and one of the blockbusters in the clinical practice. And we have used either strength, and vildagliptin is fabulous. And Belinda is going to speak about it. So, Stuti, what Belinda is saying is coming.
Sir, Dr. George is joining in 5 minutes.
Who?
Belinda George.
Belinda George.
Jayashree, are you there? Dr. Jayashree, are you there?
Yes, sir, she is here.
Jayashree, good morning, good afternoon. Hello.
Sir, she has joined, but she's not replying. She hasn't unmuted herself.
Dr. Jayashree, I'll just
was taken. And in these patients, they had actually taken people who had diabetes and renal microangiopathy. So where there was Kimmel-Steele-Wilson's disease. And these patients also had cardiomegaly and advanced heart failure. They found that in these 4 subsets, there was diffuse myocardial fibrosis, but there was no coronary artery disease. So they have reported first in 1972 in American Journal of Cardiology that in patients with diabetes, there can be cardiomyopathy, which is being observed. So now, what is the prevalence of the problem? So this is a ADA consensus in 2022. It says that heart failure is under-recognized complication. It is seen in 22% of individuals with diabetes, and it could be a first presentation of a cardiovascular disease in diabetic patients. So is heart failure really seen in diabetic patients? What is the incidence? Do we have data? So these are 4 slides which give data from different countries. From the UK, we have data from the Caliber study, close to 2 million individuals who were followed up, of which more than 30,000 had diabetes mellitus. In this study, it was found that the most common complication of diabetes, of course, was peripheral arterial disease. It was followed by heart failure. The important observation here is that heart failure is more common than coronary artery disease or stroke. It's a common thing which we look for. Now we go for the data from the US. And in those patients who had hospitalized with self-reported heart failure, 1 in 2 of them had diabetes. And also this is the other way. First was patients with diabetes being followed up for heart failure. The incidence was around 14%. And those now, in the US, there was no such prospective data. We could just have the retrospective data. 2 types of retrospective data. One is that self-reported heart failure, around 50% of them had diabetes. Heart failure patients have diabetes. And similarly, among 462 hospital data, so even in this study, almost 40 to 50% of patients who have heart failure do have diabetes. So basically, the diabetes and heart failure are coexisting, and it is as common as in 50% in patients with heart failure and more common than coronary artery disease among population with diabetes. This is an interesting study from Netherlands, which says that they have taken 600 patients who are above 60 years of age and screened everybody. And they found that this is from this study that the 22% incidence comes up. They found that in patients with diabetes who did not have any other symptoms, who were just taken randomly for screening for cardiac problems, the incidence of undiagnosed heart failure was 22%. So they say in about 1 in 3% or 3 patients with diabetes have underdiagnosed heart failure. So now the relative risk and the absolute risk, this is the next thing. So this relative risk slide on the left-hand side, it shows that this is a meta-analysis of 12 million individuals, and the relative risk of heart failure associated with diabetes mellitus is shown. It says that diabetes confers a slightly higher risk in women than in men. The relative risk was 2-fold higher in women and 1.7-fold higher in men. So women at more higher risk. If you come to the absolute risk, one on the right, this is data from more than 3 million individuals in the Scottish primary care with a 10-year follow-up. So in this, the incidence of heart failure was higher in diabetic patients, and younger patients more than older patients, and women more than men had increased absolute risk for heart failure. So from this, what I would expect you to understand is that in patients with diabetes, it is possible that these patients have heart failure. The presence of heart failure in patients with diabetes is more common than that of a coronary artery disease or a stroke. This is a very important point because Whenever we see a diabetic, we first screen them for coronary artery disease, but we never have screened them for heart failure. Then on the other side, if you have a patient with heart failure, approximately 50%, 1 in 2 of them who have heart failure will have diabetes. So 1 in 3 of diabetic patients will have heart failure, and 1 in 2 of heart failure patients will have diabetes. So first, I have set the stage that diabetes and heart failure are commonly associated problems. Now, how does this happen? Can diabetes cause heart failure without hypertension, without coronary artery disease? How does it cause heart failure? So this is the pathophysiology slide. Very simple. In diabetes, we patients there are metabolic derangements. We see that there is insulin resistance, increased insulin levels, and when there is resistance, there is excess glucose also. This shuttles down the accessory pathways which are seen here, contributing, for example, to increased advanced glycation end products or increased reactive oxidation species. So basically, the high glucose level, the insulin resistance, all of this creates a metabolic milieu wherein there is apoptosis of the heart muscle. So apoptosis and restructuring of the heart muscle results in cardiomyopathy. This is another busy slide. One thing which I want you to understand from that, it is not only the high glucose level which is seen in a diabetic, but also the high lipid levels. It is not the peripheral hyperlipidemia, it is not the circulating hyperlipidemia, but the tissue hyperlipidemia. There is tissue hyperlipidemia in diabetic patients, and this causes myocardial steatosis, which is lipid deposition in the myocardium, and cardiac remodeling. So these kind of various explanations are being given. Basically, these two slides tell us that through various processes, diabetes can cause heart failure. And to summarize, these are the 3 types of problems which occur in the heart in diabetics. So the 3 different key changes are: one, excuse me, one, it can be cardiac fibrosis. 2, it could be hypertrophy. 3, it could be impairment of microvasculature. So these are the 3 common final pathways which result in damage to the heart, which are shown here. Now, if you look at this, diabetes can cause heart failure preserved ejection fraction, or they can have reduced ejection fraction. It depends on which pathway gets accelerated. For those with preserved ejection fraction, there is increased LVH and stiffness. There is hyperinsulinemia and microvascular damage. So if the patient has this type of damages, it goes for preserved ejection fraction. Whereas in those where there is lipotoxicity, like there is tissue hyperlipidemia and myocardial injury or wall stress, which results in apoptosis and replacement fibrosis, those kind of patients get in for reduced ejection fraction. So which is common. If you look into it, both these 2 slides tell us that both preserved ejection fraction as well as reduced ejection fraction are common in this population. So if you look into the subtype, this is analysis from the MESA study where more than 6,000 patients were followed up for 15 years. HFpEF was more common in diabetics than in pre-diabetics or non-diabetic, the one on the left side. The relative risk ratio was also higher for reduced ejection fraction. Basically, whether it is HFpEF or HFrEF, both are common. They're commoner in diabetics. They are commoner in those with pre-diabetes than compared to non-diabetic population. Next, what all in diabetes contributes to heart failure? So these are the four facets. First is insulin resistance. Increased insulin resistance is associated with. Second is the duration of diabetes. As the duration of diabetes increases, you can see that the heart failure also increases. And also not only the duration, but also the control of diabetes. Those with uncontrolled diabetes, they have very high risk of heart failure compared to those with controlled diabetes. Even controlled diabetes is at higher risk compared to non-diabetic. Other things which are associated is microvascular disease. This is a very important thing which we observe. Commonly, when you see a patient with nephropathy, you ask them to go, and in a diabetic patient with nephropathy, you ask them and go and look for retinopathy. But now here there is evidence to say that microvascular disease involvement could also involve the heart, and it is important to check for heart failure in these patients. And also the autonomic dysfunction, which is observed in diabetics, can also cause heart failure. So basically from these slides, I want to emphasize that heart failure may develop in diabetic patients even in the absence of hypertension, coronary artery disease, or valvular heart disease. And this is because of various mechanisms, because of increased insulin resistance, and it is also dependent on the glycemic status of the patient, the duration of diabetes mellitus, the presence of microvascular disease, autonomic neuropathy, etc. Both type 1 diabetes and type 2 diabetics are prone for developing heart failure. In type 1 diabetics, we are not so much worried about atherosclerotic cardiovascular disease. In those with nephropathy, we are not so much worried about atherosclerotic cardiovascular disease. But now we are worried about heart failure in this subset. So why is it important to diagnose heart failure in diabetes? From these two trials of losartan, we can see that in those with heart failure, the mortality is very high compared to those without heart failure. And it starts, so early, like even almost less than a year it starts out. In both the life and in the renal study, it was shown that there was a increased incidence of mortality in patients with diabetes and heart failure. So now, what is the message we have for the primary care physician, for the diabetologist? Basically, you have a patient with diabetes, you screen for heart failure. So that's the new thing which you can take home tomorrow morning or Monday morning when you go back to your clinics. Remember that when you have a patient with diabetes, please screen for heart failure. So let us see how to screen and what are the changes in management which we can bring about. So now how to screen? First, the natriuretic peptides, we know when these changes are taking place in the ventricular myocardium, we found that the natriuretic peptides increase. In heart failure, it has been very well established. In normal individuals, the markers are very low. And in settings where the myocardium is affected, these values tend to rise. So we will try to see whether these elevation of natriuretic peptides, whether it will help to diagnose heart failure in diabetic patients. So the normal cutoff of NT-proBNP to diagnose heart failure is more than 450. It varies with age, but at least it has to be more than 450. This is an excellent trial, which is a randomized study of 16,000 odd patients with diabetes. And in this, of the 12,000 patients in whom it was NT-proBNP was measured, it was shown that, remember, the normal cutoff to diagnose heart failure is more than 450 picogram per milliliter. So we can see that in this study, it was found that when the NT-proBNP cutoff is more than 125 picogram per ml, it was significantly associated with increased risk of hospitalization for heart failure. So this study tells something new. A lower cutoff value can diagnose patients with heart failure. Now, this is another study. This was in this study, it was found that the study on canagliflozin, they found that around 40% of patients had abnormal natriuretic peptide values, mild elevation. And in these patients where it was elevated for more than or equal to 125 picograms per milliliter, they had 5.4 times higher risk of getting hospitalized for heart failure. So from these data, it was observed that a cutoff of more than 125 picograms per milliliter can be used for making a diagnosis of an underlying hidden heart failure. And not only that, in this examine study where 5,000 odd patients were studied, the NT-proBNP levels at baseline and at 6 months were significantly associated with cardiovascular outcomes. So this study has set the stage that it is not only necessary to initially do an NT-proBNP level, but serial monitoring of NT-proBNP can help to predict patients who will go into heart failure. So this is a score which this scoring was developed from the SAVOT-IMI 53 and the DECLARE-FIMI 58 trial. You can actually risk stratify these patients. It is not only the NT-proBNP, but also the high sensitivity troponin T, which can be used to diagnose underlying hidden heart failure. So what does the guideline say? This is 2024 standards of care in diabetes. In asymptomatic patients, the ADA does not recommend testing for coronary artery disease, but it recommends screening patients with NT-proBNP to prevent development of full-blown heart failure. So screening is equally important in patients without symptoms or signs of heart failure. So this is the very important slide. It says that anybody with a risk of stage A, with high risk of heart failure, in case say diabetic patients, they have to get a NT-proBNP done. And very importantly, it has to be repeated every year. So now, along with urine albumin creatinine ratio, it is important to do an NT-proBNP. And this guidelines also recommend that once the NT-proBNP is elevated, it is important to do an echocardiogram and to look for these parameters, which could be help us to diagnose the heart failure. So basically, so what do we do now? What are the practical implementations, or what does one do if you diagnose this? Basically, lifestyle adjustment, strict glycemic control. We can use agents like SGLT2 inhibitor or the GLP-1 agonist, and aggressive management of the associated risk factors could be helpful in these patients. Not to forget that we have to exclude other conditions which could increase the natriuretic peptides like advancing age, CKD, atrial fibrillation, etc. So basically now what are the therapeutic conditions, therapeutic considerations now? Why should we focus on early identification of heart failure? Because heart failure drug therapies which lower the cardiovascular risk and improves outcomes are available. So besides the CKD or coronary artery disease, diabetes per se through various mechanisms which are shown in this figure will cause direct effect on the heart muscle. So now, what are the medications which we can use? Till now, we saw that in patients with stage A heart failure, that is with diabetes, who don't have symptoms or signs of heart disease, we have to look for natriuretic peptides. If natriuretic peptides are elevated, the threshold value is more than 125. Not to forget, the threshold to diagnose overt or heart failure will be 450, more than 450. But now here, hidden heart failure, if you want to diagnose, cutoff is 125. So if it is elevated, then you do an echocardiogram. So we understand this. Now, how do we treat these patients? In the Pontiac trial, it was shown that in this subgroup of patients in whom the NT-proBNP is increased, there needs to be an accelerated uptitration of RAS inhibitors and beta blockers. It can reduce events. And there could be a role of SGLT2 inhibitors, early introduction of SGLT2 inhibitors in these patients. So these are various guidelines. In patients with diabetes with established heart failure, SGLT2 is a class 1A recommendation. The next drug is the GLP-1 receptor agonist. It shows that the GLP-1 receptor agonist in patients with heart failure, preserved ejection fraction, and diabetes has shown to reduce NT-proBNP level. So basically, the final messages which I would like to convey, the final take-home points from my slides are: first, in a patient with diabetes, we have to look for heart failure. 1 in 3 patients with diabetes can have heart failure. 1 in 2 patients with heart failure can have diabetes. So diabetes and heart failure coexist. That's the first point. Second is, in all, how do we diagnose? How does this happen? Through various mechanisms like increased glucose levels, insulin resistance, increased insulin resistance, lipotoxicity, advanced glycation end products. So basically, diabetes and the metabolic milieu affects the heart in 2 ways. Microvascular dysfunction, insulin resistance causes LVH and HFpEF, or there could be damage of the myocardium and replacement by myocardial fibrosis, and it can cause reduced, both can happen. So how do we diagnose this? All stage A patients, as per the ADA, should be looked, we have to look NT-proBNP. Normal value to diagnose heart failure is, and usually what we are currently following is, to diagnose a stage C heart failure, to confirm stage C heart failure, 450 picograms per ml. But now, in patients with diabetes without symptoms of heart failure, if the NT-proBNP is more than 125, we should use it as a cutoff to diagnose heart failure. And we have to repeat every year this NT-proBNP along with urine albumin creatinine ratio. So if it is elevated, we have to see that these patients have increased. Now we are trying to focus at stage A and stage B and prevent patients from entering into stage C. So once patient starts developing symptoms, he himself will come and tell you that he has heart failure. Now the purpose of this entire discussion is to catch the patient very for which the subclinical damage goes on. And at this time, it is the problem can also be reset. We can treat the problem effectively. We can prevent the patient from going into stage C. So in those with elevated NT-proBNP, go for an echocardiogram and see whether there are changes of cardiomyopathy. Now, in case if I diagnose heart failure, what should I do? So the choice of the OHA, we can, first is important is lifestyle. We have to be more aggressive on lifestyle modification. The second step is the choice of the OHA. It's the first choice, we have to go for SGLT2 inhibitor. And next we can go for GLP-1 receptor agonist. Like that we can choose. And patients who are on ACE inhibitor or ARB, we have to maximize the dose so that we can prevent patients manifesting with stage C or symptomatic heart failure. Thank you very much for your patient listening.
Thank you, Bimal. Very nice and a very well thought of talk, very practical. It will definitely help our delegates to go ahead. Stuti and Dr. Belinda is there. Stuti?
Yes, sir. Good evening.
Yes, sir.
Dr. Belinda. Welcome to Nucd. So we are waiting for you. You have a very important work to do, the real world evidence of vildagliptin, the knowns and the unknowns. One of the most common practical molecule, vildagliptin, use is many people consume it and that's great. So please start your talk.
Shall I share my screen?
Yes.
Yes, thank you. Is it visible, my screen?
Yes.
Yes. So a very good evening to all of you. At the outset, let me thank the organizers for giving me this opportunity. And today we will discuss about some data with regards to vildagliptin. And vilda is a drug that all of us are extremely familiar with. So we will look at some of the evidence that's there, some RCTs, and a lot of real world evidence as well. So first of all, before we start, let's look at the incretin response in Asians with type 2 diabetes. Does vilda work better for us, as a population? And the data shows, yes, that Asians, when compared to non-Asians, respond much better to incretin-based therapies. Just a second. Yeah, so that is good news for us. These drugs work better for us and the efficacy is better. So vilda was one of the first DPP-4 inhibitors to actually be used in
prospective
experimental
data, we could
studies.
just have
And
the
here you can see
retrospective
the
data.
graph which shows
Two
DPP-1
types of
inhibition
retrospective
increasing
data. One is
GLP-1
that
levels and improving glucose tolerance.
individuals, the
And the
markers
agent
are very
here
low.
used was
And in
vildagliptin
settings
at
where
that
the
time.
myocardium is
So
affected,
when we
these
talk
values
about
tend to rise.
vilda as the
So
pioneer gliptin,
we will
it is
try
a
to
good
see
drug
whether
for durable first-line therapy for
these
early control
elevation of
And
natriuretic peptides,
when it comes
whether
to
it will
weight,
help to
there's neither
diagnose heart
weight
failure
gain
in
or weight
diabetic
loss. It's a
patients.
very weight
So
neutral
the
drug.
normal cutoff
And
of
we all know that
NT-proBNP
there
to
is very
diagnose
low
heart
risk for
failure
hyperglycemia
is
with these
more than
medications. They are
450.
also
It varies with
safe with
age,
regards
but
to
at least it has
cardiac,
to be more than
kidney, and liver.
450.
And
This is
if
an excellent
we
trial,
use once daily preparation,
which is a
particularly if you
randomized
have
study
fixed
of
drug combinations
16,000
which are
odd
once
patients
daily
with
preparations,
diabetes.
then the pill
And in
burden
this,
reduction
of the
is a
12,000
significant
patients in whom
improvement
it
when it
was
comes to management of
NT-proBNP
type 2
was
diabetes
measured, it was
patients.
shown that,
So
remember,
these are the
the
trials
normal
that we
cutoff to
have
diagnose heart
where
failure is
Vilda
more
was
than
tried as a
450
first-line
picogram per
therapy at the
milliliter.
initiation of
So
treatment for
we
type 2
can see
diabetes.
that
So you have
in this
the
study it
initial
was found
trial,
that
the EDGE trial,
when
and
the
the verified trial.
NT-proBNP cutoff is
The
more
initial
than
trial is
125
social trial,
picogram
which
per
showed that
ml,
there is a
it
reduction
was
in A1C of
significantly
about
associated with
1.6 to
increased risk of
1.9 in
hospitalization for
patients
heart failure.
who were
So this
initiated and
study
treated with
tells something
vildagliptin.
new.
EDGE
A
trial, of
lower
course,
cutoff
is
value
the
can
real-world
diagnose
evidence,
patients
which
with heart
looked at
failure.
the percentage
Now,
of
this
patients
is another study.
that achieved
Now,
A1C less than
this was
7% without
in this
weight gain
study.
or
It was found
hyperglycemia,
that
and
the
you can
study
see
on
that there is
canagliflozin,
significant
they found that
reduction in A1C once
around
patient is
40%
initiated on
of patients
vildagliptin.
had abnormal
And the
natriuretic
verified
peptide
trial is a
values,
trial that all of us are
mild
very
elevation.
familiar with.
And in
It's a
these
trial which
patients
looked at
where it was
combination
elevated for more
therapy
than or
as
equal to
first
125
option in
picograms per
type 2
milliliter,
diabetes
they
management,
had
as opposed to
5.4
always
times
initiating with
higher risk
metformin.
of getting hospitalized for
So
heart
all these
failure.
trials show that Vilda is
So
an
from
effective and
these
safe
data,
initial combination
it
therapy
was
for
observed
early
that
and aggressive control of
from these
glycemia
data, it was
to
observed
prevent
that a
all
cutoff of
complications
more
in
than
patients with type
125
2 diabetes.
picograms per
So this
milliliter
picture shows
can be used
results from the
for
verified
making a
trial.
diagnosis
This
of
trial was
an
basically
underlying
designed to
hidden
see
heart failure.
if sequential therapy, that is starting with
And not
one
only
drug
that, in
and
this
then adding on a
examine
second drug
study,
when
where
the
5,000
HbA1c
odd
target is
patients were
not met,
studied,
is better,
NT-proBNP
or
levels
whether
at
giving both
baseline and
drugs
at 6
together
months
upfront
were significantly
will
associated
achieve
with
better
cardiovascular
glycemic
outcomes.
durability
So
with
this
early
study
combination
has
therapy.
set
And
the
this is one of the
stage that
first trials
it is
which
not
showed
only necessary to
that early
initially do an
combination therapy or
NT-proBNP
initial
level,
monotherapy
but
strategy
serial monitoring
actually
of
works better
NT-proBNP
over a
can
long
help
period
to
of
predict
time,
patients
that the
who will
glycemic
go into heart
durability of
failure.
the initial
So
combination
this
is
is a
better
score
than
which
sequential
this
therapy.
scoring was
Patients who were
developed from the
initiated on
SAVOT
metformin and then
IMI-53
Vilda
and the
was
declared
added
that
actually had
it is
lesser
not only
short-lived
necessary
durability
to
than the one
initially do an
combination therapy or
NT-proBNP
initial
level.
combination therapy upfront. So this is one of the trials based on which ADA itself is based, the recommendation of starting patients on initial combination therapy in select cases. So we all know that when it comes to hypoglycemia risk, incretin-based drugs are actually very, very effective. Risk of hypoglycemia is very less. And this is data which shows comparing vildagliptin to sulfonylurea. And you can see that, as expected, the risk of hypoglycemia is extremely low with Vilda when compared to SUs. So it had much fewer hypoglycemic episodes, and good glycemic control and weight control was seen in patients who were treated with vildagliptin. Now, coming to cardiovascular safety of vildagliptin, we all know that all the new molecules that introduced for control of glycemia need to go through a rigorous cardiovascular outcome trial if they require, FDA approval for management of type 2 diabetes. So Vilda is one of those drugs that we use in clinical practice that do not have a dedicated cardiovascular outcome trial. So instead of that, here we have a meta-analysis of various RCTs done using vildagliptin, which includes about 17,000 patients. And it has looked at exactly all the same endpoints that an RCT of CVOT would look at. So it has a composite outcome of major cardiovascular events. It has myocardial infarction, stroke, and cardiovascular death. And you can see that vildagliptin fared very well in all of these complications. So based on this data, you can say that Vilda is cardiac safe drug, and there was no significant increased risk of any cardiovascular event in patients treated with vildagliptin. So this is a summary of all the cardiovascular outcome trials of the other major gliptins. So the first one is sitagliptin, which was found to be safe. Then you have cevoltimi for Saxa and Allo, and all of them, except saxagliptin, all other gliptins did not really show any red flag with regards to cardiac events. And based on the meta-analysis that we discussed earlier, Vilda falls into the same category, and we can think that it's safe to use vildagliptin in patients with or without heart disease. So based on all the published CV outcome trials, except Saxa, all other gliptins can be considered to be cardiovascular cardiovascular safe. So now we'll look at some amount of real world evidence to prove cardiovascular safety, simply because WILDA did not have a dedicated cardiovascular outcome trial. So if you look at here, you can see a combination of different types of studies. There are 3 meta-analysis. There is one RCT, which looked at 254 diabetes patients with heart failure. And of course, you have a lot of real world evidence in patients, in lakhs of patients, where cardiovascular safety was looked at. And data from more than 12 lakh patients shows that cardiovascular safety is not a concern with vildagliptin, and that we can safely use this drug in our patients with type 2 diabetes without having the concern of whether they will develop or worsen their cardiovascular risk. So when it comes to what needs to improve in our diabetes management, without compromising safety and efficacy, what are the things that we can do to improve patient compliance, improve the adherence, and also see whether keep it economical, and also see whether we can use it in inpatient management. So one of the things that we can do, because Wilda, the original prescription for Wilda has to be a BD dosing. The dose is actually 50 milligram given twice daily. So here is an innovative molecule, which is basically a slight change in the sustained release preparation of vildagliptin, which makes it feasible to be given as a once daily pill. So this sustained release provides quick achievement of drug plasma level, and that'll remain constant at a value within the therapeutic range for a longer period of time. And this modification assures that there is a control all day long. And we will look at some studies which looks at its bioequivalence with regards to 50 milligram twice daily prescription of vildagliptin. And there is also 90%, more than 90% DPP4 inhibition in 24 hours. And once we can give this once daily dosing, with regards to the patient, it becomes very convenient and also economic. So this is a couple of studies which has looked at the amount of DPP4 inhibition with patients who are receiving both preparations of vildagliptin. The first column shows you the 100 milligram sustained release product, and the second one shows you the original Vilda BD product. And you can see that the DPP4 inhibition across all the studies is more than 90%. So even with 100 milligram once daily sustained release formulation, we achieve the same degree of DPP4 inhibition. This is another study which is looking at the pharmacodynamic and pharmacokinetic profile of the OD versus BD preparation. Again, you can see that if you look at the mean concentration of vildagliptin across time, you will see that it sort of maintains a very similar profile, just like the BD dosing is given. So, and here on the right side, you can see again the DPP4 inhibition over 24 hours in OD versus BD preparation. And you can see that they're very similar. So the sustained 100 mg once daily and the 50 mg twice daily, it showed very similar PK/PD profile in healthy adult males, and both formulations had similar bioequivalence, and both were very well tolerated or equally well tolerated. So we will look at we looked at PK/PD profile and DPP4 inhibition. Now we will see that data being translated into clinical parameters. So here you can see the efficacy and safety and tolerability of these OD versus 100 milligram OD versus 50 BD preparation. So if you look at the HbA1c and fasting and postprandial glucose, you can see that the 100 milligram OD preparation performed as well as a 50 milligram BD preparation. There was no significant difference observed between these two therapies in terms of glycemic efficacy. And with regards to weight and other safety parameters, there were no red flags at all in this study. Weight neutrality continued for both 100 milligram OD preparation, just like in the 50 milligram BD preparation. There were no change in liver enzymes, and SGOT, SGPT, and serum bilirubin levels remained constant throughout the study. This is just a slide to show you how the OD preparation, what is the mechanism behind obtaining sustained release delivery. So this can be used for any drug. This is the method used in the vildagliptin SR preparation. So you have a gel layer which is coating the dry matrix, and the dry matrix actually has your drug or the molecule that has to be given to the patient. And once the gel layer comes in contact with the water, absorbs moisture, there are holes in the gel layer which acts as little pores through which the the drug molecule can be released over time. So this is the osmotic drug delivery system, and it works very well for this particular preparation of sustained release of vildagliptin. So now, apart from A1C, FPG, and PPG, we also have this new way of assessing glycemic control, which is the time in range. So this is looking at TIR in patients with receiving sustained release buildup preparation. So here you can see that from baseline to week 1 to week 2, the time spent in TIR is increasing significantly after initiating the 100 mg OD preparation. Similarly, you can see that around 42% achieved TIR of more than 70% in week 1. And in week 2, that proportion of patients actually increased to another 10%. So 52% over week 2 achieved TIR of more than 70% after initiating 100 milligram OD preparation. Similarly, you can, if you look at the estimated HbA1c levels, it reflects the same glycemia. As the TIR improves, your estimated HbA1c also will decrease. So this is now another study which is looking at 100 milligram Vilda versus 100 milligram Sita, because Sita is the other gliptin which is available and can be given as an OD preparation. So this is a single center retrospective study which looked at patients who received either Sita or Vilda for a period of 16 weeks. And if you look at the graphs on the side, which shows you the FPG, PPG, and HbA1c, you can see that whether they received treatment A or treatment B, the changes were very much comparable. So Sita and Vilda were comparable and very similar in the glycemic efficacy with regards to the same. Now here we have a study which is looking at patient profiling and outcome assessment of patients who are receiving a fixed drug combination. So in clinical practice now, these FTCs are becoming extremely popular. Various combinations of gliptins, SGLT2 inhibitors, plus minus metformin. So this particular study has looked at adding Vilda and DAPA to patients with type 2 diabetes, a combination of Vilda and DAPA. This again is a retrospective study who were prescribed this particular FTC and they were enrolled into the study. So these are the results. Here you have majority of the patients who were enrolled in this study had a duration of diabetes more than 5 years. So around 60% plus, around 65% of patients had diabetes more than 5 years of duration. So it's good to know that even patients with long duration of diabetes, these medications do work. And just like in clinical practice, you can see that a large chunk of your patients, close to 66-70%, had A1C between 7 and 9, which reflects what we see in our clinic. And 30% had a very high A1C, which is above 9. And if you look at the fall in HbA1c of the patients, again, this is something very, very similar to what we see in clinical practice. So addition of a combination of SGLT2 and DPP4 inhibitor, in this case, Vilda and dapagliflozin, you can see the mean reduction in A1C was about 1.28% or 1.3%, and that is what we would expect. So you can see majority of the patients, close to 59% of the patients, had an A1C drop somewhere between 0.5 to 1.5, which is what we see in clinical practice. And of course, the drop in A1C was actually reflective of the baseline HbA1c. Higher baseline HbA1c had higher drop in HbA1c over a period of time. Now, we already know that Vilda has a weight neutral drug. Adding DAPA to Vilda, we expected to have some amount of weight loss. So as expected, around 70% of patients had significant weight loss of more than 2 kgs. And at least 1/4 of the patients, that is 26% of the patients, had weight loss over 5 kgs. So this is very good news for our patients. Combining these two drugs given as a single oral pill, once daily pill, imagine the benefits that we get with regards to both glycemia and more than that, the weight, improvement in the weight. So this study actually shows that Vilda 100 plus DAPA 10 is a good therapeutic option for patients with type 2 diabetes, particularly because we can see that both glycemic target and weight target, there are some amount of additional benefits or synergistic benefits as we combine these two medications. Now, this is again real world data which is looking at patients who receive Vilda 100 milligram sustained release once daily preparation. And like we've seen in the previous studies, there is significant drop in HbA1c. There's also some improvement in blood pressure in patients with type 2 diabetes. And of course, in obese patients, there's some improvement in weight as well. Most of the time, that may be attributed to the lifestyle modification that we introduce along with the medications that we prescribe. And in obese and non-obese patients, you can see that HbA1c drop was non-significantly similar. So now this is sort of a summary or written by Dr. Sanjay Kalra. And you can look at, this is the Indian perspective, where there's an expert evaluation of vildagliptin and how it can be used in our clinical practice. So you can see that if you want to start Vilda as monotherapy, that is just vildagliptin, you can either use vildagliptin 50 milligram twice daily, which is a full dose, or the 100 milligram sustained release once daily preparation. And what are the situations in which we would refer these drugs? Is when if the patient is already on other OHAs and the intensification is needed, HbA1c target is not met, then this is a good option that we can add. In patients who have intolerance to metformin, maybe it's a good substitution as a monotherapy. And in patients with renal impairment, or if they have only postprandial glucose elevation, then even 50 milligram, the original 50 milligram preparation once daily will also work in these patients. Now, the next one is combining and giving Vilda and metformin in various dose preparations, dose combinations. So here, this is what the verified trial looked at. So this is typically used when you initiate the patient on therapy for diabetes. And if the A1C is more than 1.5% higher than the target A1C for that particular patient, then it's a good idea to combine these two drugs upfront and initiate the patient on Vilda metformin combination therapy. Of course, you can use this combination anytime you want to intensify the therapy. HbA1c target is not met. Then, of course, you can add on Vilda if the patient is already on metformin, or increase the dose of metformin along with vildagliptin if the patient is only receiving, let's say, metformin 1000 mg per day. Next, of course, is a combination of Vilda with SGLT2 inhibitor. And in our country, because DAPA is the most economical SGLT2 inhibitor, that is the one that's being commonly used. So here again, if there is any compelling indication for the patient to be on SGLT2 inhibitor, like already having established cardiovascular disease, heart failure, CKD, then introducing DAPA becomes extremely important. So, hello, am I audible?
Yes, you are audible, madam.
All right, thanks. So in these patients, we can add upfront Vilda plus DAPA combination. And of course, in patients with metformin intolerance also, when you are not able to use metformin upfront, drugs of choice. Now, the triple combination is currently becoming extremely popular, which is basically SGLT2, DPP4 inhibitor, and metformin. So that also we can use in patients who come with uncontrolled diabetes. If you want to initiate this as a first line of therapy, that's also all right, particularly in patients who come with fairly high HbA1c, A1c of 8.5, 9, 9.5, but do not have any osmotic symptoms. They prefer only OHAs and do not want any other medication. Then this is a good trial drug to start off with and see how they respond, and then take it forward from there. So if patients are already on therapy and still it's uncontrolled and you want to add on a new drug, then instead of increasing the number of pills, we can actually give this fixed drug combination, and that also works very well for patients. Lastly, there is a combination of Vilda with pioglitazone. So like we know, pioglitazone, based on the IRIS study, pioglitazone is a good drug if there is past history of TIA or stroke, and also it has benefits in NAFLD. So if the patient has any of these indications that where the patient will benefit from pioglitazone, then you can add Vilda pioglitazone combination for these patients as well. So this is a nice summary paper on how and when to use vildagliptin and what are the special situations where specific combinations of Vilda with other drugs can be utilized for our patients. So summarizing, what makes vildagliptin stand apart? is the fact that we do have a lot of clinical evidence, largely real world evidence to prove its safety and efficacy, particularly when it comes to cardiovascular safety. Even though we do not have a dedicated cardiovascular outcome trial, there is ample evidence based on both real world evidence and meta analysis of multiple RCTs to assure us about the cardiovascular safety of vildagliptin, and a lot of data to show earlier and better glycemic control. The verified trial particularly has shown us the benefits of glycemic durability with regards to vildagliptin and metformin combination. It offers more opportunities to address individual patient needs. And of course, having the single daily sustained release preparation improves patients' adherence to therapy as well. So that is the end of my talk, and I will stop here.
Thank you, Belinda. Excellent talk.
Thank you, sir.
Many doctors are prescribing vildagliptin, metformin combinations, but your talk will give them strength. They will feel they are on the right way. There is a lot of confusion in the medical fraternity that this molecule is not good, that is not good. But I must have used 30,000 patients vildagliptin with metformin, and all of them are okay. It's a very comfortable, trouble-free molecule. So that is a great thing, and you have amply supported it, and you have presented excellent data on that. Please stay for the panel discussion after the
Sure, sir.
talk
Yes.
of Shivendra Verma. I'll invite Dr. Shivendra Verma, please. Hello, Shivendra. How are you?
Yeah, yes, sir. Yes, sir. Good evening, sir. Sorry, I could
Good evening.
not join on time.
It's okay, no
I got
problem.
late a little.
Thank you for joining, and you are a very important name in the area with your endocrinology things, and in all India level you have achieved a status, and we are happy and lucky at NUCD, National Update on Clinical Diabetes, to have you for a very interesting talk on integrating dapagliflozin and metformin for comprehensive diabetes care with obesity. It's a very important molecule, and now a lot of prescribers are using it because of its convenience and good mode of action. So the stage is for you. Please start.
Yeah, sir. Can I have? Yeah, just.
Tuti, are you presenting yourself or slides, sir? You are muted. Please unmute yourself.
There are some internet issues with Dr. Verma. I guess he is stuck.
Dr. Joyasri, Professor Joyasri Swami has joined. Are you there?
Yeah.
Hello,
Sir, I am here.
Joyasri.
Sir, namaste, sir.
Welcome,
Namaste, sir.
welcome,
Namaste.
welcome,
Namaste, sir. I
welcome.
am here. Throughout the session, I am here. Sir, I am listening a quite beautiful session, interesting sessions, and informative sessions of, I can say, Dr. Bimal has given a nice information regarding the heart failures. I am listening all the things. And Dr. Belinda has also a nice talk regarding the VILDA comparison study of Sanjay Karla, sir, and other. I am here, sir.
By the time Shivendra joins with his talk, please take the mic and continue your discussion on these molecules.
Sir. So first of all, sir, good evening, everybody. Thank you, Alok sir. Thank you, Ashok sir. Thank you, Dr. Jayant, for giving me this opportunity for this panel discussion. Our eminent cardiologists, endocrinologists, physicians are there in this forum. Sir is there in this forum. So all have a nice discussion, nice informative scientific discussion presentations. So to be very frank, I'll ask some simple questions. I'll go through some simple questions. To start with the Dr. Bimal sir. Sir, you are here. Sir, welcome to this panel discussion. Sir, you have you are given nice information regarding this heart failure, going to do American guidelines and all the things. So my point is, sir, practical. What are the practical steps to screening these early signs of this heart failure during routine consultations in asymptomatic, long-standing diabetic patient?
Yes, madam. That's the very important question, madam. As a diabetologist, now the concept is there are different stages of heart failure. Stage 3 heart failure is the heart failure which is which needs heart transplant and devices. Stage C heart failure is the heart failure wherein patients come to us with breathing difficulty and we start them on the heart failure medications. Stage B is the heart failure where we see echo changes, but the patient will not have symptoms. Stage A is the stage where patient has only risk factor, but there is no evidence of any other problem. Now we have evidence to say that any patient with diabetes, we should look for NT-proBNP, irrespective of whatever duration or whatever severity. If we are seeing a patient with diabetes, we have to look for NT-proBNP, because the concept is once the patient gets stage C, once the patient starts telling that he has breathing difficulty, by that stage it is already several years have crossed and now the patient has manifested. Now the cardiologist, endocrinologist, and the diabetologist are trying to come together. This heart failure has actually brought together these three specialties: cardiology, endocrinology, and diabetology, and they are now giving joint guidelines. So what they are saying is, in your patient who has diabetes, you do NT-proBNP every year. If the NT-proBNP is above a particular value, more than 125 picogram per ml, that means that patient has already developed heart failure. And they're also saying that heart failure could be the first complication for a diabetic patient. Now, we have a tendency to look for a complication like coronary artery disease. Diabetic patient, we tell them, hey, you're a diabetic, go get tested for treadmill test, echo. Every year you check, or once in 3 years you check for that. But now the ADA, the ACC, and the endocrinologist forum, all of them are proposing that it is good to look for NT-proBNP. It's a simple blood test. Do the blood test in the annual checkup every year. If your patient has more than 125, a slightly elevated value, your choice, importantly, you are going to focus more on lifestyle measures. Ask him not to take more of pickles, hidden salt, better control of diabetes, better control of risk factors. And your choice of anti-diabetic is going to be either a SGLT2 inhibitor or a GLP-1 receptor agonist. And if the patient is on ACE inhibitor, we are going to accelerate the ACE inhibitor taking, and we have to do an echo for this patient. So otherwise, not every year we might not do echoes, but once the NT-proBNP is slightly higher, it is recommending for an echo. Basically, this approach is do a blood test. You can identify patients very early, and if you treat this like having symptoms of diabetic cardiomyopathy. So that is the basic take-home message, madam.
Sir, you are telling about the type 2 diabetes. It is not for type 1 diabetes. Is it for type 1 diabetes?
Yes, madam. Both
at the time of sir, listen to me. At the time of the diagnosis, according to your message, at the time of the diagnosis, you can go for the NT-proBNP in each and every patient, those who are suffering from the diabetes. I mean, it is for the type 2 diabetes. For type 1 diabetes, is it recommended by the different society? For type 1 diabetes, at the time of the diagnosis, you will go for that?
Yes, madam. So this
is
a
clear?
Very excellent question. Why I say like that is, in type 1 diabetes, we cardiologists used to say that there is no increased incidence of cardiovascular disease with type 1 diabetes. Don't be worried with them. but they are more prone for microvascular disease like retinopathy and nephropathy, and we look for that in type 1 diabetes. The point here is type 1 diabetes is more associated with heart failure than type 2 diabetes. I repeat, type 1 diabetes is more associated with heart failure than type 2 diabetes, more so because heart failure is a microvascular disease rather than a macrovascular disease. So it is important to look for heart failure in type 1 diabetes equally or more important than in type 2 diabetes.
Okay, sir. Thank you, sir. Thank you, sir. So coming to our next thing is, sir, what is the efficacy of the sir? Also, sir is there.
Yeah. So
Sir, pranam. Sir, pranam.
Pranam. The issue is like this, Dr. Bimal, what you presented. You started with a case of the Rubler. You started the Rubler's cases, 27 cases out of that 4 had nephropathy, and in these cases, Rubler found in the heart microangiopathy. And those were going along with the kidney microangiopathy, and they had heart failure. Those 4 cases are classical cases of diabetic microvascular cardiomyopathy. But I'm not sure whether we can say that the entire type 1 diabetes heart failure is because of microangiopathy. Are you getting my point, Professor Jayashree?
Yes, sir. Yes,
Dr. Vimal started beautifully. He said about the first 27 cases, it was 27 cases you said, of heart failure out of 4 had cardiomyopathy. So that's a good point you have said. I think it stands to common sense also that type 1 diabetics will have more of diabetic specific stuff, and diabetic specific stuff is angiopathy, microangiopathy. Whereas the type 2 is a mixture disease. It is not a pure virgin disease of only. I think that stands to common sense. That's why. What is the prevalence of large vessel disease in the heart, coronary disease in the type 1? Any idea?
Very less.
Much less. Huh?
Yes, sir. It is around 11% in type 2 diabetes. It's probably a very in single digit, sir, in type 1.
Single digit.
Yes, sir.
I think it's a very important point because diabetes and heart is one of my interests. And so I think I will, this is a very interesting point. So you said that for the type 1 diabetics, one needs BNP or NT-BNP, whereas type 2 one does not need. Because type 2 is heart failure. Type 1 to prove heart failure, you need that. Is that you mean, Professor Bimal?
Yes, sir. Can you please repeat the question, sir?
You said to Professor Jayashree's question that in type 2, you need NT-BNP. In type 1, since the heart failure is less, you don't need NT-BNP. Was that the point or the other way around?
It's actually previously we used to think microvascular disease is more associated with retinopathy and nephropathy. But now, even in the autopsy cases, it was microangiopathy which was seen. They did not have macrovascular disease. So basically, type 1 people have more microvascular disease, and heart failure, one of the subsets of heart failure, has microvascular disease. So they are saying among the type 1 and type 2, type 1 is more associated with heart failure than type 2.
Oh, I see.
So they're saying it is even more important in patients with type 1 because now we are flooded with patients with LV dysfunction for whom we don't know the cause. Patient will come for some reason, you do the echo. We have advanced modalities of for testing heart failure, like the global longitudinal strain, which we call as GLS. We're seeing so many diabetics are with them with LV function normal, which reduced strain, which is an early marker of systolic dysfunction. So we are missing all this, and these patients come with LV dysfunction. We do angiogram, it is normal, but these patients will have LV dysfunction of unknown cause. So it is important to
latest knowledge, and is it the same that syndrome X that they have may not have large vessel disease, but they have Melinda, am I correct? They used to say syndrome X is the intramyocardial disease, which is not large vessel, but intramyocardial small vessel disease. Is that a entity? Is that an entity, Vimal?
Yes, sir. Microangiopathy, microvascular dysfunction is one of the ways in which diabetic cardiomyopathy. So basically, there is an entity called as diabetic cardiomyopathy. There is these patients, like previously we used to see left ventricular hypertrophy in patients with hypertension. So we used to think, what is left ventricular hypertrophy doing in a patient without hypertension? We did not know why it was there. But now we are getting to know that even in patients with diabetes, there could be this hypertrophy which is happening. LVH could be seen, and that reflects the cardiomyopathy in diabetic patients.
Yes, I mean, we have got two types of heart. One is a big heart, as you rightly said, enlarged heart. Other is long, narrow heart. That
Yes,
is
sir.
the classical description of a stiff heart. They call it STIFF, stiff
Yes.
heart. In that, that was my PhD thesis, Bimal. So that's why I'm interested in that. Good, I think. Good. Is
Sir, with
yes,
your due permission, I will like to go for to Belinda regarding
yes.
that things. Ki NT-proBNP, is there any recommendation to do this NT-proBNP in type 1 diabetes at the time of the diagnosis? Is there anything? Sir, I think the comment of Belinda we should take into account.
At the moment, there is no recommendation to screen with NT-proBNP when you diagnose type 1.
Yeah.
Like Dr. A.K. Das correctly said, I think type 1 diabetes microvascular complications is more prominent. And we expect it as part of microvascular disease to occur over a period of time. Unlike type 2 diabetes, where they may have occult hyperglycemia for a longer period before they manifest or before they are diagnosed, which is why we screen for all complications at onset in type 2 diabetes. Whereas type 1 diabetes usually presents along with onset of hyperglycemia. So generally, there is no recommendation to screen for any microvascular disease at the onset, except when they are going through puberty. So maybe, and at the moment, to the best of my best knowledge, there is no recommendation to screen with NT-proBNP in type 1 diabetes at onset. But certainly, as time goes by, if the patient is symptomatic, definitely we'll have to screen the patients. And maybe over time, with more data in type 1, it might come as an annual screening with a significant duration of hyperglycemia. Do you agree with me, Dr. Jayashree?
Yeah. I think see type 1 diabetes at the time of the diagnosis, we don't have any recommendations at present. With the due course of the time, when the patient is 5 years, 10 years, or any other complications, microvascular complications, we should screen for that. Sir Bimal, sir, Dr. Bimal has given nice clarifications regarding when to do the NT-proBNP in type 2 diabetes, and also we learned some things when to do NT-proBNP in type 1 diabetes. Sir Ashok sir, I mean, we are clear in this word?
I think let us try now Dr. Shibendu's talk, because of the first talk we're waiting, Dr. Shibendu Stuti. Why can't you focus the slides, even if internet is not fully?
No, he'll give the talk. He'll now give the talk.
You can give the talk, Shibendu, because a very
With
important
permission
aspect.
from Jayashree.
Yeah,
Sir,
Jayashree of the. So what I will say that it's a very important concept of combining DAPA with metformin, because that becomes very good for the hyperglycemia and obesity. I heard a paper from Dr. Anup Mishra about a week back. He was presenting a paper. I saw it on the web only, where he has said that combination of DAPA, metformin, and one more agent is very efficient to take care of diabetes, obesity, and of course hyperglycemia. So let us listen to Shibendu Barma. Stuti, can you put the slides? Help Shibendu to put the slides. And Melinda, we'll come back to you. Have you left?
No, sir, I'm here.
Because you know, I have heard you before and many times. I heard you today on the Jalra, the Builda plus Metef, which is a very important molecule. Yes, let us start Shibendu's talk, because the other session will begin at 7 o'clock. So we have got another 20 minutes. So let us listen to Shibendu and 5 minutes for discussion. Stuti, just focus the slide. People are waiting to see the slides of Shibendu Burma. Otherwise, I'll ask him to
So
kindly.
I don't have his slides. He has to put his slides on his own.
Shibendu, will you send the slides to please, please, Doctor, to Stuti? What I wanted is that Shibendu, you have joined from the very beginning of the session. there is some problem with the internet which is beyond your control. If you
Yes.
send the slides to Stuti, she will focus slides centrally, and all of us will see that, and you can give your talk. That is perfect. Can you send your slides to Stuti? You have her email ID?
Or to Rupesh, or the slides can go to Rupesh, and we will organize that.
Yeah, please send it.
Shivendra, can you hear me?
Stuti, give your email ID to
Sir, I have WhatsApp him. He can directly send me on the WhatsApp.
it's on your WhatsApp, Subhendu. Can you send on the WhatsApp the
Yeah,
slides?
yes, sir. Yes, sir. Just a
That
second.
will be best. Good. Bimal, you are in which hospital in Sundaram Hospital? I saw in Trichy.
Yes, sir.
Is it a big hospital?
Yes, sir. It's a 200-bedded hospital, sir.
I see. I see. And they have a cardiology and diabetes focus.
Yes, sir. We have a physician who's very good, very versed with cardiology, and he is also an examiner for MRCP.
What's the name?
His name is Dr. Vivek Sundaram.
My friend's son.
Yes,
I
sir.
was thinking that when we say Sundaram Hospital, he's the son of a very famous physician, Jayashree, who we lost about 5 years back. We lost him.
Yes, sir.
5 years back. So Sundaram Vivek is a great guy. He's a MRCP examiner. He's my friend's son. Oh, you're in the same hospital. Good. I'll tell him that I met you. Yeah, world is so small. So in the meantime, if you don't mind, Dr. Sibendu will like to, or he's, I think, sending the slides. Good.
I have a question for Dr. Belinda, if I can ask.
Yes, Belinda is here. Madam, Dr. He has a question.
How do you choose which gliptin to use, or in which scenario which gliptin, madam? Or all three are equal? You can use it wherever, just like DAPA, EMPA, or do you have a?
So when it comes to gliptins, the commonest one that we use are Sita, Vilda, and maybe sometime back before the patency of these two drugs were lost, teneligliptin. Generally, the other gliptins available in India is Saxa and Lena. Because of cost issues, most of us don't write Lena as much as we use the other gliptins. And Saxa, because there is a red flag with heart failure, a lot of us shy away from using it, that frequently. So that leaves us with essentially Sita and Vilda. And between the two of them, there is no major role to. I mean, there's no major data to say one is better than the other. But Sita has CVOT data, whereas with Vilda we don't have a dedicated CVOT. But efficacy wise, both are very, very similar.
If there is a liver dysfunction, Vilda is not to be given. No, am I correct?
Yes. So yes, sir. In all Vilda trials, we have seen some amount of AST, ALT elevation in a small subset of population. So particularly we anyway screen them for NAFLD as part of the diabetes thing. So if we find that is going up, then we take off Vilda and we prefer other agents.
Now let us listen to Dr. Shivendra, please. He's joined.
Shivendu, please start.
Sorry for internet glitches and other things. So I'll just go fast because we have already lost much time. So my talk after a wonderful talk from Dr.
You can have, because we have finished discussion part.
Yeah. Am I audible, sir?
Yeah, you are audible.
Yeah. So I'll be speaking on integrating dapagliflozin and metformin for comprehensive diabetes care with obesity. We all know obesity is a rampant problem, and almost half of our patients don't have a within the range BMI. So my talk is divided into 4 parts: introduction, understanding the impact of visceral fat; dapagliflozin and metformin, what are beyond glycemic benefits; and exploring the feasibility of fixed dose combination and what are the benefits of the fixed dose combination. India is now considered diabetes capital of the world for almost 2 decades. And really, not only the diabetes, but the diabetes complication and comorbidities like obesity and hypertension are also rampant. And data from recent epidemiological reports offer no solace for India. And ICMR India is the recently published study which has shown very shocking results, like overall weighted prevalence of diabetes was 11.4, and overall dysglycemia, that combining pre-diabetes and diabetes, was almost 25%. So 1 in 4 Indians have some sort of dysglycemia. Regarding NHFS5 data 2021, estimated prevalence of diabetes was 16.1%. So we are one of those countries where high prevalence of diabetes is there. And more than 50% of individuals with diabetes in India remain undiagnosed. And that is also one of the problems, that we diagnose diabetes late, and the mean A1C is also kind of more than 8 or 9% when the patient first comes for the diagnosis. Regarding the prevalence of obesity in type 2 diabetes, this is also one of the very common problems. Obesity in diabetes, 88% is seen, whereas the abdominal obesity, we have a thin fat phenotype, and it's more predominant the central adiposity, which is seen in 82%, and BMI is also 25.8 with the cutoff of 23 for Asian. So definitely most of our diabetic patients have concomitant obesity, and we need to find ways to treat both the diseases with authority. So obesity is a modifiable and yet neglected risk factor. And years ago, I think 4 or 5 years ago, it was not in the scene to treat obesity as well. Now we have our armamentarium. We can treat diabetes with a lot of drugs. And obesity is a triggering factor for diabetes associated with insulin resistance. And there are common pathways for both the obesity and diabetes. And we know that adipose tissue is increased in obesity, which releases a lot of adipokines, which includes the inflammatory cytokines also, like TNF-alpha, MCP1, and IL-1, that can lead to not only insulin resistance and diabetes, but also adverse cardiovascular events. And there is a vicious cycle of obesity and insulin resistance. Once the obesity is there, the insulin resistance keep on increasing. And the problem with insulin resistance, it is only with the metabolic milieu for insulin, which is causing abnormalities in the glucose disposal. But the anabolic effects of insulin is maintained. So very high levels of insulin, and they keep on increasing, more accumulation of adipose tissue, and body weight keeps on increasing. So it's a vicious cycle that both are interrelated. And to cut down that, we have to force our patients to lifestyle modification and medications so that the obesity can be rapidly taken down and this vicious cycle can be broken. So what are those high-risk obesity phenotypes? Remember, there can be patients of obesity which don't have many of the comorbidities or many of the high-risk features, and they don't present, even for years they are living with obesity, they don't present with a lot of complications. So these high-risk obesities are those who have central and visceral adiposity. So you can very well see those patients who have probably more of a central adiposity marked by increased waist circumference. And if you see, their abdominal girth is much more increased compared to the adipose tissue seen at the hips or other peripheral subcutaneous sites. And these are the patients who have increased insulin resistance, glucose intolerance, increased risk and risk of type 2 diabetes. Apart from that, dysglycemia, they also present with higher blood pressures, abnormal lipid metabolism, dyslipidemia, inflammation, and endothelial dysfunction. And these patients, when they have long-term metabolic abnormalities, of course, they present with higher risk of cardiovascular events, increased coronary artery disease, and mind you, it is more of a diffuse coronary artery disease. And as the discussion was going on, many of these patients, even without epicardial coronary artery obstructions, they may present with reduced or preserved ejection fraction heart failures. Apart from that, risk of arrhythmias and sudden death is also increased. So there is high prevalence of this thin fat Indian and high visceral fat phenotype, which is metabolically unhealthy non-obese patients also in Indians. So we know that obesity with more than 30 of BMI, we can divide them into metabolically healthy obese, that in that the comorbidities like type 2 diabetes, ASCVD, heart failure, all others are much lower. And there is a other phenotype of metabolically unhealthy obese, which have very high uncontrolled diabetes, high risk of atherosclerotic cardiovascular disease, heart failure, and risk of death as well. These abnormalities in Indians not only is seen in obese patients with higher BMI, but can also be seen in the spectrum of normal BMI with 18.5 to 23, and also with those with BMI is not much high, maybe less than 30. And they can also be divided into these two phenotypes with metabolically healthy non-obese and metabolically unhealthy non-obese, which is seen in 20.5% of these BMI cutoffs of 18.5 to 29.9. The idea of describing this phenotype is that even at this lower cutoffs of BMI, with this central adiposity is much more prevalent, and the risk of this atherosclerotic cardiovascular disease, heart failure is much, much higher compared to the other ethnicities. And so we should be very careful, not only in patients who are morbidly obese, but also in patients who do not have significant high BMI. And what is the effect of this visceral fat? Why are we so concerned with this visceral fat on organ complications and comorbidities? This is the hypothesis. This is a busy slide which shows that whenever there is a high visceral fat, this causes more of a lipid spillover, higher insulin resistance, which is directly related with the abnormalities in glucose disposal. And also, it leads to higher accumulation of liver fat, that is, de novo lipogenesis increases, which again causes increased gluconeogenesis, increased triglyceride-rich lipoprotein synthesis, and increased C-reactive protein. And this all complications, whether at the level of the skeletal muscles or at the level of the liver, it leads to this metabolic milieu, which impairs the vascular function and leads to atherosclerosis, which is leading not only for dysglycemia, but many of the macrovascular and microvascular complications seen, like it is associated with abnormal brain health, and which leads to impaired, which can lead to stroke and dementia at the level of the kidneys, increased renal sinus fat. There is accumulation of the renal sinus fat as well, which leads to impaired renal dysfunction and may in the long-term progression of renal disease, and the requirement of renal replacement therapy can be seen. Lot of studies and now are going for increased epi and pericardial fat and its association with increased coronary artery disease, atrial fibrillation, and heart failure. Along with that, the newer thing is abnormalities of the respiratory function, which may be associated with the higher tongue fat, which is one of the markers of higher insulin resistance and abnormalities of respiratory function. It may lead to increased airway compression, and some of these patients may go on to develop obstructive sleep apnea as well. And this recent study has examined the longitudinal association between visceral adiposity index and diabetic nephropathy, and it is showing a linear correlation that one standard deviation increase of visceral adiposity index is significantly associated with increased risk of nephropathy with a hazard ratio of 1.127. So definitely more the visceral adiposity, more is association of those accumulation of these abnormal visceral fat at abnormal at areas which do not normally have fat accumulation, like even pancreatic fat, epicardial fat, even renal sinus fat, and they all are directly correlated with abnormalities at each and every organ system. So now with this background, where we see that many of our patients have uncontrolled diabetes, high prevalence of diabetes in India. Along with that, almost 85 to 90% of our diabetic patients have obesity with more evidence of visceral adiposity. So what are the answers to take care of these adiposity along with diabetes. So what is the role of dapagliflozin and metformin? Does it provide any benefit beyond glycemic control in taking care of both the problems with one single answer? So this is a prospective study which examined the effects of dapagliflozin on the body muscle mass and fat content. So study was done on 50 stable but diabetic patients of HbA1c of more than 7%, and they were randomized to receive either dapagliflozin or non-SGLT2 inhibitor medicines for 6 months to take care of their hyperglycemia. And at the end of the study and the changes in the body composition were investigated using bioimpedance analysis as well as abdominal CT. And at the end of the study, it was found that dapagliflozin treatment significantly decreased body weight and total fat mass without affecting skeletal muscle mass. And this is a common scenario is also seen in our patients on SGLT2 inhibitor, that they self-report a significant or some drop in weight loss without any significant change in their appetite. And this is mostly a loss in the fat mass compared to the muscle mass, which is a welcome effect. Now, what is the effect of metformin on obesity as well as per se diabetes? Studies have shown, though it is not an established effect, that at the level of the CNS, it suppresses orexogenic hypothalamic agouti-related peptide neurons via AMPK suppression, which is a primary effect of metformin peripherally, but it is also seen in the neural pathways and increases hypothalamic leptin sensitivity. So thus leptin is a satiety signal which suppresses appetite. Increased production of incretins and vagal signaling via nucleus of tractus solitarius by increasing GLP-1 and peptide YY, and also suppression of appetite via postprandial elevation in lactate production. So these are one of the hypotheses, or you can say some of the neural pathways involved in appetite suppression by metformin. It also has some aging effects, that reduction in sarcopenic obesity. Sarcopenic obesity is the age-related muscle loss along with obesity, which gets reduced with the use of metformin, and so it does reduce aging-related metabolic derangement. And at the level of the liver also, there is decrease in hepatic glucose production and reduced systemic insulin requirement. The good benefit which is seen at gut microbiota is the alteration of gut microbiota, which is seen as bacteroides to firmicutes ratio is altered to the benefit of the patient, and alteration in lactobacillus species and hepatic glucose production, increase in Akkermansia species, and increase in the production of short chain fatty acids. So all these things are beneficial, and more we use the extended release or sustained release preparation, it is seen that more of these gut microbiota effects are expected with metformin. And at the GI, we also see some of the nausea, which may cause suppression of the appetite, plus it may be related to the L cells produced GLP-1. It also causes alteration in bile absorption and secondary gut hormone signaling, which are also one of those factors which produce satiety. Diarrhea and bloating, which due to altered enterocyte metabolism, this is one of the side effects, and sometimes we have to stop the medication of that, and also altered taste, which is commonly seen with metformin. So what is the status of metformin and weight loss? So in 2012, with the diabetes prevention program, which tried metformin for prevention of onset of diabetes compared to the exercise program. So in the metformin arm, there was a reduction of diabetes by 31%, which was lesser than the exercise program, but it was seen that 31% of the patients in that arm over a 3-year period had reduced in the incidence of diabetes, and they experienced 2.1 kgs of weight loss on an average. And it was also associated the adherence level of the metformin with the weight loss. So more the patients are adherent to the metformin, more likely they can lose weight. And in 1995 metformin study group, it was seen there was a significant 3.48 kg of weight loss with metformin compared to no significant change in the sulfonylurea group at week 29. And in United Kingdom prospective diabetes study UKPDS 2008, which is a 10-year follow-up. The UK PDS keep on coming up every 10-year decade data of that follow-up cohort. It showed a weight-neutral status of metformin compared to glibenclamide and sulfonylurea, which stimulates a weight gain. So all in all, whatever evidence we have, we can't say that is a significant weight-reducing drug, but if the compliance is there and good lifestyle modification is there, we can expect 2 to 4 kgs of weight loss with metformin alone. Now, what are the possibilities when we combine it with dapagliflozin in a fixed dose combination, and what are the synergistic benefits? So what is the rationale behind combining these two drugs? Is that with progressive deterioration, metformin definitely goes on with the failure and we need to add more medication. So definitely we need 2 or 3 medications sometimes in our patient when the diabetes duration increases. Sulfonylurea and thiazolidinediones are associated with usual weight gain, and many of our patients considered being obese and insulin resistant. We cannot afford our patients to gain more weight, whatever being lost with lifestyle modifications and metformin alone. In this regard, dapagliflozin and metformin actually complement each other, that they have a different modes of action for diabetes control, plus either metformin we can consider weight neutral or some weight loss. Dapagliflozin definitely has a weight reducing benefits. So in this combination has an edge over sulfonylurea and thiazolidinediones. And in 2024 ADMIRE study, which considered first-line treatment with dapagliflozin and metformin FDC as an effective and safe in patients with uncontrolled hyperglycemia. How this study was conducted? In this study, 68% patients had obesity and 58% had hypertension, and HbA1c was mostly uncontrolled, 9.34% of the mean HbA1c, and 78% were patients who were on additional hypoglycemic agents. So naturally, many of the patients were not doing good on their current OADs and they were obese, and this provided 2.2% HbA1c reduction and 4.2 kg of weight reduction, which is very meaningful in our day-to-day practice. So besides glycemic control, this molecule can be preferred because it promotes weight loss. Dapagliflozin has a definite reduction in adverse cardiovascular events, and they also reduce the progression of renal disease, particularly if your patient has concomitant albuminuria, and then this becomes a valid choice. And in this particular study, significant improvements were seen over 6 months period, like we can see and we can expect with this combination is some reduction in weight, some benefits in systolic and diastolic blood pressure, and metabolic parameters as well as eGFR decline is also expected to halt or even improve. And this is regarding Omen-DAPA study, which is the effect of this fixed dose combination on drug-naive patients. So we have seen effect on patients already on some OADs and not doing good. So let's see what happens when this drug is given in a newly diagnosed type 2 diabetes. So it's a phase 4 open label RCT, single-centered, and type of patients who were drug-naive and having less than 1 year of duration of diabetes. So they were either given metformin of 1700 milligram per day on 14 patients, metformin or DAPA 10 milligram per day in 15 patients, metformin plus dapagliflozin. So primary objective was to investigate the effect of metformin and dapagliflozin in the reduction of abdominal fat layers. So small studies, number of subjects are not high, but the secondary objectives of this study was correlation between fat depot thickness and cardiovascular risk measurements, biochemical risk markers, and intermedia thickness, and percentage of patients who were able to reduce their omental fat at below defined cut points of more than 37 mm in females or more than 54 mm in males after 6 months of treatment. So this is a unique study which related the fat thickness with along with cardiovascular parameters like CIMT, and whether this combination reduce the omental fat, which is a marker of central adiposity. So in this study, 21% of the patient reached a safety level below the metabolic syndrome cutoff of risk limits. Weight loss with metformin alone was only 5.7%, but it got 8.6% with metformin plus dapagliflozin. And after there was 5.4 centimeter reduction in abdominal circumference. So definitely central adiposity was reduced, and it was clinically measurable also. And as far as accurate data on omental fat is considered, there was a significant 21.4% reduction and 24% reduction in right perirenal fat. So this is an interesting study which actually measured the central adipose mass pre and post treatment. So it can be presumed that omental fat, which is responsible for insulin resistance, dyslipidemia, and hypertension, and perirenal fat, which is also a potential cardiovascular clinical adverse cardiovascular clinical marker, and NAFLD, they were reduced, and hence we can expect a lot of cardiovascular benefits in long run. Though this is only a 6-month study, so a lot of clinical outcomes cannot be derived, but definitely a larger and more prospective longer studies are needed. Plus, the significant weight loss achieved by glycosuria induced net caloric input and secondary volumetric reduction. So abdominal fat layer reduction seen at different levels with in subcutaneous, deep subcutaneous, pre-peritoneal, omental, right perirenal, they were all significantly reduced at the end of the treatment, especially when patients were given dapagliflozin along with metformin. So definitely we can derive a lot of benefits. And what is the significance with this OMEN-DAPA study? That it demonstrates benefit of this fixed dose combination in drug-naive type 2 diabetes patients in reducing the risk of metabolic syndrome and cardiovascular risk by inducing fat loss in the abdominal fat layers involved, that is in omental and perirenal fat layers. And we know that these are the fats, perirenal and omental fat, are associated with both insulin resistance, dyslipidemia, hypertension, adverse cardiovascular events, and NAFLD. So a reduction in these two important fat parameters, we can have significant benefits. However, I would say we need to have a longer prospective study on larger number of patients just to be sure that really the decrease in this fat parameters gives us significant and meaningful clinical outcomes. Now, regarding the Bollinger et al., when dapagliflozin was added to metformin, it results in total body weight reduction in patients who were inadequately controlled with metformin alone. So this study which used dapagliflozin 10 mg per day or placebo when added to open label metformin for 6 months. So what is the effect after 6 months? There was a total body weight reduction of 2 kgs. So that is not very great. However, the waist circumference was reduced by 1.52 centimeter. Total body fat mass of 1.48 kg. That is interesting to see that most of the weight loss seen with this combination, almost you can see 75 to 80% is lost due to the total body fat mass. And look at that, the visceral adipose tissue mass was much more decreased compared to the subcutaneous adipose tissue mass, minus 258.4 centimeter cube decrease versus the pre-study data, and the adipose tissue is in the subcutaneous decreased less compared to the visceral adipose tissue. So dapagliflozin reduced total body weight predominantly by reducing the fat mass, visceral adipose tissue mass, and subcutaneous adipose tissue in patients who were inadequately controlled on metformin. So definitely we can have significant benefits in visceral adiposity. Now, the meta-analysis of impact of dapagliflozin and metformin combination on body weight, the studies which many studies have been used in this meta-analysis, which just focused on the weight loss with this fixed dose combination. So most of these studies have shown that compared to the placebo, there is almost 2.5 to 4 kgs or 4.5 kgs of weight loss with this metformin and dapagliflozin compared to almost 1 kg or even 0.88 or 0.6 kgs of weight loss in the placebo arm. So compared to the other fixed dose combination of placebo treatment standard of care, this combination does produces significant weight loss. Now, this is Sethi et al.'s real-world Indian study on effectiveness of dapagliflozin when it is added on to metformin. So, what about the Indian data? We have already seen the real-world whole global data. So, when dapagliflozin was added on to metformin, it brings about improvement in BMI and blood pressures. So, reduction in BMI versus placebo almost 1 point reduction, 31.1 to 30, and in another one is 32.7 to 31.9. And reduction in mean systolic blood pressure is also can be in the range of 5 to 6 millimeters of mercury. There is some slight reduction in diastolic blood pressure also. Though they are not very in the real world setting, they cannot we cannot say they are very significant differences, but actually some reduction in systolic diastolic blood pressure brings about the more efficacy of the concomitant antihypertensive medications also. So we should not take it as insignificant findings. One drug is producing so much of benefits, and it is contributing not only for obesity but also enhancing our management for hypertension as well. Now, the Kuker et al. Review of studies evaluating dapagliflozin as add-on to metformin. So they actually identified what is the combined benefit with this fixed dose combination of various parameters. So we can expect almost 2% up to 2% reduction of HbA1c, 2 to 3 kgs of weight loss. Remember, it's a mean weight loss, so we can expect even a higher weight loss as well, and some 3 to 5 mmHg reduction in systolic blood pressure. So this, all in all, nutshell, what are the benefits with this fixed dose combination we can achieve. So key takeaway points with this fixed dose combination, the use of dapagliflozin and metformin, and this all in all in this this particular talk is India is now the diabetes capital. Many of the patients, almost 50%, remain undiagnosed, and even at diagnosis, they have a very high HbA1c plus concomitant obesity is very common. And chronic low-grade inflammation is associated with obesity, which leads to not only diabetes, but this insulin resistance leads to onset of other comorbidities and cardiovascular risk profiling. And there is a vicious cycle between the obesity and insulin resistance. And visceral fat has been associated with diabetic nephropathy as well as rise in blood pressure via hyperinsulinemia. And across various studies, dapagliflozin and metformin combination has consistently demonstrated not only efficient glycemic control, which may be in the range of up to 2% HbA1c reduction, a good amount reduction in body weight, BMI, fat mass, visceral mass, as well as subcutaneous fat. And it is predominantly the visceral adiposity that is taken care of, and also provides cardiorenal protection. We have evidence with a lot of cardiovascular outcome trials. With this, I end here, and I will
Thank you,
be
Shivendra.
happy to
Very nice talk. And you established the clinical efficacy of dapagliflozin and combination with metformin without any doubt. Thank you very much for all these things. And now with us, the next session is holistic cardio-renal metabolic
I
care.
think Alok, one issue that I want to highlight here. I know Dev is here already. You know, I think what Subhendu have done highlighted a very important fact. I told you that I knew about this molecule. It is available in Mayo and in USA, the Jigdio XR. Am I correct? Jigdio SR. And this particular drug is the widely used anti-diabetic drug in the USA, because you know we say USA obesity, but there are also people who are not very morbid obesity alone. So the people in India where the obesity is not morbid, I mean overweight by 5 kg, 6 kg, this drug works out very well. That is what the discussion I heard. So 3 ways: the epirenal fat, it clears. He also showed that it also clears dapagliflozin's DAPA kidney trial. It also showed weight loss, and metformin together with DAPA produces 4.8 up to 4.8, but average 3 kg weight loss. I think Subhendu, fantastic paper. Where are you, Subhendu? I'm not seeing you.
Yeah, I'm here, sir. I'm here.
Yeah, great talk, really great. Thank you very much. I'm sorry, Alok, I interfered because I want to
No,
drive this
thank you,
point.
Subhash.
This is a very important combination in our country, both in the beginning and continuation. My friend is here with whom we are following an elusive program for the transgender. This year it will happen. Deb, I welcome you with all sincerity, and over to Alok to take care of.
Thank you. Thank you, Jayashree, for excellently conducting the meeting. So, thank you, Jayashree. Please
Sir,
stay
sir,
with
thank
us
you.
for some time.
Yeah,
And
sir.
now
Sir,
I request Dr. Devmala Sanyal for holistic cardiorenal metabolic care in type 2 diabetes patient, optimizing approach with SGLT2 plus DPP4 inhibitors. Jayashree, you can conduct. Kishore is there. You can join Kishore for this session. Thank you.
Sir, I'm here.
Thank you, sir. Thank you, Dr. Dr. Ashok Kumar Das. Thank you, Jayashree, ma'am, as well. How are you? Will I share my presentation?
Yeah, please start.
Yeah. Hope it's visible, sir.
Yes, sir.
Okay. Thank you. So we would be talking about a very common, problem which we see now, which has been integrated, the cardiorenal metabolic aspect, and which we have just learned, with regards to obesity, the impact of obesity on chronic kidney disease. We have seen the fat accumulation and the oxidative stress, the similar oxidative stress, as well as the atherosclerotic process can lead to acute coronary syndrome and subsequently heart failure, where you have neurohormonal activation as well, and the very important aspect of NASH and what is currently known as MAFL, where there is increased lipotoxicity and insulin resistance. So very important, about 30% of diabetes have CKD even at presentation, and 1 in 8 will develop a drop in GFR, and again, about 20% do not have significant albuminuria. Heart failure, something which has been brought to light by the SGLT2 inhibitor trial, is present in a significant proportion of patients, and nearly 50% have diastolic dysfunction. 1 in 3 have cardiovascular disease, 1 in 5 have coronary artery disease, and about 50 to 70% of death in diabetes because of CV death. Very importantly, nowadays, we have seen the rising prevalence and early detection of MAFL, where nearly 70, almost some studies have said even 90% of diabetes patients have MAFL. Actually, the Indian data also says what is more important is the fibrosis. The F2, the stage 2 fibrosis, is present in almost 20-25% population of diabetes, where there is further rapid progression from fatty liver to hepatitis, steatohepatitis to fibrosis and subsequently cirrhosis, as well as HCC, and there can be direct conversion to HCC as well, and significant prevalence of dyslipidemia. So it's very important to assess cardiorenal features at presentation: BMI, waist circumference, the metabolic components, the blood pressure and the lipids, as well as the use of FIB4 as a standard index to assess liver fibrosis, which has been indicated by recent guidelines every 1 to 2 years. We need to assess the GFR as well as the urine ACR. The echo as well as the cardio biomarkers like NT-proBNP can have a significant impact on the subclinical detection of subclinical heart failure. So a 35-year-old male with recent diagnosis of diabetes and dyslipidemia having a BMI of 31, A1C of 8.5, having feeble peripheral pulses, fasting 165, postprandial 262, dyslipidemia. Again, the SGPT, SGOT are raised. The urine ACR, the CKD is actually good. The GFR is 114. The GFR is good. there is grade 1 fatty liver and the TMT is positive, the patient is already on metformin 1 grams BD. So what is very important to understand that the positive calorie balance actually leads to increased insulin resistance at the periphery, at the liver, which can lead to increased reduced effect of insulin in terms of neoglucogenesis and increased fasting glucose level, as well as because of deposition of excess triglyceride in the pancreas, there can be decreased meal-related insulin secretion and postprandial hyperglycemia as well. So this excellent paper by Dr. Unnikrishnan et al. Showed that even in newly diagnosed diabetes patients, about 40% were high risk and 60% were very high risk in terms of atherosclerotic cardiovascular disease. And obviously, we need to expand this to detect the high risk factors. Among the major high risk factors, the commonest is the low HDL cholesterol, followed by hypertension and smoking, which is prevalent significantly. Even at diagnosis, 42% have hypertension. CKD is again prevalent in nearly 10% of the population. Now, how to assess with regards to investigation? Well, the class 1 recommendations are to assess for microalbuminuria, for renal dysfunction, as well as cardiovascular disease, as well as doing a routine ECG, especially in patients with hypertension. One can do clinical assessment of ABI, which can be a risk modifier. We can do a calcium, coronary artery calcium score, which can be a risk modifier. Further imaging like coronary angiography or myocardial perfusion may be considered where there are some indications in asymptomatic patients. But doing a carotid ultrasound may not be, is not recommended. Neither the biomarkers need to be assessed routinely. So in just doing a simple ACR, doing an ECG may be sufficient. If we, and as well as ABI can be an indicator. In patients, some patients, we may go for coronary artery calcium scores. So this is again a 55-year-old hypertension dyslipidemia with fatty liver, and you can see the SGPT, SGOT raised. The ACR is 90, the GFR is 60, and LVH is there. So about 50% of diabetes patients have LV dysfunction, especially the diastolic dysfunction, which we see so commonly, and that can lead to heart failure with preserved ejection fraction. The advanced study showed that both GFR and ACR actually increases CVD as well as the kidney events as well. And at all stages, presence of albuminurias, which is severely increased. Now it is severely increased and moderately increased. Change in terminology from micro and macroalbuminuria. And you can see very high risk can be seen in about 10% of the population. Even high risk is seen about 14% of the population. So apart from lifestyle management and managing lipids, glycemic control, and blood pressure and weight, we need to use organ protecting agents like SGLT2, GLP-1, RAS blockade, and non-steroidal mRNAs to improve the long-term cardiorenal outcomes as well. And a combination increases efficacy, durability, targeting multiple pathophysiological defects, and also ease of use. So with regards to SGLT2, there is decrease in insulin resistance by decreasing adiposity. There is good evidence in terms of especially EMPOWER with regards to MACE, CV death in ASCVD, improve heart failure and kidney outcomes. Whereas DPP4 inhibitors improve beta cell function. They are the easiest molecule to be used, having minimal hypoglycemia risk and demonstrated cardiovascular kidney safety, especially with linagliptin, and broad clinical applicability. So by targeting this combination of this SGLT2 and DPP4, like with Empalina and with the metformin, you can target most of the pathophysiological defects, and one can have a sustained improvement within 3 months, and that can be sustained significantly over a period of year or two. So now we have the time in range matrix where we require at least 70% of the time in range. And within 1 day, you can see with 10 milligram of empagliflozin, and especially with 25, you achieve that time in range, and especially within 1 month, actually with both doses, you have about nearly 80% time in range. So significant improvement in glycemic variability and time in range with use of this. And especially linagliptin has also been shown to decrease glycemic excursion because they have more effect, the DP4 inhibitors, on the postprandial excursions as well. So you can see empagliflozin can also improve the beta cell function by improving C-peptide and the beta cell function and decreasing the fasting glucose level. If we see the difference in weight compared to a glimepiride, which is a sulfonylurea combination with metformin, you see the difference is about 5 kgs because of 3 kgs weight loss, which is associated with the flozin, especially empagliflozin. The ELIF trial showed a significant reduction in liver fat with empagliflozin in type 2 diabetes patients with on empagliflozin, and about 20% achieved normal liver fat with use of this molecule with empagliflozin. Again, there is a decrease in HOMA-IR. There is an improvement in fasting insulin level, decrease in fasting insulin level, and also there is reduction in small dense LDL and improvement in HDL. So the EMPA-REG trial showed overall a 38% reduction in CV death, but in Asian population, that was about 56%, a huge, a much larger proportion of reduction. And out of this, there was nearly 21% reduction in myocardial infarction and coronary revascularization, a big impact as well. And there was also significant improvement in worsening of nephropathy, progression to microalbuminuria, as well as doubling of creatinine. All were reduced to the tune of 40 to 45%, and initiation of renal replacement therapy. So the kidney disease progression in patients with diabetes and CKD, and especially also kidney failure, was reduced by about average by about 40%, which was seen in the EMPA kidney study. And very important, in the EMPA kidney study, there was about a significant proportion of patients did not have albuminuria present. So that is something which is unique compared to the other SGLT2 inhibitor kidney trials. Again, the chance of rapid decline of GFR by more than 3 ml per year was also significantly reduced, apart from improvement in urine ACR. So regression of albuminuria was there, especially macroalbuminuria was there to the tune of 82% higher likelihood, and also improvement in prior microalbuminuria. So there is improvement in erythropoietin, increase in erythropoiesis, and decrease in hepcidin, and that can lead to increased iron bioavailability and increased energy production, and leading to better hemoglobin levels. There's improvement in uric acid levels as well. So we are all aware of the EMPA-REG trial showing, apart from 14% reduction in MACE, a 38% reduction in CV death and 32% reduction in all-cause mortality. Hospitalization and heart failure and CKD are almost seen in almost all the molecules with regards to SGLT2 inhibitors. And you can see with regards to GLP-1, especially the flozins definitely score in terms of CV death or hospitalization for heart failure, for end-stage renal disease, as well as CV death. So these are the main outcomes where they score, especially CKD, hospitalization for heart failure, and CV death. With regards to MI and stroke, they were equivalent with regards to GLP-1. So all-cause mortality, CV death, end-stage renal disease, and hospitalization for heart failure was reduced compared to GLP-1. Again, with regards to linagliptin, they have shown significant safety, especially for heart failure, which we had a scare in the saxagliptin, savertimi, as well as in the examine with allogliptin. And you can see the 3-point MACE and hospitalization for heart failure, where in the center, so showing no additional risk in the Carmelina study. And again, with regards to the only data with CKD, and which included a significant population with CKD, was with the Carmelina study, showing absolutely the hard endpoints were not changed. The albuminuria proportion was actually decreased. And you can see with use of glucose lowering agents in type 2 diabetes, there was a significant, the recommendations, you can see the 2025 recommendations in ASCVD patients, in heart failure and CKD, as well as for weight management. This is an important molecule. And we have seen demonstrated effects, especially with EMPA in MACE, heart failure, and DKD progression. And you can see safety with regards to the DPP4 inhibitors. And the ease of use with regards to a combination of EMPA and LINA, whether it is 10/5, where we can actually intensify with 25/5, which can have complementary pharmacotherapeutic benefit with a single pill, and that would improve compliance. And we can use it, especially when the GFR is above 30. But we need to be aware of the limitations, especially we shouldn't be using this in type 1 diabetes patients, in history of pancreatitis, especially when the LINA is there, and also probably when the GFR is low. But again, we can continue up to the period of dialysis as well, and need to be also aware of anaphylaxis, angioedema. But by targeting these pathways, we can have a significant improvement in glycemic control. We can have which can be safe in terms of weight, which can be safe in terms of hypoglycemia risk. Additionally, we can provide benefit in terms of cardiorenal perspective, heart failure perspective, as well as NASH, MAFL perspective, with reduction in liver fat as well. And so early use of this combination in our population with a higher cardiovascular risk is something which is desirable. Thank you very much. Thank you for a patient hearing.
Thank you, Debmalai. Very nice talk, very specific and very clear. And the message is clear that EMPA-LINA combination, both in 10 and 25 milligram EMPA, is really, and I have used it a large number of patients. And one thing is very important, that it gives a sense of well-being to the patient. First thing. Second thing, no hypoglycemia, almost. Third thing, there is no balanoposthitis with this combination. Possibly addition of LINA protects it from the glucagon effect and other things, and there is no balanoposthitis. So this is a original molecule, and this will remain, and this is a good molecule for clinical use. Your opinion, please.
Yes, sir. And again, especially with your valid point that, the infection rates, the genitourinary infections are decreased because of, one, the glycemic control is better, and also because of the inhibition of the enzymes which are there in the bacteria and in the fungi by this combination, especially DP4 combination as well. And so most people can, and also by lowering the glucagon level by the DP4, there is additional lowering of risk of diabetic ketoacidosis. So euglycemic decay risk is also significantly lowered. So the addition of this combination is something which is easy, and the data is maximum because this combination has established data, whether it is in terms of long-term follow-up or in terms of glycemic control.
Dr. Kishore, are you there? Dr. Kishore Behra from AIMS. Professor Das.
I think it has been a very, very gratifying talk, Dev. You have very clearly elucidated the entire spectrum of EMPA benefits. You might have seen or might not have seen in JAPI, me and Mangesh Tewaskar wrote about the euthymia with empagliflozin.
Yes.
And it was centered around the points you made about the urea, about the endothelial dysfunction, about the weight gain, about the ROS. And we had a circle, that picture, remember now, where we highlighted all the points that EMPA has provided. And the combination of the best of the SGLT2 with the best of the gliptin has to be one of the very best. And the Glyxambi has stood out. The Lina is Reno-Chef, Lina is effective, Lina is smooth, and Lina has conquered the world as far as kidney urinary tract is concerned. So I'm not surprised that as Alok said, the infections are much less and the control is very smooth. That's why this combination has stood out in the forefront, and the cardio, hepato, renal benefits are very pronounced. Even you also refer to that NAFLD and the NASH. So the both the benefits of the hepato-renal and the hepato-renal and nephro benefits, renal benefits are pronounced. At the same time, there's a great glycemic efficacy. Great glycemic efficacy. So it is win-win from all points of view. Thank you, Debmale Sanal, for a great, as usual, Dada, your talks are superb, and you have given another superb talk here. Thank you. Kishore was here. Hello, Kishore was here. I don't know where did he go. Kishore, are you there? If not there, then I will request
Please,
Alok to
please,
invite.
please introduce hydrolazine and apresal oral tablets and injections, and please invite Sumantoko Bakchi.
Dear friends, we have Dr. Bakchi, Sumantoko Bakchi, and he's going to talk to us about a product which was very close, and we have used this drug Klein. And this is a drug called hydralazine, a vasodilator, and it has worked orally, it has worked as an injection, and we have somebody who is an authority on this particular molecule. He's going to speak to us about this molecule and its pleiotropic benefits. Over to Sumantoko Bakchi.
Thank you so much, Dr. Das, for having me. I hope I'm audible.
Yeah, yes, very much.
Thank you. I would also like to thank Dr. Kanungo for giving us this opportunity, and Dr. Pandav for also inviting me to this very august session. I have been part of this session right from morning, from the time you invoke the
Really?
blessings.
Good.
Yes, on and
Kishore
off,
is
I
there.
have been.
And Dr. Das, Kishore is there, but he is not able to see himself. Next panel he will conduct. Yes, sorry, Dr. Bakchi.
No problem at all. So as I was saying, I was listening to the talks on and off, and I just came back from attending the All India AICOG 25 that is being held in Mumbai right now. I'll just share my presentation. Just give me a moment, please. Is my presentation visible to all of you?
Yes.
Right.
Clearly visible.
Thank you so much. So without much ado, I really
So sorry to interrupt. Can you do it
would
on
like to thank
slideshow
our
mode,
previous
please?
speaker, also Dr. Sanyal. Sorry?
Can you do your presentation on slideshow mode?
Sure.
Put it in the slideshow mode, please. Yeah,
That's good.
now, yes. Yeah, of course, yes. Fully
Thank
slideshow mode now.
Right. I think we are talking about, when we talk today about hypertension in India, we are talking about, if I talk in absolute numbers, a little bit of epidemiology before I progress. There's almost a 30% prevalence in India, and the total number of people suffering from hypertension is 22 crores. Now, when I look at these three parts, which we call the ATC, awareness, treatment, and control, when you look, there has been used to be a very big gap between the rural and urban, which is what is now coming down. What is scary today is the last, which is the control of blood pressure. So when you look at the rural segment, we're talking of actual control of blood pressure is only 10%. In urban, it's a shade better, although it looks double, it's 20%. But that's very negligible when you compare that the total number of people suffering from hypertension is 22 crores in India. And as a result of since we have a huge number of people living in the rural area, only 12% of people have their BP under control. Now, why am I talking to all of you on this? Because the next step is uncontrolled BP leads to a lot of health issues. And actually, there's a initiative where we would the government of India would like to reduce the prevalence of hypertension in India by 25%, which by this 2025, but I think the goal is rather ambitious at this point of time. As I said, when I have an all India figure of 12% where the blood pressure is just controlled, this results over a period of time from in an individual going into the next state of resistant hypertension. And there's a JAPI study which way back almost a decade ago said that the prevalence of resistant hypertension in India is 20%, which means 1 in every 5 individuals who suffer from hypertension in India is probably suffering from resistant hypertension. And if I have to talk in absolute numbers, then this number is more than 5 crores of people who are suffering from resistant hypertension. When I put the picture of CKD, the picture becomes more bleak. And I've been hearing a lot of talk by nephrologists, by a lot of clinicians from morning. And when I look at the burden of resistant hypertension in this group of patients, it's almost half. So that's a very, very big health issue in India. You have hypertension, you have diabetes, both resulting in CKD, and further almost 50% of these patients suffering from hypertension. And when I look at the prevalence of CKD in India, is as high as 800 per million population in India. And a lot of people who are suffering from CKD in India are probably not having access. And even if they have access to dialysis centers, they probably don't have the resources in India. If you look at India as a whole of 140 crore individuals, today the number of nephrologists in India probably is anywhere between 2.5 to 3,000. And as a result of which, the number of people progressing from CKD to ESRD is also very high in India. When I look at the goals of antihypertensive treatment, I'm not going to get into the details of this. These are all known to because you are all eminent clinicians. So I'm going to skip. But the major goal is to prevent or ameliorate injury to the key target organs, end organs, like the heart, the kidney, and the brain. And we know over a period of time, as a result of non-compliance, perhaps, or whatever could be the reason, a lot of uncontrolled patients are progressing to resistant hypertension. And in this scenario, I would really, from morning, I have been hearing a lot about a lot of newer and newer therapeutic approaches, which have played a very big role in the management of patients suffering from various kind of hypertensive disorders or diabetes or renal problems because of the two underlying diseases. Here, I would like to take your attention today to a drug which was first developed as an antihypertensive, as an oral antihypertensive in the 1950s. So it's a pretty old drug which has been there for the almost last 7 decades. The injectable version of hydralazine was introduced in the 1970s. So it has also been around for almost more than 5 decades. It shows a very significant antihypertensive effect, and it belongs to the class of drugs which are called as directly acting vasodilators. Now, there are two molecules when I look at hydralazine. One is the hydralazine hydrochloride, which is the injectable form, and the oral form is the dihydrolazine tablets that are available. And when I look at the pharmacodynamics, it acts very directly. But besides the direct vasodilatory action, it also, Dr. Das also said that it has pleiotropic effects. And there are some recent studies which have shown beneficial effects of these drugs, especially at the renal level. When I look at the pharmacokinetics, is there any difference between dihydrolazine and hydrolazine when you give it orally? No, there is not too much of a difference between the pharmacokinetics, though there are some studies which are in vitro dissolution study, which basically shows that the Cmax of the dihydrolazine is a bit delayed as compared to the oral hydrolazine, but it doesn't cause much difference in the onset of action. But what it definitely probably helps is we know that when you give oral hydrolazine, there are chances of reflex tachycardia, and probably the administration of oral dihydrolazine because of a delayed Cmax causes this effect to be reduced. But this is a in vitro dissolution effect which needs to be seen whether it is happening in patients also. Now, when dihydrolazine was actually launched in the 1950s, it was a drug that was essentially used for the management of essential hypertension. However, with the advent of other classes of drugs like the beta blockers, the calcium channel blockers, and then came the ACE inhibitors and the ARBs, and now the ARNIs, of course, it has been relegated to be used in very severe kind of patients. It is therefore used a lot in patients with CKD. And what I find very interesting when I go into a little more depth, in these patients who suffer long in the journey of hypertension and probably have developed resistant hypertension or have even started developing what is the adverse the end organ damage like CKD, we see a lot of vascular ossification happening. And probably in these patients with vascular ossification, you have a very high peripheral resistance that comes into play. And probably in these kind of patients, therefore, Aprazole oral tablets plays a very important role. And hence, I think a lot of physicians and nephrologists use this drug as one of the drugs for the management of resistant and difficult to control hypertension. The one is the proof of pudding about its efficacy. The other thing is always, you think about the safety of a drug because that's the fine balance that one has to do. And what could be more evident about its safety, that this is only one of the 2 or 3 drugs that can be used very safely in the management of pregnancy-induced hypertension that is seen in almost 10 to 15% of of ladies who are pregnant in India. So that's a very big plus point about hydrolazine as a oral tablet. As with any other drug, hydrolazine tablets are not to be used in certain group of patients who are either allergic to hydrolazine or dihydrolazine. In certain group of patients, you may see SLE, and therefore in these kind of patients, it's not an absolute contraindication, but you may need to reduce the dose. And I know in a lot of patients where the primary drugs may not be useful or there are certain contraindications like hyperkalemia and where one has to use hydrolazine. Nephrologists in this real world have used hydrolazine up to a dose of almost 200 milligrams per day. So this is a very, very effective drug, although a very old drug, but it still has a lot of use. So this is the algorithm, proposed by the American Heart Association for the for the management of resistant hypertension, when the target high blood pressure is not coming down to the target levels, even after adding drugs like diuretics or an MRA or a beta blocker, then one recommends that a drug like hydralazine comes into the picture. There are other options also. Hydralazine is one of them. I'm not going to skip this and come to the other effect, the positive effects that hydralazine plays also in the prevention of progression of a patient of CKD with ESRD. So these are the beneficial effects that Dr. Das was referring to, that hydralazine provides. It provides renal protection in kidney disease. It has an antioxidation benefit. It also has an anti-inflammatory effect, and it prevents DNA methylation. Quickly, I'll move from the oral to the injectable form because we have recently launched this molecule in the injectable form. And hypertensive crisis in India is also not small. Again, there are about 1 to 2% of patients who suffer from hypertensive crisis in India. Again, when you look at the total number, it's almost 22 to 44 lakhs. We know hypertensive crisis can be classified based whether there is an end organ damage into hypertensive emergencies or urgencies. When I look at the number of people who are getting admitted into the ICU in India, this is an Indian study, almost 18%, almost close to 1 in every 5 Indian who gets admitted into an ICU is because of hypertensive emergencies. When I look at the hypertensive emergency, the most common clinical presentations are cerebral infarction, pulmonary edema, hypertensive encephalopathies, CHF, and eclampsia. This is extremely important. There are other clinical presentations, which is around another 20%, but roughly the 75-80% are because of the top 5. Now, when you look at the hypertensive emergencies, what were the options that were there in front of you for the management of the patients? Were drugs like sodium nitroprusside, nitroglycerine, and labetalol, because you would give the patient the drug in a parenteral form. But I believe with the addition of hydralazine in an injectable form, you also have another option. And I would like to delve a little into what could be like nitroprusside. And this is from the pack insert of sodium nitroprusside, where there is a black box warning which says that sodium nitroprusside can sometimes cause precipitous decrease in blood pressure and can even cause cyanide toxicities. Moreover, this is a drug which is not suitable for direct injection and needs to be used very, very carefully. Again, it cannot be used in a certain way and has to be given only as a continuous infusion. And I know that all these sodium nitroprusside needs the entire system to be covered with an opaque sleeve. That itself can cause some kind of anxiety in a patient and cause the blood pressure to rise. When you look at nitroglycerine as a drug, again, a very important drug, which is used for the management of hypertensive emergencies and has been used a lot. But again, there are certain limitations where you cannot use it as an intramuscular bolus or a diluted slow IV. It needs to be administered only via a pump that can maintain a constant infusion rate. The good part, of course, is when you stop the infusion of nitroglycerine, the blood pressure, the fall in blood pressure is therefore very nicely calibrated. The problem with nitroglycerine is you cannot give it beyond 24 to 48 hours because there is some amount of tolerance that develops with this drug. Labetalol is another drug which can be given IV, but then we all know that this is a non-selective beta blocker. Okay, and this non-selective beta blocker cannot be given in certain patients, such as those with bronchial asthma, and those with heart failure, with bradycardia. So these are some adverse events, adverse reactions of labetalol, where you would not like to use it as a primary drug. And therefore, when I look at hydralazine as a solution for parenteral administration in hypertensive emergencies, you can provide this drug in patients with CHF and pulmonary edema. This is hypertensive crisis associated, not for the management of CHF or pulmonary edema. This is a drug which is the gold standard for the management of severe hypertension that is associated with preeclampsia and eclampsia. And it is also a drug that can be used for the management of intradialytic hypertension, which is as high as 15% in India. So this is a very important drug that can be used for the management of intradialytic hypertension. I will not go into the pathophysiology here at this point of time, but I would like to bring to your notice this journal, the Canadian Journal of Kidney Health and Disease, where it says choose a drug which are less dialysable. And in one of these drugs, you can see that they are talking about a drug like hydralazine that has rapid onset and offset and may be used to prevent intradialytic hypertension. So this is a very important drug that can be used also for the management of intradialytic. There are several studies that talk about the benefits of hydralazine in the management of severe preeclampsia. So I'm not going to get into the details because it is the ASCOG which talks about it. There's a Royal College of Obstetricians which talk about it. This is the Japanese College of Obs and Gynacs also mention hydralazine, both oral and injectable, for the management of severe hypertension. So when I look at the management of hypertensive emergencies with hydralazine, you need to give it only and only in patients who are in hospital and are being supervised. This is not meant to be given in patients in an OPD basis. So I would like to urge and put that word of caution. What is very important is the versatility of hydralazine as an injection. So not only can it be given as an intravenous, and within intravenous, you can give it the IV bolus, you can give it as a slow diluted IV injection, you can give it as an IV infusion, but you can also administer this drug as an intramuscular, especially in those patients where it is very difficult to find the vein at times, or the patient has collapsed and you're not able to find the vein immediately. So this comes in very handy. And I'll just spend just a couple of minutes when we talk about how you give it. When you give it as an intramuscular, you can go up to 10 to 15 milligrams intramuscular every 4 to 6 hours. 2 words of caution. The first is switch to oral hydralazine or any oral antihypertensive within 24 to 48 hours. My biggest thing here is please do not bring down the blood pressure beyond a certain level, because you do not want to induce any kind of hypoperfusion injuries in patients. So that's very important, whether you give it intramuscular or you give the intravenous IV bolus route. Please give it slowly and measure and calibrate the fall in BP in a stepwise manner, and not bring down the blood pressure drastically. Among the intravenous route, perhaps this is the most interesting way of giving it, where we dilute 1 ml, which is 20 milligrams, in 9 ml of normal saline, and we inject 2.5 ml, which is 5 milligrams, every 15 to 20 minutes. We check the BP and bring down the blood pressure in a calibrated manner. So this is one method, I think, that can be used effectively and safely without compromising on the vasculature of any organ. The infusion, if one needs to use it, can be given over 6 to 8 hours, where you dilute 5 ampoules, that is 100 milligrams, in 500 ml of normal saline, and allow it to be administered at the rate of 200 to 300 micrograms per minute over, and this single 500 ml infusion can last almost 6 to 8 hours. So you can start off with the bolus if need be. You can progress onto the slow IV diluted, and then maybe over the next 8 to 24 hours, keep a IV infusion till the blood pressure settles down, and then switch from a parenteral route of administration to a oral route of administration. These are the absolute contraindications of hydrolysine injections. So while you have a lot of benefits, we would like to use this drug in a very cautious manner. We would not like to give it in patients who already have some kind of myocardial insufficiencies, have some kind of SLE, or are suffering for isolated right ventricular failure due to pulmonary hypertension, or having dissecting aneurysm, because you don't want a reflex tachycardia to cause more damage in these patients. So I always would urge that please keep the safety of the patient first in mind. These are the warnings, and these are not the absolute contraindication again. One word, when one uses this drug, the preferred drug for dilution is normal saline or ringer lactate and not dextrose, though as dextrose seems to be reducing the efficacy. It does not negate its effect, but it reduces its effects. So we do not recommend it to be diluted with dextrose infusion. So at the end, I would like to end by saying that in any patient where you would like to use this very effective but safe drug, the Latin thing comes into saying primum non nocere, which means first do no harm, as a principle for any patient. Thank you so much for providing this opportunity to me and Exeltis for giving this presentation to this august audience.
Thank you, Dr. Sumanta. I'll request Dr. Kishore Kumar Behera to join and take it forward. Kishore, have you joined? I have sent you a different link.
Yes,
Please
sir, I
join
got
by
it, sir.
that.
Kishore is there. Kishore.
Please discuss on the matter and
Sir, it's excellent talk, I think, and I have myself have, I mean, it's a excellent platform, and sir, you have invited very excellent speakers, and I enjoyed a lot, and I learned a lot rather than asking something. But I have few queries about like how you place this hydral gene, like somebody is having type 2 diabetes, first line of drugs, suppose you have used SC inhibitors or ARBs with amlodipine, and still the blood sugar is not under good control. So whether we'll choose for alpha blockade or we'll go straight away with hydral gene. So that is one thing. And what are the specific conditions when we are using the hydral gene? Is it has got some effect in the prevention of the cardiorenal, like prevention of the albuminuria, all that, or it only takes care of only the control of blood pressure?
Thank you, Dr. Behra. I think that's a very, very interesting. Am I audible?
Yes, sir.
Yes.
Right. I think that's a very, very interesting question. In fact, at the last ISN Con in Kolkata that was held, there was a lot of talk on the benefits of hydrolysine in cardiorenal syndrome, which by itself can, we know a lot of these patients also suffer from other comorbidities. And we, although this drug was first discovered and first established as a primary drug, but as you that there have been a lot of other classes of drug which definitely provide a lot of benefit. But we have seen that in a certain group of patients where you cannot use an ACE inhibitor or a ARB or ARNIs where these drugs are contraindicated. You are seeing a lot of hyperkalemia. This drug is an electrolyte neutral drug, and it has a direct effect on the peripheral vasculature, and it brings down. And therefore, we definitely would like that this drug provides benefit to a lot of patients. But obviously, this drug cannot be given all by itself. It needs to be combined with maybe a beta blocker or diuretic and even probably an MRA. These drugs comes into a picture. But I think this drug plays a very important role in a certain subtype of patients where the blood pressure refuses to come down. I was mentioning probably before you joined that when you look at the vasculature of these patients who have progressed over a period of time, there is something called vascular ossification. The calcium deposition that happens within the endothelium creates a vasculature where the endothelium is not anymore responding. The smooth muscles are not relaxing. And as a result of that, you have a scene where you have very high peripheral vascular resistance. So in this kind of scenario, I think hydrolysine would play a very, very important role. I hope that answers.
Yes, sir. Thank you. Thank you, sir. Sir, I have one more, just curiously, I'm just asking. Suppose we are dealing with pheochromocytoma, and we know that the first line of choice is alpha blockade. Then if it is not controlled, then we will go for a calcium channel blockade. So what your take on whether we can use these drugs for the control of, I mean, suppose you are not able to control the blood pressure, and do you choose these drugs as a add-on for a certain condition like pheochromocytoma?
So, yeah, that's a very interesting question. When you look at the real world, actually, today, uh, drugs like clonidine and alpha blockers are still very, very widely used as drugs which are actually patients are put on these drugs even before they are put on hydrolysine. So I'm sure the benefits that must be accruing to the patient because of this drug probably outweigh the benefits. But I'm sure when I look at hydrolysine, what is most interesting is it doesn't have any kind of a central action. It does not have it actually does not touch the electrolyte. And we know electrolyte imbalance in these kind of patients can be a very, very harmful thing. I think that is the most important benefit that hydrolysine as a molecule, gives to these patients.
Thank you, sir. Thank you, sir. Thank you, sir, for wonderful answering this question. So this is from all from my side, sir.
Professor Das,
yeah,
please
I
conclude.
will like to compliment Sumantokada for a very effective talk. Your communication was superb, contents were marvelous, and the way you presented it, you had your own style. I'm listening for the first time, but I am told that you are one of the best speakers of the country. Second thing, I would like to ask you a very important question. Sumantakada, I remember this drug was available as Neprisol. Remember Neprisol?
Absolutely.
And available, yeah, Neprisol available as 10 milligram and 25 milligram.
Right, sir.
I've used this drug plenty.
Right.
Plenty in the that time we didn't have access to CKD with the anuria or total anuria. Anuria is up to 100 ml, total anuria, not a single drop of urine. With the anuria, we used this drug and had very good results. We have also used this drug as antihypertensive that time. And why this drug you did not pursue for a long time? Because, I remember, I think Shamantakada, I must tell you from the core of my heart, is Debmalya is there? Debmalya there? Are you there? They're just saying, are you there, Debmalya? They're just saying by, not there, by Salim Yusuf. You know Salim Yusuf, the father of the all the drug trials in the country, and Salim Yusuf, very famous man. He once said that whatever drug you bring in, if you do not have activities around the molecule, it do not see light of the day. He was referring to me, he's my classmate. he was referring to me saying that that is because in the micro hope and hope, two studies, hope and micro hope, they had around the enalapril, and then the drug is gone. So what exactly happened, Sumantavada? I mean, this may be something you can tell me afterwards. Now, coming back to the Neprishol, I should say that I have used it both as in the kidneys in a very high dose to produce urine, where I have been successful. I have also used it as a vasodilator for treating hypertension, where also I have been quite successful. And this drug is, as you rightly said, is not used alone. You may have to give something else to produce the desired result. The beauty of this drug is almost lack of any side effect, and
Right.
that's the beauty of this drug, and can be prescribed. They call it prescribe and forget, because this is not going to any side effect.
Right. Right.
That's
You're
drug.
right, sir.
And I'm extremely happy they have brought it back with a different name called Aprishol. And I think that with this drug will be quite successful. I would just like to last at the end that is there any recent Indian trial, Indian studies, or at least real world evidence that I think that you have to generate, Sumanta Goda, to again gain back the confidence of the prescribers.
Right, sir. I think you have touched the absolute right point. We are actually undertaking a real world evidence right now. In fact, we have just finished one real world evidence study of this drug in pregnancy induced hypertension, and this was presented today at the EICOG. And we have also initiated an ethics committee approved study in one of the largest medical colleges in India. So you are absolutely right that we will be generating data, Indian data very recently. Yes, sir.
Thank you.
It is very interesting that usually people do not speak about the negativity of a product. They never highlight that. But
Absolutely.
you have very clearly highlighted where it should not be given, what are the side effects, what are the precautions, and that will make the clinicians, doctors in the ICU very careful. And thank you very much for this nice presentation. Professor Ashok Das to conclude today's session.
Dear friends, it has been a great day, and I must congratulate that we had so many sessions and so many programs and so many very eloquent speakers. I to you that this we started with the obesity, which was by Dr. Anup Mishra, Dr. Krishna Sasadri, and by Dr. Sandeep Mathur. Kishore, all the people came here. They were in CMC yesterday. Today they were all here, and then we had people who joined us from for the complication of diabetes. It was a very wonderful session that went very well, and then we had session on the oral hypoglycemic drugs, two sessions back to back. And the beauty of this program, Sumantakada, I must like to tell you that it's a detailed interactive session, because we have first a talk, then we have an interview, the vision of Dr. Alok Anungo's son, that this gives and that we do not restrict. So this is about 15 minutes. We can go up to 20 minutes, not beyond 20 minutes. So it clarifies all the things about the particular thing. And following that, we have a panel discussion, which will give 45 minutes time. So all the topics, all the things were discussed. In fact, I was delighted to learn about there were dapagliflozin, metformin, and I have used this drug while I was in States for a short time. It's called Judigo XR. Now it has been available in India. There are simple things which can produce great results and change the destiny of diabetic patients. So Alok, that's what the beauty of this meeting, and purely clinical and purely practical, giving tidbits of the practice. So I'm very happy that this was there. And dear friends, I must tell you that today we had about 2,000 plus people who joined us, in spite of Sumantagada, 3 conferences going simultaneously.
I know.
ICM Vellore, which is, I think Kishore is there. The second is Hormone India meeting, because I was invited to all the meetings. So there's a Hormone India meeting in Bhopal. Am I correct, Kishore? Hormone India is going on also in Bhopal. In spite of that, having 2,000 plus delegates tucked in, and we have not missed a single speaker. You came back from Dubai, attended it, and all the speakers attended the program, and they have made very seminal contribution. So I must tell you, and it is very important that that we should bring out a proceedings of the meeting, because that will give the greater access to the what we are doing, and also will produce a lasting compendium of all that has been discussed here. So to finish, I must say that it is
Tomorrow at 10:30 we will start.
yeah, before I
And a
close,
very important session, insulins and GLP-1 receptor agonist, and it is a novo session, but it is a wonderful session, and I will request all delegates to join by 10:25 tomorrow.
yeah, I must tell you that tomorrow's session is centered around GLP and the newer insulins, about the newer molecules, and there are a lot of things tomorrow. We have also Alok, we have also have a session on the what is it called, nutrition and exercise. That is a great thing people don't discuss. We have a full session on the
Diabetic food
and we have a diabetic foot, which is by from
and
your
neuropathy.
we have got the best of the speakers. We have Ghanshyam Goyal, we have got Manoranjan Behra, we have got our own professor from SCB, we have got Ashur Astogi, and it's a great session. We have tried to get whatever. We have a session, the third one on the diabetes complications. We have a session on the basal insulin and a session on diabetic neuropathy also. And we have of course, insulin and GLP-1 array. So I think tomorrow's program will be quite befitting. And before I end, I must tell you that the things we discussed in the last session, the diabetes, cardio, reno, hepato circle, the 360-degree way of treating diabetes. And also we discussed about the future of oral anti-diabetic drugs. And of course, I cannot forget before I close the session on diabetes in the young. I think that session was superb. I think Dr. Alok is very humble. That session was led by him. We had Dr. Ram Naik, who is from the United States Authority on the Autoimmunity in Type 1 Diabetes. He also joined. And we had the great discussion with Bansi, who is an authority on the Type 1 diabetes care. Professor Ram Naik from States. We had Alok himself. And there's a good discussion on that particular topic. So I have no audacity to, but I think I have told most of the things that happened today. Alok, am I correct? Most of it happened today, and the highlights. And let us pray that tomorrow's session is better than today. And Dr. Alok, I must tell you that you have done a great service, which is cannot be described in the words. Tomorrow we'll discuss that. And
Professor Jargar gave a very wonderful talk.
Padma Bhushan Vinod Karan Goration. It was a diabetes in women and fantastic talk. It was based on his original work. And in 15 minutes, he presented 7 papers of his on diabetes in women. He's a close friend of mine from Sere Kashmir Institute on Kashmir. So people from Kashmir to Kanyakumari, we had people from the Madurai, we had people from Trichy, people from Bombay, people from Calcutta. So I think it has been absolutely pan-India, absolutely fabulous. Thank you very much.
Thank you.
As you said, we'll join tomorrow by 10:25 positively. So
Recording stopped.
Thank you, Stuti. You can't stop like this, Stuti. I should thank you profusely and RX Events. And with God's grace, nothing has gone wrong. And tomorrow, same thing will happen. Stuti, are you there, Stuti?
Yes, sir, I'm here.
Yeah, tomorrow, same thing should happen. And Kishore, thank you very much for joining.
Thank you, sir. Thank you, sir. It's
Kishore,
excellent. I
just
mean,
imagine
I learned a lot, sir.
Head of the endocrinology, metabolism, diabetes at AIMS. But you must be very aggressive, Kishore. I told you last time, Kishore.
Sir.
So I'm extremely happy to meet you. And he's one of my students and excelled. And he wants to do much more projects in Bhubaneswar. Thank you, Kishore, for joining. We'll help you whatever we can. Thank you very much.
Thank you, sir. Thank you.
Thank you, Kishore.
Thank you, Jayashree, for everything.
Yeah, I should thank all the chairperson. Joyce is there? I'm not seeing her.
No,
Joyce is there?
No, sir.
I think she must, but she get a very great contribution. I thank all the chairpersons. I thank all the people joined the inauguration. My teacher, Professor K.C. Samal, my teacher, Niranjan Tripathi, Vijay Mishra. I don't know, we couldn't listen in. Bidi Sahu came and Vijay Mishra sir came and all the seniors came. Great meeting and no, it has been a good beginning today. I hope, but nothing in hoping. I must pray for a well continuation tomorrow. Thank you.
Thank you, sir.
Thank you.
Pranam.
Thank you. Pranam, pranam, pranam.